Shall we start now? Let's start. So the next topic is going to be vascular surgery, that is your arterial and the venous disorders. Audio, is it fine? Yes, we will be completing surgery today, beta. Chalo. Hopefully the audio visuals are fine. Great, chalo. So let's start now. The next topic is going to be vascular surgery. Here there's a question which states, this was a previous year question, beta, that states we are having an elderly smoker patient complains of cramping pain in the limbs, beta. Okay, cramping pain in the limbs which worsens on writing. So the patient is having pain in the upper limbs, beta, and whenever the patient writes too much, that pain is going to worsen basically, or that pain becomes more severe. And now the patient comes to you with this below given finding. What is seen? Here you are able to see, beta, there is necrosis in the tip of fingers, or there is gangrene in the tip of fingers basically. So please tell me, what is the likely diagnosis in this case? What is the likely diagnosis in this case? An elderly smoker patient, cramping pain in limbs, which worsens on writing, that is a claudication, and this below given finding, that is gangrene in the tip of fingers. Very good. We know it is a case of gradual arterial obstruction. That is when the obstruction or the blockage in the arteries develops very slowly, beta, over a period of months or years together. Okay, there are two reasons for gradual arterial obstruction. One cause is atherosclerosis. Second cause is Buerger's disease, also known as Buerger's disease. Now, out of them, basically, my likely diagnosis has to be nothing else but atherosclerosis. You will be like, so why? Reason, beta, please remember, this was a PYQ itself, and in this I agree that usually small vessels are affected, so it will be more likely a case of Buerger's. Okay, but they have clearly mentioned the patient is elderly, beta. Do remember that elderly patient more than 50 years of age, beta, is commonly going to cause atherosclerosis, whereas Buerger's disease is more common in younger patients less than 40 to 45 years of age. That has to be remembered. Clear about? Second important to remember, beta, smoker, a lot of people feel smoking matlab Buerger's. No, that's analogy is wrong. That analogy is wrong, beta. Reason, smoking is a risk factor for both atherosclerosis as well as Buerger's disease, beta. Clear? So just only at only you're going to look at smoking and are going to answer Buerger's. That is going to be wrong. Most important factor is going to be age of the patient, beta. Samjhe baat? So both the causes of gradual arterial obstruction, more common cause is obviously atherosclerosis, beta. Do you remember atherosclerosis is more commonly seen in elderly patients more than 50 years of age? But Buerger's disease, also known as thromboangiitis obliterans, it is usually seen in younger patients less than 40 to 45 years of age, beta. That is what is important. Second, we know that atherosclerosis usually involves the larger vessels of the body, especially like the aorta. Whereas Buerger's disease, definitely, it involves the medium to small sized vessels of the body, beta. Okay, Buerger's involves the medium to small vessels of the body. Do you remember atherosclerosis, the blockage is going to be proximal to distal. That is, it starts from the larger arteries and goes towards the smaller ones. Okay, it is proximal to distal blockage. But Buerger's disease is completely opposite. It is distal to proximal. It starts from the smaller arteries and then comes towards the larger ones, beta. That is distal to proximal. Hopefully clear to all of you. These are the factors, but the single most important factor being age group of the patient, beta. Clear about yahan tak? These are the things that you need to remember. Risk factors are common. It could be smoking, it could be alcohol, it could be hypercholesterolemia or hyperlipidemia, it can be obesity. These are going to be the risk factors for both the conditions, beta. Now, whenever the patient is having a gradual arterial obstruction, obviously we know if the artery is going to be blocked, beta, the part distal to the blockage will not receive enough blood supply. Barabar, if there is a blockage in the artery, the part distal to the blockage does not receive enough blood supply. If the muscles are not receiving enough blood supply, the patient has cramping pain inside these muscles, beta. Okay, and this pain appears when? Only when the patient walks, basically, then the pain is going to appear, beta. As soon as the patient takes rest, the pain disappears. ठीक है? तो जब भी पेशेंट चलेगा तो उसकी वजह से दर्द होगा, बट जैसे ही पेशेंट आराम करेगा दर्द रुक जाएगा. Clear? So definitely this is classically known as nothing else but intermittent claudication beta. That has to be remembered. No issues with this. So do remember that the earliest feature in cases of gradual arterial obstruction is nothing else but intermittent claudication, which is a cramping pain on walking or cramping pain on writing that disappears at rest. Now the blockage increases further, and as the blockage increases, there is decreased blood supply to the nerves also. If there is decreased blood supply to the nerves will start dying beta, and these dying nerves will cause a constant pain. Okay, and this constant pain is even present at rest. Therefore, the second stage is going to be rest pain beta. The second stage is known as rest pain. Next, if the blockage increases further, now the patient starts having tingling, paresthesias, numbness, color changes in the skin, and ulceration beta. Wherever there will be paresthesias, numbness, ulceration, color changes, all of these features, and that is the stage of pre-gangrene beta. All these features together we call it as pre-gangrene. And lastly, when there is complete necrosis, as you are able to see over here, okay, if there is complete necrosis, it is going to be nothing else but gangrene beta. Okay, so initially the patient will have a cramping pain known as intermittent claudication, later on a constant pain called as rest pain, later on there will be color changes, ulceration, paresthesias, numbness known as pre-gangrene, and ultimately complete necrosis called as gangrene beta. समझे यहाँ तक? These are the stages beta which can be seen in both the cases of gradual arterial obstruction, whether it is atherosclerosis or it is Buerger's disease beta. Clear? Now, if a patient of gradual arterial obstruction comes to us, we can definitely check the patient's ABPI. Now, what is ABPI? It is ankle brachial pressure index. That is systolic BP at the ankle upon systolic BP at the arm beta. Okay? It is a ratio that we take of systolic BP at the ankle upon systolic BP at the arm basically. Okay, that is known as ABPI. Normally we know beta, due to gravity, there is slightly more blood flow towards the lower limbs or towards the ankle. Therefore, the BP in the lower limbs or in the ankle is slightly high. Okay, that's the reason. Normally, the patient's ABPI will be in the range of 0.9 to 1.3 beta. Okay, normally the ABPI is going to be in the range of 0.9 to 1.3. Important is, if the blockage starts, the blood flow to the lower limb is going to decrease, and as the blood flow to the lower limb decreases beta, obviously the systolic BP in the lower limb or systolic BP at the ankle will also decrease, and due to that the ankle brachial pressure index drops. Do remember, in intermittent claudication the patient's ABPI will be less than 0.9 beta. If the patient is in the stage of rest pain, then the patient's ABPI will be less than 0.5 basically. But after this, there is a stage called as critical limb ischemia. This was a previous year question. Okay, in the recent exam also it has been asked in ANA, and that was, instead of writing critical limb ischemia, they wrote imminent gangrene. Means after this stage beta, if you do not give attention to the patient will surely develop gangrene beta. That is this stage. Okay, critical limb ischemia or imminent gangrene is seen whenever the patient's ABPI is going to be less than equal to 0.3. You can say less than 0.4 or you can say less than equal to 0.3 beta. It is one and the same thing. समझे बात? So critical limb ischemia or imminent gangrene is seen beta whenever the patient's ankle brachial pressure index or ABPI is less than equal to 0.3. Hopefully clear. Now important is, if I ask you what is going to be the investigation of choice and the gold standard investigation. Do remember, investigation of choice should be cheaper, it should be easily available, it should be more practical, either non-invasive or minimally invasive beta. Okay, and it will give you diagnosis in 90% cases. But gold standard investigation or the best investigation is the one which may not be easily available, it may be expensive beta, it may not be very practical, it may be invasive also, but it gives you diagnosis in 100% cases. And one more thing, gold standard investigations do not only help in diagnosis, they also help in the treatment as well. Okay? So if I talk about vessels beta, do remember the basic logic. For all the peripheral vessels, investigation of choice is a duplex scan or a color Doppler beta. Reason, all the peripheral vessels, that is the upper limb and lower limb vessels, are superficial. Therefore, for all peripheral vessels, investigation of choice is a duplex scan or a color Doppler. Whereas for all the central vessels basically beta, central vessels matlab head, neck, thorax, abdomen. For all the central vessels, the investigation of choice is a CT angiography. Okay? For all the central vessels, the investigation of choice is a CT angiography beta. Clear? because these vessels are deeper and surrounded by multiple organs. Apart from that, gold standard investigation for both the vessels, irrespective whether they are peripheral vessels or central vessels. Gold standard investigation is same for both, that is angiography. When we only say angiography, we are talking about the catheter or the invasive angiography, where we have to inject a dye or we have to inject a contrast in the vessels. Beta, samjhe baat? That is important. So do remember, investigation of choice in cases of Buerger's disease as well as atherosclerosis has to be nothing else but the duplex scan. Beta, in case if duplex scan is not an option, mark it as color Doppler. Hopefully clear. Answer it as duplex scan. If duplex scan is not an option, mark it as Doppler. That is what is important. Whereas if I talk about basically what is the gold standard investigation, so as I've already told you, gold standard investigation for all vessels is nothing else but angiography. Beta, gold standard investigation for all vessels is angiography. Okay? Do remember, in Buerger's disease, when you do angiography, you are able to see a very classical appearance that is known as corkscrew collaterals. Beta, okay? So definitely we know whenever there is a blockage in a vessel, beta, the body starts forming collateral vessels, barabar, and these collateral vessels which are formed, beta, in patients of Buerger's disease, they give a very classical appearance known as corkscrew appearance. Beta, has to be remembered. Samjhe baat? Now please tell me in the chat box which is the most common vessel affected in cases of atherosclerosis. If I talk about a case of atherosclerosis, beta, in atherosclerosis, please let me know which is going to be the commonest vessel affected. Atherosclerosis mein the most common vessel that is affected overall. Anybody? The commonest vessel that is affected in atherosclerosis? Very good. It has to be an abdominal aorta. Beta, the most common vessel that is affected in atherosclerosis is nothing else but abdominal aorta. That has to be remembered. Okay, so abdominal aorta is the commonest vessel affected. Okay. Whereas followed by abdominal aorta, it will be the coronary artery. And if coronary artery is blocked due to atherosclerosis, you might have discussed in medicine, patient develops MI, that is myocardial infarction. Barabar. If they ask you which is the most common peripheral vessel affected, then your answer will be right. Beta, agar pucha jaye the most common peripheral vessel affected, then definitely my answer has to be nothing else but the popliteal artery. Beta, most common peripheral vessel affected, if they ask you, then my answer is somewhere the popliteal artery has to be remembered. Hopefully clear. Now if I talk about basically that which is the least common vessel affected with atherosclerosis, which is the least common vessel that is affected with atherosclerosis, answer is going to be, let me know in the chat box, the least common vessel that is affected with atherosclerosis. Shabash. The least common vessel affected with atherosclerosis is circle of Willis. Beta, so circle of Willis are the arteries which supply the brain. They are the least common vessels to be affected by atherosclerosis, followed by the second least common vessel affected is going to be the IMA, that is internal mammary artery. Beta, the second least vessel affected after circle of Willis is IMA or the internal mammary artery, known as Lima or Rima, that is the left or the right internal mammary artery. Hopefully clear to all of you now. So these are the points that you need to remember. Okay, these are the points that we have to keep in mind. Now if I talk about what is going to be the treatment, so if a patient has been brought to us with complaints of a gradual arterial obstruction like atherosclerosis or Buerger's disease, in both the conditions the risk factors are modifiable. Beta, that's the reason the first line treatment will always be lifestyle modifications. Lifestyle modifications mein you'll ask the patient for weight loss, to quit smoking and alcohol, to avoid any kind of junk food basically, right? These are going to be the advices in lifestyle modification in both these conditions. Okay, quitting smoking and alcohol is the most important advice. Let's say lifestyle modifications have been tried but the patient's condition does not improve. Agar patient की condition ठीक नहीं होती, in those conditions the next step is medical management. Beta, medical management में we have to give 3 types of drugs. One are going to be vasodilators. Beta, and the vasodilators that we give are usually drugs like cilostazol or pentoxifylline. Okay, we give vasodilators like cilostazol or pentoxifylline. Second, we can give antiplatelet drugs. Beta, something like the aspirin and clopidogrel. Beta, we have to give the antiplatelet drugs basically, that is aspirin or clopidogrel. And third, if the patient is having hypercholesterolemia, you have to give statins beta. For hypercholesterolemia, you give statin. Hopefully clear. So that is what is important to be remembered beta. Understood? Now let's say you have tried the medical management in these patients, but patient's condition does not improve. So if patient's condition does not improve, then what is the next step? Remember, if it is a case of atherosclerosis beta, if it is a case of atherosclerosis, then my next step is actually going to be the balloon or the stent angioplasty beta. You might have heard about it as PTA, percutaneous transluminal angioplasty. So you go for a balloon or a stent angioplasty. Either with the help of the balloon, you will try to break that blockage, or you will try to break that atherosclerotic plaque beta, or you are going to place a stent at the level of the blockage beta. Important is, nowadays we tend to use drug-eluted stent. Please tell me in the chat box, this was a previous year question in FMG, that the drug-eluted stent that we use are coated with which antiplatelet drug? The drug-eluted stent nowadays beta, they are usually coated with which antiplatelet drug? Let me know in the chat box. The drug-eluted stent are coated with which antiplatelet drug? Shabash. The drug-eluted stent which are there beta nowadays, they are usually coated with sirolimus. Okay? The drug-eluted stents are usually coated with sirolimus beta. That has to be remembered. Samjhe baat? Now, let's say if I have to do an angioplasty, doesn't matter whether a balloon or a stent angioplasty, do remember I'm going to use this catheter. Let me know the name of this catheter. This is a vascular catheter beta. You can see it has a balloon, and it is generally used for the procedure of an angioplasty. So whenever I have to do an angioplasty, I use this catheter, classically referred to as the Fogarty's vascular catheter beta. It is classically known as the Fogarty's catheter or the Fogarty's vascular catheter. Do remember, this is the catheter that is commonly used for the procedure of angioplasty beta. Has to be remembered. Clear about? Now if I talk about basically, okay, in case in a patient of atherosclerosis, if you have tried doing the angioplasty, but even after doing angioplasty, the patient's condition does not improve, that means angioplasty also fails, then the next step in cases of atherosclerosis has to be a bypass grafting beta. Okay, it has to be bypass grafting. Do remember that. Okay, bypass grafting mein what we do, either I use a autologous graft, that is a vessel from the patient's own body, or we use a synthetic graft which is artificially prepared. And what we do is, with the help of this graft, we connect the proximal and distal end of the vessel beta. As you connect proximal and distal end of the vessel, the blood now will flow via the bypass beta. The blood will now flow via this bypass graft, bypassing the blockage basically. Barabar hai baat? So definitely as the blood flows via the graft, bypassing the blockage, we call this procedure as bypass grafting. That is what is important to be remembered. Understood? So if I talk about basically the last resort in patients of atherosclerosis, it is usually bypass grafting that we try to do. Okay. Whereas if they say it is a case of Buerger's disease, see, in Buerger's disease, we try lifestyle modifications. Yes. We try medical management. Yes. But do remember, angioplasty and bypass grafting are not possible for Buerger's disease. So in Buerger's disease, as soon as the medical management fails, the next step is a lumbar sympathectomy beta. Lumbar sympathectomy is nothing else but removal of the sympathetic lumbar ganglia. Yes, we have to remove the sympathetic lumbar ganglia beta, due to which there will be vasodilatation. And as it will cause vasodilatation, it will increase the blood flow to the nerves. And as there will be more blood flow to the nerves beta, the nerves will not get damaged. Samjhe baat? So lumbar sympathectomy has to be done. Do remember point that lumbar sympathectomy which is there, it is usually done when the patient is in the stage of rest pain. Lumbar sympathectomy has to be done whenever the patient is in the stage of rest pain or the nerves are about to die. But it is absolutely contraindicated whenever the patient is in the stage of intermittent claudication. So in a case of claudication beta, the lumbar sympathectomy is absolutely contraindicated. Reason is beta, do remember, if you perform lumbar sympathectomy in the stage of intermittent claudication itself, the muscles will get died. Okay, the muscles are going to die basically. So never perform a lumbar sympathectomy during the stage of intermittent claudication. It is always advised in the stage of rest pain. Samjhe baat? At least remember these points. Now if they ask you basically beta that if there is gangrene, so what is going to be the treatment for gangrene, whether it is a case of atherosclerosis or it is a case of Buerger's disease. Do remember, in case if there is gangrene, we have to remember we have to only go for amputation beta. In the stage of gangrene, the only option that is possible is nothing else but amputation in the patient. समझे बात? चलो, so याद रखना, atherosclerosis में the sequence is lifestyle modification, then medical management, then angioplasty, then bypass grafting, and if gangrene present, then amputation. In cases of Buerger's disease, the sequence is lifestyle modifications, medical management. After that, directly lumbar sympathectomy. Bypass grafting or angioplasty are not possible for Buerger's. Angioplasty is not possible because in Buerger's, very small vessels are affected. And bypass grafting is not possible. Reason is, in Buerger's, the blockage which is there, it is distal to proximal. If the blockage is distal to proximal, mujhe bata, do you have a distal end to connect the graft somewhere? No. And if I don't have a distal end to connect the graft, how I can perform a bypass grafting? Samjhe? These are the reasons why angioplasty and bypass grafting cannot be performed in a patient suffering from Buerger's disease. Got it? Chalo. Now if I talk about basically this one, that is nothing else but about the grafts. So please tell me beta, for the procedure of bypass grafting that we do in a patient of atherosclerosis, please tell me which is going to be considered as the best autologous graft. Autologous means the graft or the vessel that is harvested from your own body, from the patient's body. The best autologous graft, if they ask you beta, very good. The best autologous graft, if they ask you, answer has to be nothing else but Lima or Rima beta. Now what do I mean by Lima or Rima? Lima is nothing else but left internal mammary artery. Rima is the right internal mammary artery. Clear? I have told you that after circle of Willis, the least common vessels affected in atherosclerosis are the Lima or Rima beta. Therefore, they are considered to be the best autologous graft. Clear? Yes. Do remember, arterial grafts are always more superior as compared to the venous grafts beta. They have a longer patency as compared to the venous graft. Samjhe baat? Now, if they ask you which is the most autologous graft that is used, the most common autologous graft, if they ask you beta, it is nothing else but your GSV, that is your great saphenous vein or the long saphenous vein, whatever you call it as. The best autologous graft is going to be Lima or Rima beta, but the most common autologous graft is going to be the GSV or the great saphenous vein. As it is much easier to harvest beta, therefore the great saphenous vein is used as the commonest graft picture. Clear? But better one is always internal mammary artery. Next, if they ask you the best synthetic graft, so I hope all of you are quite aware, synthetic graft depends on basically which kind of vessel is affected, whether it is a larger vessel or a smaller vessel beta. If larger vessels are affected, do remember the best synthetic graft is going to be which material? If larger vessels are affected, the best synthetic graft is going to be of which material? Very good. So if larger vessels are affected beta, the best synthetic graft is going to be of Dacron material. If the vessels like the aorta, okay, or iliac vessels, if they are affected beta, Dacron graft is always a better graft. Next important, if smaller vessels are affected beta, then which is a better graft? If smaller vessels are going to be affected, the better synthetic graft is known as PTFE, that is polytetrafluoroethylene. If the smaller vessels are affected like the popliteal artery or tibial arteries, then the better graft which is there, it is always PTFE, that is polytetrafluoroethylene beta. Hopefully clear to all of you now. So these are the points that you have to remember for the gradual arterial obstruction of conditions like atherosclerosis and Buerger's disease beta. Next is this case over here. What is seen over here? It is a case of aortic dissection beta. Now dissection in literal terms means tear beta. So if there is a tear in the aortic wall, that is known as aortic dissection. Now हमें पता है if there is going to be a tear in the aortic wall beta, what happens is the blood which is there, it usually starts flowing inside the wall. The blood which is there, it starts flowing in between the wall beta. That is what is known as aortic dissection. तो अगर aortic wall में tear हो जाता है तो blood wall के अंदर चला जाता है बेटा. That is what is important. ठीक है? Aortic dissection or this tear commonly happens due to uncontrolled hypertension. The leading cause of aortic dissection is the uncontrolled hypertension beta. That has to be remembered. Whenever a patient is going to have aortic dissection, the commonest presentation is patient will come to us with complaints of diffuse chest pain beta, and this chest pain is going to radiate to the interscapular area, that is exactly in the center of back. Do remember in MI also patient has chest pain radiating to back, but in MI the chest pain also radiates to the left shoulder, left arm, left jaw. Okay? But in cases of aortic dissection, the pain only and only radiates beta to the interscapular area or to the center of the back. That has to be remembered. Okay? Along with that, the patient may be hemodynamically unstable or the patient may be in shock. And as a lot of blood will go inside the tear, the organs will not receive enough blood supply beta. And therefore, the patient may have various problems like myocardial infarction, acute renal failure, stroke. These kind of problems may arise if the patient is usually suffering beta from aortic dissection. The tear is not in tunica media, the tear is in the tunica intima. The blood flows between tunica intima and tunica media. समझे? But tear अंदर वाली लेयर में होता है, that is tunica intima. Now, in cases of aortic dissection, if this patient comes to you, what is going to be the investigation of choice beta? तो याद रखना, we know as aorta is the central vessel of the body. I have already told you the investigation of choice has to be CT angiography beta. Okay, so if the patient is hemodynamically stable, the investigation of choice for aortic dissection is nothing else but CT angiography. That has to be kept in mind. Okay, and when I do a CT angiography beta in patients suffering from aortic dissection, we are able to get a very classical appearance, and that appearance is this one over here. You can see. Okay, this one is the main lumen of the aorta and this is the tear of the aorta. You can see a lot of blood is actually flowing via the tear beta, and this aortic dissection on the CT angiography, it gives you a very classical appearance. Yes, known as the tennis ball appearance beta. Okay, this CT angio usually shows you a very classical appearance known as nothing else but the tennis ball appearance. It shows you classically the tennis ball appearance beta. Barabar. So if CT angiography is showing you the tennis ball appearance, it is a classical case of aortic dissection, has to be remembered. Now, please tell me in the chat box beta, we know CT angiography can never be done if your patient is hemodynamically unstable. So let's say if your patient is in shock or your patient is hemodynamically unstable, then what should be considered as the investigation of choice? Let me know in the chat box beta. If my patient is hemodynamically unstable, then what should be my investigation of choice? Very good. If your patient is hemodynamically unstable, the investigation of choice is nothing else but a transesophageal echo beta. The investigation of choice for a hemodynamically unstable patient is going to be a transesophageal echo. So when I do a transesophageal echo in an unstable patient, I'll be able to diagnose aortic dissection beta. समझे बात? Now if they ask you what is the treatment, we know treatment of aortic dissection depends on the classification. There are two classifications used in aortic dissection. One is known as the DeBakey's classification. Second is called as the Stanford classification beta. Barabar? Stanford classification is important or it is necessary to decide the treatment in a patient of aortic dissection. Clear? Now, in both the condition, doesn't matter whether the patient is a case of Stanford A or Stanford B beta. In both the types, the first treatment is always IV esmolol. To control the patient's blood pressure, you have to give a beta blocker like IV esmolol. After giving IV esmolol, now, if it is a case of Stanford A beta, what do I mean by Stanford A? If there is tear in the ascending aorta or if there is a tear in both ascending plus descending aorta, okay? Either only ascending aorta or ascending plus descending aorta is what is called as Stanford A. If it is a case of Stanford A beta, the definitive treatment is always a surgery or always a surgical repair. Okay? Definitive treatment is always a surgical repair beta. Conservative management is not possible for a Stanford A type. Hopefully clear to all of you now. Whereas, if I talk about the next one, that is Stanford B. What is Stanford B? If there is involvement of only and only the descending aorta. If there is involvement of only the descending aorta, that is Stanford B. In this, after you have given IV esmolol, then you just try to monitor the patient beta. We just do monitoring in the patient basically. Okay. We just keep the patient under observation. We just keep on doing monitoring. Okay. In case if the monitoring fails beta, in case if this monitoring fails, then only we go for a surgery. So do remember beta, in Stanford B, the surgery is not a first option. Usually we only go for IV esmolol. After that we wait and watch, or we go for observation or monitoring. समझे बात? That is important. Recent NPG question, it has been Stanford B wala. So do remember this point. Clear? So if it is Stanford A, that is ascending aorta only, or ascending plus descending aorta, always go for a surgical repair. Whereas if it is Stanford B, that is only descending aorta, then I'll go for a monitoring or observation beta. Clear hai baat? Chalo. Next important is this question over here. What is the question saying? The question states, beta, we are having a 45-year-old female who had a history of malignancy. Okay, she took a long flight. Okay, she took a long haul flight, beta, and after landing, she starts complaining of pain and edema in the calf region. What is the likely diagnosis? What are you going to think about? Very good, all of you. So हमें पता है बेटा, the female is suffering from a malignancy, or she had a history of malignancy. We know malignancy is a hypercoagulable state. The blood is more viscous, blood ज़्यादा गाढ़ा होता है, बराबर? So definitely malignancy is a risk factor. Second important, the most common cause. She has taken a long flight, beta, and that long flight mein she will be sitting continuously. That is prolonged immobilization. And we know prolonged immobilization, whether it is due to bed rest, whether it is due to long flights, whether it is due to fractures, or it is due to surgeries, beta, doesn't matter. In these conditions, if the patient is having a prolonged immobilization, what will happen? There will be stasis of blood in the veins of lower limb, beta. And if there is stasis of blood in the veins of lower limb, then there will be formation of clots, or there will be formation of thrombus in these deep veins. And whenever there is formation of clot or thrombus in the deep veins, basically, beta, do remember, you have to go for nothing else. You will think about nothing else but DVT, that is deep venous thrombosis, beta. Clear hai baat? Chalo. So that is what is important to be remembered. So diagnosis, if they ask you, it is nothing else but DVT, also called as deep venous thrombosis. It is classically known as nothing else but deep venous thrombosis, beta. Not exactly the staging, but you have to remember the stage-wise management. Like in liver, 1, 2, 3 goes for conservative, 4, 5, 6 goes for surgical management. That is what you have to remember. Samjhe baat? So do remember, beta, here the diagnosis is classically deep venous thrombosis, has to be remembered. We know deep venous thrombosis mein the most common cause which is there, it is nothing else but prolonged immobilization, as you have rightly said. And here, for the prolonged immobilization, they have given us a hint that the patient has taken a long haul flight, beta. Hopefully clear. Now please let me know in the chat box, beta, that most commonly in DVT, beta, okay, the minimum time to become DVT, it is minimum 72 hours basically, beta. The patient should be having a prolonged immobilization according to Wells criteria. Minimum it should be 72 hours. Okay? Now important is, do remember, basically, if they ask you what is going to be the most common veins that are affected in DVT, so yaad rakhna, the commonest veins that are affected in DVT is nothing else but the soleal veins, beta. The commonest veins that are affected in DVT are the soleal veins, and these soleal veins are usually found in the calf region. That's the reason in patients of DVT, the patient will complain of the pain and edema in the calf region, beta. This is the reason why the patient has pain and edema in the calf region. Let me know in the chat box, beta, if I say that a case of DVT suddenly starts experiencing chest pain and dyspnea, what is the likely complication then? If a patient of DVT suddenly starts complaining of chest pain and dyspnea, beta, what is the likely complication that has occurred in the patient? Let me know in the chat box. Very good. So we know, beta, sometimes what may happen, the clot or the thrombus from the deep veins, beta, it gets dislodged or it gets separated. That clot or the thrombus travels all the way up to the pulmonary blood vessels and causes a sudden blockage, beta. And that condition is known as pulmonary embolism, due to which my patient will start complaining of the chest pain and dyspnea. So in a case of DVT, if there is going to be a chest pain and dyspnea, beta, do remember, it is basically a case of nothing else but pulmonary embolism. Has to be remembered. Samjhe baat? Now, in a patient of DVT, what are the clinical signs, beta? So we know, let's say this is the leg of the patient, this is the foot. So when I dorsiflex the foot, beta, patient has a pain or stiffness in the calf region, beta. That is classically called as my Homan sign. dorsiflexion of foot causes pain and stiffness and calf. That is classically known as your Homan's sign beta. Apart from that, the next one, if I squeeze the calf, that causes pain beta. If I'm squeezing the calf, that causes pain. That is classically known as my Moses sign beta. Squeezing of calf causing pain is known as Moses sign. Do remember, both these clinical signs are not elicited clinically beta. Reason, if you try to elicit this signs clinically, the thrombus will get dislodged and lead to pulmonary embolism. Never ever try to elicit this signs clinically beta. समझे बात? Investigation of choice. We know it is the deep veins in the lower limbs or the peripheral veins which are affected. So investigation of choice has to be nothing else but the duplex scan or the color Doppler beta. बराबर है बात? तो investigation of choice has to be nothing else but the duplex scan or the color Doppler itself. Now if they ask you for diagnosis, which criteria is used? So as we know basically beta, that the criteria that is used for the diagnosis is nothing else but called as the Wells criteria. Okay, Wells criteria or the modified Wells criteria. So Wells criteria is generally used for the diagnosis of DVT or deep venous thrombosis beta. समझे बात? So Wells criteria is generally used for the diagnosis in patients of DVT. At least remember the name beta, that is important. Wells criteria is used for the diagnosis of DVT. Now if they ask you basically beta, what is the treatment? So do remember basically beta, treatment mein, as there is formation of a clot or as there is formation of a thrombus beta, obviously for treatment you have to go for an anticoagulation beta, right? We have to go for an anticoagulation, and in anticoagulation the two drugs that we give, one is a low molecular weight heparin injection. Okay, one is injection of low molecular weight heparin and second is oral warfarin beta. ठीक है, तो please remember injection low molecular weight heparin and oral warfarin, that has to be given for a span of 5 days beta. ठीक है, for 5 days you have to give both the anticoagulants, but after 5 days basically, after 5 days you have to only continue the patient on oral warfarin beta. You will continue the patient only on oral warfarin basically. Do remember, if it is the first episode of DVT, I'll continue oral warfarin for 3 months. अगर पहली बार DVT हुआ है, you have to continue oral warfarin for a span of 3 months. But if it is a recurrent case of DVT, continue oral warfarin lifelong. अगर बार बार हो रहा है, if it is a recurrent case of DVT, please continue oral warfarin lifelong in this patient. Understood? Next, what is done for prophylaxis? Prophylaxis means prevention beta. Let's say a patient has undergone a major surgery like a TKR or a THR, total knee replacement or total hip replacement. We know after these major surgeries beta, patient will have a prolonged bed rest or a prolonged immobilization. So the patient will have very high chance of DVT. So how to prevent DVT or what is done for the prophylaxis of DVT beta? So याद रखना definitely, for prophylaxis of DVT or for prevention of DVT, you have to use this. What is this? It is nothing else but pneumatic compression stockings. A previous year image based question. Okay, we have to use the stockings beta. After every 2 hours the air fills up in the stockings and it will compress the calf or it will compress the legs beta, so that a proper blood flow is maintained. If there is no stasis of blood, there is no risk of thromboembolism beta. समझे बात? That is what is classically known as the pneumatic compression stockings basically. This was a previous year image based question in the FMGE exam. The ones which are shown in the picture is a classical case of nothing else but pneumatic compression stockings, which are given for prophylaxis or the prevention of DVT. Another advice that we give in a patient of DVT beta, and that is nothing else but we have to go for early ambulation. After the surgery beta, you might have heard we have to go for an early ambulation. That is nothing else but you will ask the patient to start walking as early as possible. You ask the patient to start walking as early as possible beta, because early ambulation will prevent basically the risk of thromboembolism beta. Hopefully clear to all of you now. So these are the points that you need to remember beta. Okay? These are the cases of, these are the points in DVT. Let's talk about the next topic, and that is nothing else but classically known as the varicose veins beta. If I talk about the next one, that is nothing else but varicose veins. Now varicosities is what? Literal meaning mein varicosities means whenever the vessels will get dilated and they will become tortuous. ज़्यादा pressure की वजह से जब vessels dilate हो जाती है और टेढ़ी मेढ़ी हो जाती है, tortuous हो जाती है, that is known as varicose vessels or varicosities beta. So varicose veins basically is what problem, understand. Let's say this is my deep vein beta, which is larger, and this is my superficial vein. Let's say this is my femoral vein, which is a deep vein, and this is my great saphenous vein, which is the superficial vein. We know both of them are connected at a junction beta, and this junction is classically called as saphenofemoral junction. Normally we know beta, at this saphenofemoral junction we are going to have a one-way valve. But let's say but let's say at this junction beta, if this valve is absent or if this valve is defective, अगर ये valve absent होगा या ये valve defective होगा, तो what will happen? A lot of blood from the femoral vein will go into the great saphenous vein, or a lot of blood from the deep vein goes into the superficial vein beta, and due to that, definitely beta, the patient will have extreme dilatation and tortuosity of the superficial vein. This extremely dilated and tortuous superficial vein which is there beta is classically known as nothing else but varicose vein. Is there a lag? Hopefully now it is fine, or still there's a lag. Let me know in the chat box. Hopefully now it is fine. Great, sure. Now I feel now it is fine, yeah. So please remember beta, we have a deep vein called as femoral vein and a superficial vein known as the GSV or the great saphenous vein. Both of them are connected at the level of junction beta known as the saphenofemoral junction. Please remember basically beta that whenever we have valves at the level of the junction, let's say if these valves are absent or let's say if these valves are defective beta, okay, what will happen? A lot of blood goes from the femoral vein into the great saphenous vein, or a lot of blood goes from the deep vein to the superficial vein beta, and due to which the superficial vein gets dilated and it becomes tortuous beta, and this dilated and tortuous superficial vein is known as varicose veins beta. Hopefully clear yahan tak. So that is important. So varicose veins, the most common cause of varicose veins is valvular incompetence, means if the valve is defective or if the valve is going to be absent beta. At which level? Most commonly beta at the level of the saphenofemoral junction. Most common cause of varicose veins is nothing else but the valvular incompetence, and the most common site for the valvular incompetence is usually the SFJ, that is known as saphenofemoral junction beta. That is important to be remembered. समझे बात? चलो. Now if they ask you what is the risk factor, like in DVT, the most important risk factor was prolonged immobilization. Do remember, in cases of varicose vein, the most important risk factor is prolonged standing beta. Okay, if the patient will do prolonged standing, what will happen? There is pooling up of blood in the deep veins of the leg, and if there is more blood in the deep veins of the leg along with valvular incompetence, all this blood will go into the superficial veins of the leg beta, causing varicosities. समझे बात? तो prolonged standing is considered as a risk factor for varicosities or varicose veins. That has to be kept in mind. Now if they ask you what is the classification, I hope all of you are quite aware. The classification that we have in cases of varicose veins beta is known as the CEAP or the CEAP classification, whatever you want to call it as. Okay, this classification of varicose veins beta, it is usually based on 4 parameters. The classification of varicose vein is based on 4 parameters beta. The first one is clinical manifestations. The second one is etiology. Third one is anatomy, and fourth one is pathophysiology beta. Okay, so C stands for clinical manifestations, that is signs and symptoms. E stands for etiology, that is the cause. A stands for anatomy, that is the location, and P stands for pathophysiology, that is the mechanism. Okay, based on these parameters beta, we can classify the varicose veins. Most important being the clinical classification beta. Clinical classification of varicose veins which is there. C1 basically means it is either it is telangiectasia or reticular veins beta. C1 literally means telangiectasia or reticular veins. C2 when the veins are going to be more than 3 mm dilated. Whenever the veins are more than 3 mm dilated, we call them as varicose veins. So do remember beta, C2 literally means varicose veins when the veins are more than 3 mm dilated. If they write the C2R beta, that small r basically stands for recurrent. If it is a case of recurrent varicose veins, then we write it as C2R. समझे बात? Next important is going to be C3. C3 is usually edema beta. C3 is edema. Next is C4A. Do remember, due to pooling up of blood in the lower limbs, you are able to see pigmentation and eczema. So C4A is nothing else but pigmentation and eczema that is going to be seen. So C4A is nothing else but pigmentation and eczema. Okay, as you are able to see over here. See, this is the veins which are more than 3 mm dilated, called as varicose veins. And this is nothing else but the pigmentation or the eczema which is seen in the lower limbs beta. That is C4A. Next is going to be C4B. Do remember, C4B is nothing else but a condition known as lipodermatosclerosis. A very, very important question from the previous year FMGE exam. Twice it has been asked as the image based question beta. They give you a picture and ask you the stage of varicose vein. So do remember, if they give a picture of lipodermatosclerosis, we know it is the stage C4B beta. What is lipodermatosclerosis? It is this one over here. Okay? It is this one over here that you are able to see. What is seen? So definitely there is pigmentation, there is eczema. If you feel basically beta at this site, there will be a woody hard texture. If you feel due to fibrosis or due to sclerosis, there is a woody hard texture that is felt. And if you see the shape of the lower limb, or if you see the shape of the leg beta, due to the fat loss and muscle contracture, the shape of the leg usually looks like an inverted champagne bottle. So this is what is the picture of lipodermatosclerosis beta. That is the stage C4B, and it is giving us a very classical appearance known as the inverted champagne bottle appearance. Anybody, if a small child is having inverted champagne bottle appearance in both the legs, what is the differential that should come to your mind from pediatrics? Let me know. If a small child is having an inverted champagne bottle appearance in both the legs, okay, what is the differential that should come to your mind? Let me know in the chat box. Bolo. समझे बात? Next important, if I talk about basically C5. C5 is a healed venous ulcer beta. C5 is a healed venous ulcer, and C6 is usually a active venous ulcer. C6 is an active venous ulcer. No. Achondroplasia में there is a champagne glass pelvis. There is not an inverted champagne bottle appearance. ठीक है? Inverted champagne bottle appearance in both the legs is a classical feature of nothing else but Charcot-Marie tooth disease beta. It is a classical feature of Charcot-Marie tooth disease. Clear about? Next, if they ask you investigation of choice, we know again varicose veins are usually the superficial veins of the legs which are affected beta. So again, peripheral vessels. So investigation of choice has to be nothing else but you have to go for the duplex scan beta. The investigation of choice which is there, it is nothing else but the duplex scan or the color Doppler. And when I do a duplex scan or the color Doppler, basically beta, if I do a duplex scan or color Doppler, and if there is an incompetence at the saphenofemoral junction, I will be able to see a very classical appearance beta, and that is nothing else but called as the Mickey Mouse appearance. That is classically known as nothing else but the Mickey Mouse appearance beta. That has to be kept in mind. समझे बात? So that is what is important. So investigation of choice is a duplex scan, and on duplex scan basically beta, if there is going to be a saphenofemoral junction incompetence, that gives us a very classical appearance beta called as the Mickey Mouse appearance. That has to be kept in mind. Samjhe? Now what should be the treatment? We know if the patient of varicose vein comes to us in the early stages beta, okay? If the patient comes to us in the early stages, then we have to just go for nothing else but beta lifestyle modifications. And the lifestyle modifications that we do in early stages of varicosity is beta. One is advise the patient to wear elastic compression stockings beta. Advise the patient to wear elastic compression stockings which will compress the legs beta, so that the blood does not pool up in the superficial veins of leg and varicosities do not develop. Second important is ask the patient to elevate the limb. If the patient will elevate the legs, or if the patient will elevate the limb beta, take a pillow below the legs. So what will happen? the deoxygenated blood will not pool up inside the leg beta, it will properly drain and therefore varicosities will not develop. Okay? Apart from this, also advise the patient to avoid prolonged standing beta. Okay? So 3 things for lifestyle modification: elastic compression stockings, elevation of limb, and avoid prolonged standing. These are the important hints that you have to give. Clear? Now, in case beta patient is in the advanced stages of varicose veins. So if the patient is in the advanced stages of varicose veins, nowadays the surgery of choice that we prefer for varicose veins beta, one is basically going to be a EVLT. What is EVLT? Endovenous laser therapy or a endovascular laser therapy beta. Okay, one of the treatment options that we have nowadays is EVLT, called as the endovenous laser therapy. With the help of the laser beta, we are actually going to block the junction, as well as we are going to collapse the superficial venous system beta. If with the help of laser you collapse the junction and the superficial venous system, obviously if no superficial veins are there, there is no pulling up of blood only. Clear about that? Is important to be remembered. Second, another option which is equally effective is known as RFA, or a radio frequency ablation. Instead of laser, if you use radio waves beta to collapse this superficial veins, then we basically call it as the radio frequency ablation. So nowadays the surgery of choice are not the conventional surgeries like ligation and all. Nowadays the surgery of choice, if they ask you, it is nothing else but either a endovenous laser therapy or a radio frequency ablation beta. Clear about? These are the important points that you need to remember. Okay. And if they say if the patient is having a perforator incompetence, what are perforators? Perforators are small connections between the deep veins and the superficial veins. Sometimes varicose veins may also develop due to perforator incompetence beta. Okay, if there is a problem at the level of perforator, and if the problem is due to perforator incompetence, the surgery in perforator incompetence can be classically known as SEPS beta. What is SEPS? It is the subfacial endoscopic perforator surgery. Okay, the surgery of choice which is there beta for perforator incompetence nowadays is SEPS, subfacial endoscopic perforator surgery. Previously we used to perform Dodd and Cockett surgery. Nowadays the surgery of choice for perforator incompetence is SEPS, or the subfacial endoscopic perforator surgery. Clear about? So these are the points that you need to remember. Answer this question. This was the previous year question in the FMGE examination. What is the question saying? The question states beta, a patient presented to the OPD with complaints of discomfort along with a dilated tortuous vein in the leg region beta. Okay? The patient is having a dilated tortuous vein in the leg region. He gives a history of trauma at that site almost 8 years ago. On examination, a pulsatile swelling is palpable beta. What is the likely diagnosis in this scenario? Let me know in the chat box. This was the previous year FMG question, July 2023, I feel. Do remember beta, in this condition, the answer is not at all. Reason, हमें पता है varicose veins is just very good weapon. We know varicose vein which is there basically, it is just a dilated vein. And vein में कब से pulsations होने लगे इतने strong? So if they say pulsatile swelling, okay, it is not a case of varicose vein. Varicose vein में, yes, the vein is going to be dilated, the vein is going to be tortuous beta. Okay, that's fine. Okay, but it has nothing to do with the history of trauma. It has nothing to do with pulsatile swelling beta. That has to be remembered. Clear about the varicose veins में pulsatile swelling is not seen. That is important. Only a dilated and tortuous vein is there. Clear? Pseudoaneurysm usually arises from the arteries. It is much deeper. And here they have said basically it is a vein which is dilated. Hemangioma is a benign tumor arising from the vessels beta. Here they have not said anything about a tumor basically, okay, or anything about a mass or a lump, nothing. So answer to this question is a AV fistula, also called as an arteriovenous fistula. याद रखना, AV fistula or an arteriovenous fistula में there is an abnormal connection between the artery and the vein beta. Now if there is an abnormal connection or a fistula between the artery and vein, what will happen? We know as arteries have more pressure, so a lot of blood goes from the arteries to the vein beta. And when a lot of blood goes from artery to the vein will get dilated and the vein will become tortuous. And this is going to cause the dilated and the tortuous vein beta. Apart from this, do remember one point, that basically here as more blood will go from artery to the vein beta, therefore you will find that with each no, sorry, you will find beta that the swelling which is there, it is pulsatile in nature. Okay, that swelling which is there basically it is showing pulsations beta. That is what is important. There are multiple reasons for why a AV fistula or why this abnormal connection develops beta. Either it could be the commonest causes penetrating trauma. If there was a penetrating trauma beta, that is the reason why a AV fistula may develop in the patient. Other reasons can be malignancy, which erodes the vessels. It could be some infections. It can be definitely iatrogenic. When we create a fistula beta for the hemodialysis procedure, multiple reasons are there for a AV fistula or an arteriovenous fistula to develop. Clear? The commonest cause is nothing else but penetrating trauma beta. Do remember in patients of AV fistula, pulsatile swelling will be the keyword. Pulsatile swelling is only seen in two conditions. One is a AV fistula, second is an aneurysm beta. Do remember aneurysm commonly arises from the artery and it is much deeper. On the other hand, AV fistula mein the swelling is usually due to the dilated vein. That is important. So it is more superficial. Yaad rakhna, in patients of AV fistula, there is a classical sign seen known as the Nicoladini-Branham sign beta. At least remember the name of the sign. The sign that is usually seen in cases of AV fistula is classically referred to as the Nicoladini-Branham sign. That is when I definitely block the feeding artery beta. Whenever I am going to block the feeding artery, basically what will happen is, please remember, the size of the swelling will decrease, the pulsations in the swelling will decrease, okay, the brew on the swelling will decrease. That is classically known as the Nicoladini-Branham sign basically. Okay, we'll do it at the last. Okay, so it is known as the Nicoladini-Branham sign beta. That is what is important to be remembered. No issues with this. Apart from this, do remember one more point beta, and that is nothing else but investigation of choice. Investigation of choice in cases of AV fistula is nothing else but an MR angio or an MR angiography beta. That has to be kept in mind. Clear? And treatment, if they ask you, obviously if the patient is asymptomatic, I don't need to go for any treatment in AV fistula. If the patient is asymptomatic, no treatment is needed. But if the patient is symptomatic, I basically go for an angioembolization beta. If my patient is symptomatic, I go for an angioembolization. And let's say if you have tried angioembolization but if it fails, you have tried angioembolization but if it fails beta, then definitely you have to go for a surgical ligation. If you have tried angioembolization but that fails, you have to go for nothing else but surgical ligation basically. That is what is important. Okay? Chalo. So these are the points beta that you have to remember in a case of an AV fistula or an arteriovenous fistula. If the same question is repeated, please don't make a mistake in the FMGE exam. Clear? Chalo. Let's start with the major topic of surgery, and that is nothing else but GI surgery or the gastrointestinal surgery beta. The first case is a neonate has come to you beta with complaints of continuous drooling of saliva from the mouth. Okay? So there is a continuous drooling or continuous dribbling of saliva from the baby's mouth, and he is also suffering from respiratory distress. The mother gives a history of polyhydramnios during pregnancy. So the mother was suffering from polyhydramnios during pregnancy beta. Okay, now they say the chest x-ray has been given over here. What is the likely diagnosis? What is seen on the chest x-ray? Here on the chest x-ray, you are able to see some radio-opaque shadow beta. And this radio-opaque shadow which is there, it is nothing else but your NG tube or the OG tube beta. That is nasogastric tube or the orogastric tube which is seen. But you can see that the NG or the OG tube is not going up to the stomach. Rather, there is coiling of the tube which is seen beta. Why there is going to be coiling of the tube beta? So there has been a coiling of tube because the esophagus is not completely formed beta. Yes, as the esophagus is not completely formed, that is the reason why the tube may not go down into the stomach and there is coiling of tube which is seen over here. Yes, yes, it is a classical diagnosis of nothing else but esophageal atresia beta, and we know that this esophageal atresia which is there is very commonly associated with a tracheoesophageal fistula. Barabar, this esophageal atresia is commonly associated with a tracheoesophageal fistula also. Hopefully clear to all of you now. That is what is important. Now we know that esophageal atresia literally means what? So let's say we know if both the ends of the esophagus are not connected to each other beta, That condition is known as esophageal atresia. Along with that, what happens at times is, we know this esophagus which is there, it may have an abnormal connection with the trachea. And if there is an abnormal connection with the trachea, beta, this is basically called as the tracheoesophageal fistula. Why I'm saying that in this child a tracheoesophageal fistula is present, beta? The reason is basically because, do remember, the child is having respiratory distress. And what is the reason for respiratory distress? The saliva which is there, beta, it may enter into the trachea or into the airway. And if that saliva enters the trachea or the airway, that will cause aspiration. And due to aspiration, the child is having respiratory distress, beta. Samjhe baat? So that is what is important. So as there is esophageal atresia, the baby is having continuous drooling of saliva, and that is the reason why the mother had polyhydramnios during pregnancy also, beta. I hope all of you are quite aware from gynae. Most common cause of polyhydramnios is idiopathic, but most common cause of severe polyhydramnios, if they ask you, answer is GI anomalies or gastrointestinal anomalies like esophageal atresia or duodenal atresia, beta. Samjhe baat? That is what is important. Understood? So here the patient is having an esophageal atresia along with tracheoesophageal fistula, and I said tracheoesophageal fistula because of this respiratory distress which they have mentioned in the question. Clear hai yahan tak? Now we know that this condition known as esophageal atresia is commonly associated with a set of anomalies or a group of anomalies, and that group of anomalies which is there basically, beta, what you are saying? Yeah, obviously it will be more dangerous. Please remember, associated with a group of anomalies, that is nothing else but VACTERL anomalies basically, beta, that you have to remember. If I talk about VACTERL anomalies, it is nothing else but V for vertebral defects, A for anorectal malformation, C for cardiac anomalies, TE for tracheoesophageal fistula, R for renal agenesis, and L for limb defects. Now a previous year FMG question was, out of the VACTERL anomalies, beta, which is the most common type of anomaly seen in the child? Commonest anomalies seen among the VACTERL anomalies, beta, let me know in the chat box. The commonest anomalies seen in the VACTERL group is going to be the cardiac anomalies, beta. Very good. The most common anomaly which is seen out of the VACTERL group of anomalies, beta, is going to be the cardiac anomalies overall. Clear? Tracheoesophageal fistula is only associated with atresia. Overall, if I ask you, among the VACTERL group, the commonest anomalies are the cardiac anomalies, has to be remembered. Now, we know esophageal atresia is usually classified into 5 types, beta. Type A to type E. We know type A is only atresia, beta. Type A is only atresia. Type B is atresia plus a proximal fistula. Type B is atresia plus proximal fistula. Type C is atresia plus distal fistula, beta. Type C is atresia plus distal fistula. Type D is atresia plus both the fistulas, that is proximal as well as distal. Type D matlab dono fistula. Type D is atresia plus proximal as well as distal fistula. And type E is only fistula, no atresia. Type E is only a fistula, no atresia. PYQ was, which is the most common type of esophageal atresia in the child? Let me know in the chat box. The commonest type of esophageal atresia in a child, answer will be the most common type of esophageal atresia from type A to type E. Answer is going to be very good, beta. The most common type of esophageal atresia is basically going to be type C, beta. And type C is nothing else but patient having esophageal atresia with a distal tracheoesophageal fistula. Patient having esophageal atresia with a distal tracheoesophageal fistula. This type C is the commonest type of esophageal atresia. Now, when the child of esophageal atresia is brought to us with drooling of saliva and the respiratory distress, we will try to pass the nasogastric or the orogastric tube. And once we pass the nasogastric or orogastric tube, on chest X-ray you are able to see the classical coiling of tube, beta. The confirmation is going to be done by a CECT, investigation of choice, if they ask you, beta, in patients suffering from esophageal atresia. Answer is nothing else but the CECT, that is contrast enhanced CT scan, or a CT scan with oral contrast, beta, whatever you call it as. Okay? Now if they ask you what should be the treatment, so do remember, beta, treatment mein it depends which type it is. If it is a case of type A, that is nothing else but esophageal atresia only. Type A ka matlab The patient is only having esophageal atresia. There is no fistula beta. Now in type A beta, it depends whether both the ends are close to each other or far away from each other. If I say that both the ends basically are close to each other, then I will go for an immediate connection or an immediate anastomosis. And when I make a connection between the two ends of esophagus, we call it as esophago-esophageal anastomosis or esophago-esophagostomy beta. Clear about? So when I definitely make a connection between both these ends, that procedure is classically known as esophago-esophagostomy. Clear about? Let's say basically beta that if both the ends are very far away from each other, let's say these are the two ends beta and they are very far away from each other. Now if both the ends are far away from each other, can you pull them and go for a connection or an anastomosis? No beta. If they are very far away from each other, I cannot go for an immediate anastomosis. So what I need to do? I have to wait for a span of few days beta. Okay, yes. We have to wait for a span of few days. Till that time, both these ends will grow towards each other. And once these ends grow towards each other, once they come close towards each other, then you can go for a connection or an anastomosis between them. Clear about? So if two ends are far away from each other, so initially perform a feeding gastrostomy beta to provide nutrition to the child, right? Because tube cannot go inside the stomach. So what we do is we directly create an opening on the patient's stomach, and via this opening we insert a tube beta. And via this tube now you should provide nutrition in the child beta. This procedure is classically known as a feeding gastrostomy. Clear? So till the surgery you have to feed the child with the help of feeding gastrostomy, and once both the ends have grown close towards each other, then go for a connection known as esophago-esophageal anastomosis or esophago-esophagostomy. So feeding gastrostomy and few weeks later perform a esophago-esophagostomy. समझे बात यहाँ तक? So that is what is important to be remembered. Feeding gastrostomy is preferred whenever the gastric emptying is normal. If gastric emptying is normal, go for gastrostomy. If gastric emptying is problematic, then go for a jejunostomy. समझे बात? That depends on gastric emptying of the patient. Next important, if I talk about, is nothing else but type B, C, D and E beta. What is the common factor between all of them? The common factor between all these types is nothing else but a fistula. All these types of esophageal atresia will also have an associated tracheoesophageal fistula. So in these conditions, what we do? First of all, we cut the fistula. After cutting the fistula, we repair the trachea. And after repairing the trachea, then we go for an esophago-esophageal anastomosis or esophago-esophagostomy beta. This three-step surgery that we do in type B, C, D and E is classically known as the Cameroon heat surgery beta. This is classically referred to as the Cameroon heat surgery. Clear about? So these are the points that you need to remember बच्चे about the esophageal atresia and tracheoesophageal fistula. समझे यहाँ तक बात? चलो. Another sarkari question which is there in the examination from pediatrics and surgery. The question states beta, a neonate complains of respiratory distress along with dextrocardia, that is the heart is shifted towards the right side beta, and the child is having a scaphoid abdomen or a scooped out abdomen. It seems as if somebody has taken a scoop of ice cream from his abdomen. ठीक है, खाली पेट दिखता है सब बच्चे का. What is the classical diagnosis or what is the probable diagnosis beta? If they ask you. Very good. तो हमें पता है, let's say beta, this is nothing else but a case of CDH where what happens is there is a defect in the diaphragm. As there is a defect in the diaphragm beta, what happens is the intestine, bowel or the abdominal contents go into the thoracic cavity. When the abdominal contents or the intestines beta, they protrude or they enter into the thoracic cavity beta, okay, due to that what will happen? The lung will not get enough space to develop. If the lung is not developed properly, we call it as pulmonary hypoplasia. And due to this pulmonary hypoplasia, the child suffers from respiratory distress. The defect or the herniation is more commonly seen on the left side beta. That's the reason your bichara heart usually gets shifted to the right side, causing dextrocardia. And as all the abdominal organs have gone into the thoracic cavity or have herniated into the thoracic cavity, the abdomen appears to be empty like a scaphoid abdomen beta. Clear? This is the classical triad of congenital diaphragmatic hernia. The classical triad is respiratory distress, dextrocardia and scaphoid abdomen, RDS. Clear? So the classical diagnosis is CDH or congenital diaphragmatic hernia. We know what happens is due to a diaphragmatic defect beta, the abdominal organs will herniate into the thoracic cavity, leading to a pulmonary hypoplasia in the baby. समझे बात? So that is the condition known as CDH. Important is, let me know in the chat box. We know there are two types of congenital diaphragmatic hernia. One is the Bogdalic hernia. Second is the Morgagni's hernia, also known as Larry's hernia beta. So please tell me which one is more common type beta, the Bogdalic or the Morgagni's hernia? Which one is a more common type of congenital diaphragmatic hernia, whether it is going to be the Bogdalic or the Morgagni's hernia? Let me know in the chat box. So I hope all of you are quite aware. The more common type which is there is nothing else but the Bogdalic hernia beta. We know that the Bogdalic hernia which is there, or the Bogdalic hernia which is there, basically it is going to be seen on the left side beta. Yes, in Bogdalic hernia, the defect which is there, it is usually seen on the left side and in the posterolateral wall of the diaphragm. Okay, Bogdalic hernia meant the defect is on the left side and mainly in the posterolateral part of the diaphragm beta. समझे? Whereas Morgagni is completely opposite. Morgagni में the defect is on the right side in the anteromedial part of diaphragm. Morgagni में the defect is on the right side in the anteromedial part of diaphragm. Now what is contraindicated? We know this child of congenital diaphragmatic hernia basically beta is having a respiratory distress, and whenever a patient has respiratory distress, we need to manage the patient's airway or we have to provide ventilation beta. But which type of ventilation is absolutely contraindicated? Very good. We know beta, Sarkari question again, the bag and mask ventilation which is there, it is going to be absolutely contraindicated beta if the patient is usually suffering from congenital diaphragmatic hernia. Reason, if you provide a bag and mask ventilation beta, the air also enters inside the patient's GI tract. And if there is more air which goes in the bowel, or if there is more air which goes in the intestine, there is more bowel distension which will cause more respiratory compromise beta. Samjhe baat? So if you go for a bag and mask ventilation beta, the patient will have more respiratory compromise or worsening of distress. That's the reason you avoid bag and mask ventilation. If they ask you then what is the airway of choice? We know airway of choice is nothing else but beta endotracheal intubation. The airway of choice that we have to use is nothing else but AT intubation or endotracheal intubation has to be done. Because via AT intubation, the air only reaches into the patient's airway. The air will not go inside the GI tract beta. Samjhe baat? When this child of congenital diaphragmatic hernia is brought to us in the emergency, we can go for a chest x-ray. And when I go for a chest x-ray, you can see this classical picture. Rather than complete black lung filled beta, I am able to see air filled or gas filled bowel loops in the thorax. So whenever the chest x-ray shows you the classical bowel loops in the thorax beta, that is a classical hint towards the case of CDH or a congenital diaphragmatic hernia beta. Samjhe baat? That is important. Do remember that whenever you have confirmed it as a case of congenital diaphragmatic hernia, after x-ray you go for a CECT. And once you confirm it as a case of CDH beta, then the treatment is surgery, where we do the reduction of all the abdominal contents, and after reducing or after pushing back all the abdominal contents beta, we close the diaphragmatic defect. Okay, we have to close the diaphragmatic defect. If the diaphragmatic defect is large, I close it with the help of prosthetic patch beta. Okay, if the diaphragmatic defect is large, we usually prefer to close it with the help of prosthetic patch. Mesh is not preferred usually beta for closure of the diaphragmatic defect in CDH. Okay, because mesh is going to shrink. So we prefer using a prosthetic patch. Samjhe baat? So definitely treatment is nothing else but the definitive treatment is nothing else but the surgical repair. You have to push all the organs back into the abdomen and go for a surgical repair or a surgical closure of this diaphragmatic defect. Next, another common question which is asked basically beta, and that is this. A patient presents to you with complaints of heartburn, also known as retrosternal burn. Patient has burning sensation over here. Along with that, there is epigastric pain and there is a retrosternal pain beta. A classical triad, right? You might have heard. Heartburn, epigastric pain, retrosternal pain. A classical triad which is seen along with sour brush. Sometimes beta you get a gush of fluid in your mouth. Okay. And that gush of fluid that you get in your mouth basically is nothing else but the acid reflux which is happening. Barabar? And the patient is also having hoarseness of voice. Why? Because the acid reflux, if it happens till the larynx beta, obviously due to that acid, the vocal cords will be damaged over a period of time, and that causes hoarseness of voice beta. Clear? So it happens due to the LPR or the laryngopharyngeal reflux. Okay, and this is a classical diagnosis of nothing else but, very good. Yes, it is a classical diagnosis of nothing else but GERD beta, also called as a gastroesophageal reflux disease. We know that if I talk about the GERD or the gastroesophageal reflux disease, what is the main reason behind it? The main reason is a transient lower esophageal sphincter relaxation beta. If the lower esophageal sphincter is relaxing more frequently beta, if the LES sphincter, if the lower esophageal sphincter relaxes too much, what happens? The acid of the stomach basically goes back into the patient's esophagus, and when the acid goes back into the patient's esophagus beta, that is classically known to cause nothing else but beta the gastroesophageal reflux disease or GERD. Okay, as the acid goes back into the stomach, the patient, as the acid goes back from the stomach into the esophagus, that is basically known to cause GERD. And due to this GERD, the patient has the classical triad: heartburn, epigastric pain, and retrosternal pain. Clear? Now, if this here patient of GERD comes to you basically beta, what is going to be the investigation of choice? One option is upper GI endoscopy. Second option is 24-hour pH monitoring beta. Let me know in the chat box. This is a repeat question of the FMGE PYQ. What is the investigation of choice in a patient of GERD or a gastroesophageal reflux disease? Very good, bache. So please remember, yes, the investigation of choice which is there, it is nothing else but the upper GI endoscopy beta that has to be remembered. Samjhe baat? The investigation of choice is nothing else but upper GI endoscopy basically that has to be remembered. No issues with this? Chalo, great. So upper GI endoscopy is the investigation of choice basically beta. Reason, it is going to be less invasive, and as it is less invasive beta, it is the investigation of choice. On upper GI endoscopy, you are able to see the transient frequent LES relaxation beta that confirms the diagnosis of GERD. Clear about? In case if the patient is not diagnosed with the help of upper GI endoscopy, in those conditions definitely beta you have to go for a gold standard investigation, and that gold standard investigation that we have is known as 24-hour pH monitoring. Reason, 24-hour pH monitoring which is there, it is more invasive beta. Here a pH, here definitely the probe is inside the esophagus beta for a span of 24 hours, so it is more invasive. So investigation of choice is 24-hour pH monitor. Investigation of choice is upper GI endoscopy. If that fails, then gold standard investigation is 24-hour pH monitoring. In 24-hour pH monitoring, you calculate the Johnson-Demister score. If the Johnson-Demister score is more than 14.7 beta, then we say the patient is a case of GERD. If the Johnson-Demister score is more than 14.7, then we diagnose it as a case of GERD, has to be remembered beta. Clear hai baat yahan tak? Great. Now if they ask you what is going to be the treatment, so do remember beta, the treatment, the first line treatment in a patient of GERD is always lifestyle modifications beta. Why? Reason being the risk factors which are responsible for GERD are always modifiable. Usually obesity, alcohol, smoking, tea, coffee, carbonated beverages. All these are modifiable. So the first line treatment is always lifestyle modifications that has to be done. You will ask the patient for weight loss. You will ask the patient to quit smoking and alcohol. You will ask the patient to avoid tea, coffee, carbonated beverages, or spicy food beta. Clear? These are the advices, and you will always ask the patient to take small frequent meals basically. Okay, always ask the patient to take small and frequent meals. Let's say beta, if lifestyle modifications have been tried, but if lifestyle modification fails, in those conditions beta, the treatment of choice or the drug of choice is going to be what? Medical management. And I hope all of you are quite aware the drug of choice or the treatment of choice in patients of GERD is nothing else but known as PPIs beta. What are PPIs? The proton pump inhibitors. These proton pump inhibitors beta, they decrease the secretion of HCl or they decrease the secretion of acid. As they decrease the secretion of HCl or acid basically beta, that's the reason the risk of reflux is also going to decrease. barabar, the risk of reflux which is there basically, it is also going to decrease. We know PPIs or the proton pump inhibitors are all the drugs which end with prazoles beta. It is usually the drugs like omeprazole, lansoprazole, pantoprazole, all of these. Okay? So the drug of choice or the treatment of choice is nothing else but proton pump inhibitors beta or the PPIs. Along with proton pump inhibitors or PPIs beta, another agents that we can add basically along with PPIs beta, the another agents that we can add basically are nothing else but prokinetics beta. I hope all of you are quite aware. The prokinetic agents that you can add are usually the drugs like mozapride, etopride, all of them. Okay? So along with PPI, the another drugs that you can add basically are nothing else but the prokinetic agents like mozapride or etopride. Do remember beta, PPIs or proton pump inhibitors nowadays is not only the drug of choice but even the treatment of choice. Why? Because such a good improvement is seen with patients of GERD beta that you don't need any kind of surgery in majority cases. So nowadays the treatment of choice for GERD is also PPIs only. Clear? PPIs or proton pump inhibitors are the drug of choice or are the treatment of choice in three conditions. कौन से तीन condition में? First one GERD, second one gastritis, and third one peptic ulcer disease. So GERD, gastritis, and peptic ulcer disease. Drug of choice or treatment of choice is same, that is nothing else but PPIs or the proton pump inhibitors which है. Clear है बात यहाँ तक? चलो. Now in case if you say that we have tried the PPIs for a very long duration of time beta, but even if we try PPI, the patient's condition does not improve. If the patient's condition haven't improved beta, in those condition you can go for the surgical procedure. What have we done in the surgical procedure? You can see now we have taken the fundus of the stomach and we are going to wrap this fundus of the stomach around the lower esophagus. तो मैं fundus लेना stomach का और उसको lower esophagus के around wrap कर देना है. तो if I take the fundus of stomach and wrap it around the lower esophagus beta, okay, that is known as fundoplication surgery. This is known as fundoplication surgery beta. We have complete fundoplication or partial fundoplication. The one which is shown in the picture is the most important and the common one beta. Here we can see there is a complete 360-degree wrap or a complete 360-degree fundoplication around the lower esophagus. And this is classically known as Nissen's Fundoplication. A recent 2024 NEET PG question, just image based question, surgery का नाम पूछा था. And this same question has been repeated a lot of times in previous year FMGE exams also beta. अब इमेज देख के आंसर बताना is very easy, right? Do not make a mistake ever over here. So surgery of choice in this patients of GERD beta, it is nothing else but Nissen's Fundoplication, which is a complete 360-degree wrap beta. That has to be remembered. ठीक है, तो Nissen's Fundoplication is the surgery of choice in GERD. It is only done obviously whenever the medical management or the PPI fails in the treatment. ठीक है, so Nissen's Fundoplication is a 360-degree wrap. Do remember we also have some partial wraps or partial fundoplication beta. If I talk about partial fundoplication, let me know if I say about a 180-degree anterior wrap or 180-degree anterior fundoplication, what is the name? If there is a 180-degree anterior wrap or a 180-degree anterior fundoplication, that is known as DORS fundoplication beta. Yes, that is basically called as the DORS fundoplication surgery. Whereas if I talk about the next one, 270-degree posterior wrap or 270-degree posterior fundoplication, then what is the name? If I talk about 270-degree posterior wrap or 270-degree posterior fundoplication beta, very good, shabash. It is going to be called as the Taupet's fundoplication beta. If it is a 270-degree posterior wrap, we call it as the Taupet's fundoplication. Hopefully clear to all of you now. So these are the points basically beta that you have to keep in mind in a case of GERD. Sure. Great. Done with this, at least remember these three types of fundoplication, but the commonest one or the best one is always a 360-degree wrap known as Nissen's Fundoplication, has to be kept in mind. Clear? Next, another common topic between surgery as well as ENT beta, and that topic is nothing else but foreign body ingestion. Now if they ask you basically about the foreign body ingestion, bache, we know foreign body ingestion can lead to blockage of the airway or blockage of the esophagus beta, right? That foreign body may impact in the airway, that is larynx, trachea or bronchi, or it may impact the esophagus of the patient beta. Barabar? If they ask you most common age group, so we all know most common age group where foreign body ingestion happens has to be children beta. And in children, the commonest foreign body ingested is either going to be coins or going to be peanuts beta. So coins and peanuts are considered as the commonest foreign bodies basically beta, which are usually ingested by children. Coins or peanuts are the commonest foreign body ingested by children. Do remember, if the patient is an adult beta, the most common foreign body ingested by an adult is going to be a fish bone. The most common foreign body ingested by an adult is a fish bone. And if the patient is going to be elderly, if the patient is an elderly, the most common foreign body ingested by elderly are the dentures or the loose teeth beta. The commonest foreign body ingested by an elderly is going to be the dentures or the loose teeth beta. Clear yahan tak? Great. Now important is, we know if a person is having a foreign body ingestion beta, obviously it will cause an obstruction or obviously it will cause a blockage. That is the reason why patient will have choking sensation. Patient will come to the emergency like this. You can see the patient is having a choking, not able to speak, not able to breathe beta. This is the common feature which is seen. Apart from that, basically the patient may have difficulty in breathing known as dyspnea or difficulty in swallowing called as dysphagia. These kind of symptoms can be seen in patients of foreign body ingestion beta. Now, whenever a case of foreign body ingestion comes to us, we know the first line investigation that we have to do is nothing else but X-ray. In a case of foreign body ingestion, the first line investigation is always an X-ray. We have to take both the views. One is the AP view, that is antero-posterior view, and second is the lateral view. Both the views of the X-ray has to be done beta to exactly locate the foreign body beta. Now, again, don't try to rectify anything, easy hai. Please remember, the AP diameter of the trachea is more beta. The antero-posterior diameter of trachea is more. Therefore, the foreign body goes like this inside the trachea. That means what? On the AP view, the foreign body is appearing slit-like beta. And on the lateral view, the foreign body is appearing circular. So, yaad rakhna, on AP, if the foreign body appears slit-like, and on lateral, if the foreign body appears circular, that means the foreign body is inside the airway or inside the trachea. Second thing, do remember that the transverse or the horizontal diameter of esophagus is more. The transverse diameter of esophagus is more. Therefore, the foreign body goes in the esophagus like this. That is, on AP view, the foreign body appears circular beta, and on lateral view, the foreign body appears slit-like. So, if the foreign body appears circular on the AP view and slit-like on the lateral view, that means the location of foreign body is nothing else but the esophagus beta. यहाँ पे देख सकते हो, you can see foreign body is appearing slit-like on the AP view and circular on the lateral view. That literally means the foreign body is located in the trachea beta. Whereas here you are able to see the foreign body is appearing circular on the AP view, whereas slit-like on the lateral view beta. That means the location of foreign body is inside the esophagus. Now another method is what? You can just see this black air column in front of the foreign body. If you are able to find this black air column in front of the foreign body, that means the foreign body is in the esophagus. Reason, if the foreign body is in the esophagus, in front of it will be the trachea that looks like the black air column. But again, this is one way, but it is very difficult beta. So always remember, this is the easiest way basically to remember to find out whether the foreign body is in the trachea or it is in the esophagus. Now, important is what should be the treatment. So do remember beta, if I say the foreign body is in the airway, that is if the foreign body is in the trachea, larynx or the bronchi. We know in airway I cannot keep the foreign body. So airway mein agar foreign body hai, the treatment is always and always a endoscopic removal. A laryngoscopic, tracheoscopic or a bronchoscopic removal depending on the location. Barabar? So endoscopic removal to be done beta if the foreign body is in the patient's airway. Whereas if I say that if the foreign body is in the patient's esophagus beta, if the foreign body is in the patient's esophagus, then do remember beta, if they say that the foreign body is above C6, if they say that the patient's foreign body is going to be above the C6, we know at C6 what do we have? At the level of C6 we have the CPS, that is cricopharyngeal sphincter. Or yaad rakhna, this CPS or the cricopharyngeal sphincter is the narrowest portion of the whole GIT. So if they ask you narrowest portion of whole GIT, answer is nothing else but the cricopharyngeal sphincter or the CPS. If the foreign body is above C6 or above CPS beta, that means the foreign body is large in size and therefore I need to remove it endoscopically beta. So we can go for an endoscopic removal or esophagoscopic removal if the foreign body is above the C6. But if the foreign body is below C6, if they say the foreign body is below C6, then we can just go for an observation beta. You'll be like, why? Reason is, we know beta, if the foreign body is below the C6 basically, matlab the foreign body is small. How? We know beta, if it is able to cross the narrowest portion known as cricopharyngeal sphincter, that means it is small only, na? So if the foreign body is below C6 or below the cricopharyngeal sphincter, the foreign body is small, we can just go for observation and serial x-rays beta. Okay, we can just go for observation, and to keep on locating the location basically we can go for serial x-rays. So observation, wait and watch, whatever you say, and you have to repeat serial x-rays beta. Okay. Why? Because we know if the foreign body was able to cross the cricopharyngeal sphincter, that is the narrowest portion, we know it will be able to cross the whole GIT very easily. Okay. So you will just ask the parents beta to give the meshy foods basically beta, okay, which will ensure that the foreign body is easily passed out via the stools of the child beta. Clear about that? Is what is important. So treatment is nothing else but observation along with serial x-rays. Now if this is the picture that you are able to see beta, please let me, in this esophageal foreign body, your answer is basically going to be what? Should I go for an endoscopic removal or should I go for a observation beta? Let me know in the chat box. What should be your treatment in this kind of foreign body beta? Should I go for an endoscopic removal or should I go for a observation? Let me know in the chat box. So here I am not able to calculate the number of cervical vertebra beta, so it is difficult for me to assess whether it is above C6 or below C6. Do remember beta, in these kind of conditions, always check for the clavicle. Clavicle is used basically as a landmark beta that has to be remembered. Samjhe baat? If the foreign body is touching any part of the clavicle, that means it is below C6 beta. Why? This is the clavicle. This is C6 over here. So if the foreign body is touching any part of the clavicle beta, matlab the foreign body is below C6, it has crossed the C6. Samjhe baat? So here as the foreign body is touching the clavicle, that means more probably it is below the C6. The treatment is nothing else but observation. Clear? So in the examination, they are not going to tell you the exact level. You have to find out. Always use clavicle as a landmark. So here as the foreign body is below C6, you just have to go for observation. Samjhe baat? Next important, another foreign body that we have beta, I hope all of you are quite aware, and that foreign body which is there, it is nothing else but a disc battery or a button battery. You might have seen na, those small circular batteries that we usually get in watches or in toys beta. Those are known as disc battery or button batteries beta. हमें पता है that disc battery or button batteries which are there, they are dangerous. They are highly dangerous. Why? Because this disc battery or button battery, they are known to release alkali beta. Okay, and as they release alkali, definitely that is going to cause necrosis, and due to the necrosis there will be a risk of perforation. So if a child has ingested a disc battery or a button battery, do remember these batteries will release alkali and that will increase the risk of perforation in the child. Clear? So therefore, whenever there is a battery, you have to go for an immediate or an urgent removal itself. Okay, you cannot manage the child conservatively if the child has ingested a disc battery or button battery. How to identify an X-ray? I hope all of you might be aware. When I do a X-ray in a case of disc or button battery, yaad rakhna, AP view will give me a very classical appearance. What is the appearance? AP view will give me a very classical appearance called as the double ring sign beta. On the AP view or the antero-posterior view, I get a very classical appearance called as the double ring sign that is seen. Whereas the lateral view which is there, it shows me oblique edges. Bache. Coin mein oblique edges are not seen. But if it is a disc battery or a foreign battery, I will be able to see these oblique edges, and these oblique edges are known as beveling. So lateral view, if I check beta, there will be a beveling which is seen. So do remember 2 points basically over here, that in case if they say X-ray is going to show you which sign in a case of disc battery or button battery. If it is the AP view, I'll be able to see the double ring sign. If it is the lateral view, I'll be able to see the beveling edges. Beta. समझे बात? That is what is important. So double ring sign or beveling is the feature of a disc battery or button battery on the X-ray. Now, if they ask you treatment, we know if it is a disc or button battery, treatment is always an urgent endoscopic removal. And do remember, this endoscopic removal which is done, it is irrespective of the location. That means does not matter beta whether the foreign body is in the trachea or the esophagus, whether the foreign body is above C6 or below C6 beta. Answer is always nothing else but, okay, answer is always nothing else but beta urgent or immediate endoscopic removal, irrespective of the site, irrespective of the location. समझे बात? Next, a classic favorite of your examiner. Obviously, this can be called as Sakari for sure, and that is nothing else but Achalasia Cardia. Now, what is Achalasia Cardia? Completely opposite to that of GERD beta. What was the problem in GERD? हमें पता है in GERD or in gastroesophageal reflux disease, the LES or the lower esophageal sphincter was relaxing frequently beta. बार बार relax करता था lower esophageal sphincter in GERD. बराबर? But if it is a case of Achalasia Cardia, it is completely opposite. Here what happens? The lower esophageal sphincter fails to relax. Okay, whatever you do beta, the LES will not relax itself. ठीक है? अगर LES relax ही नहीं होगा तो what will happen? As the lower esophageal sphincter is not relaxed, it is contracted beta. The patient will not be able to swallow properly, causing dysphagia. Understood? So that is what is important. The Achalasia Cardia mein, the patient will have failure of LES relaxation beta. Patient is going to have failure of LES relaxation. The LES remains in a contracted state. Why this happens? The main causes of primary Achalasia Cardia beta is, one can be loss of ganglionic cells beta. From which plexus of the lower esophagus or which plexus of the GI tract? Let me know. Whether it is the Meissner's plexus or the Orbach's plexus beta. The ganglionic cells are usually lost from which plexus of the GI tract or the lower esophagus? Very good. So the ganglionic cells are usually lost beta in the Orbach's plexus, also known as the Menetrier plexus beta. There is loss of ganglionic cells from the Orbach's, also known as Menetrier plexus. ठीक है? तो if there is loss of ganglionic cells from the Orbach's plexus or the Menetrier plexus, basically, do remember that condition is nothing else but going to cause Achalasia Cardia. Reason, if these ganglionic cells are absent beta, there is no relaxation of the lower esophageal sphincter muscles. That is the reason for Achalasia beta. Second important, if I talk about, it happens due to deficiency of the inhibitory neurotransmitters. Which are the inhibitory neurotransmitters? The two inhibitory neurotransmitter. One is nitric oxide and second is VIP beta. That is vasoactive intestinal polypeptide. So do remember, due to the deficiency of the inhibitory neurotransmitters like nitric oxide and vasoactive intestinal polypeptide, that is another reason why the patient is going to have Achalasia Cardia. Okay? So primary Achalasia will be due to these reasons. One is loss of ganglionic cells and second is deficiency of these neurotransmitters beta. समझे? We know in patients of Achalasia Cardia, the classical triad is, we know as the lower esophageal sphincter is contracted basically beta. What will happen? The food will not be able to pass, so it collects in the upper parts of esophagus. So whenever the patient lies down, there is regurgitation of food beta. The earliest feature is regurgitation of food. Second, as this food gets infected, it emits foul smell. The patient will have bad breath beta, called as halitosis. And third, there is difficulty in swallowing, known as dysphagia. Now do remember, the same triad exactly is also seen in patients of Zenker's diverticulum. But to differentiate, we know beta that in cases of Achalasia Cardia, the dysphagia is continuous. Matlab dysphagia is present all the time. But in cases of Zenker's diverticulum, the dysphagia is intermittent. आता जाता रहता है. ठीक है? Intermittent dysphagia is a feature of Zenker's diverticulum. Continuous dysphagia is a feature of Achalasia Cardia. Hopefully clear to all of you. Now do remember, continuous dysphagia is also seen in esophageal cancer. But how to differentiate? So याद रखना बेटा, in patients of esophageal cancer, there is more dysphagia to solids. Okay, in esophageal cancer, there is more dysphagia to solids. But in cases of Achalasia Cardia, there is more dysphagia to liquids beta. in Achalasia Cardia case, there is more dysphagia to liquids in the patient. That has to be remembered. Understood? Now, whenever any patient comes to us with a complaint of dysphagia beta, the first line investigation that I should do is always a barium swallow. बराबर कोई भी patient with dysphagia के साथ अगर आता है, the first line investigation we do is nothing else but a barium swallow. And when I do a barium swallow beta, a classical picture is seen. What is seen? As the lower esophageal sphincter is contracted over here, you can see beta there is a smooth tapering which is seen, and the smooth tapering or the smooth narrowing which is there beta is classically known as nothing else but the bird beak appearance. The smooth tapering or the smooth narrowing which is there, it is classically referred to as the bird beak appearance beta. That has to be remembered. This bird beak appearance we know is also called as the pencil tip sign. This bird beak appearance which is there is also referred to as the pencil tip sign. Okay, so that is important. Do remember beta, barium swallow showing you the classical bird beak appearance or the pencil tip sign basically is a classical feature of Achalasia Cardia. And this bird beak appearance or pencil tip sign is basically due to smooth tapering of the lower esophagus. It is due to the smooth tapering of lower esophagus. That has to be remembered. Now in a previous year examination, they asked that which kind of sign is seen in patients of Achalasia Cardia beta. Now, neither bird beak appearance was in the option nor pencil tip sign was in the option. Now, some people say that smooth tapering was given in the option. If smooth tapering was the option, I will prefer marking smooth tapering as the answer. If not, then you may go for rat tail appearance as the last choice beta. Okay, last choice will be rat tail appearance because there are some differences between both. Okay? But if nothing is there, then you may mark rat tail. Otherwise, I'll prefer these ones. Clear hai baat hai yahan tak? Now important is if the barium swallow shows you the classical rat tail appearance beta, or if the barium swallow shows you the classical irregular filling defect, that is a feature of which condition? Let me know in the chat box. Rat tail appearance or irregular filling defect on the barium swallow is a feature of rat tail appearance or a irregular filling defect on the barium swallow is a classical feature of nothing else but very good CA esophagus or the cancer esophagus beta. So please remember, okay, the rat tail appearance or the irregular filling defect which is there, it is a classical feature of cancer esophagus or the esophageal cancer basically. That has to be remembered. Whereas if they ask you beta, there was an option in that same question, one of the option was smooth filling defect or regular filling defect. So if they give you an option that is smooth filling defect or regular filling defect, that is a feature of which condition? Let me know in the chat box. Smooth filling defect or regular filling defect. That is seen in which condition? We know. See, irregular filling defect which is there is a feature of esophageal cancer. But agar smooth filling defect पूछा जाए, that is a feature of which condition? Smooth filling defect is a feature of which condition? A benign esophageal tumor beta. And I hope all of you are quite aware that benign esophageal tumor which is there basically is nothing else but known as esophageal leiomyoma beta. The smooth filling defect which is there basically, it is nothing else but esophageal leiomyoma. The benign esophageal tumor which is there beta, it is nothing else but called as esophageal leiomyoma. It is a smooth muscle tumor of the esophagus. समझे बात? स्मूथ टेपरिंग नहीं बोला मैंने, स्मूथ फिलिंग डिफेक्ट बोला है, लाइक दिस. ठीक है, सो दैट इज व्हाट इज द डिफरेंस. समझे? डोंट गेट कंफ्यूज्ड अगेन, आई एम टेलिंग यू. ठीक है, तो स्मूथ टेपरिंग इज अकलेसिया कार्डिया, irregular filling defect is going to be esophageal cancer, and smooth filling defect or regular filling defect is esophageal leiomyoma or a benign tumor. समझे? चलो, now investigation of choice. We know beta in any motility disorder, the investigation of choice is always a esophageal manometry beta. Reason we have to measure the pressure. We know the normal pressure in the lower esophageal sphincter is 8 to 25 millimeters of mercury. Yes, the normal pressure is 8 to 25. But in patients of Achalasia Cardia, as the lower esophageal sphincter is contracted beta, the pressure increases over here. In patients of Achalasia Cardia, the pressure in the lower esophageal sphincter goes between 26 to 100 millimeters of mercury. In Achalasia Cardia, manometry shows a pressure of 26 to 100 millimeters of mercury in the lower esophagus beta. समझे बात? Treatment of choice if they ask you, अपने को पता है there are multiple options. We can use calcium channel blockers, we can go for a balloon dilatation, we can go for an injection of botulinum toxin, We can even perform an endoscopic surgery called as POEMS beta, per oral endoscopic myotomy surgery. But overall, the treatment of choice or surgery of choice is always and always a surgery known as Heller's myotomy or the Heller's cardiomyotomy beta. क्या करते हैं? We usually make a cut or we usually make an incision over the lower esophageal sphincter muscles. As you split this LES muscles beta, these LES muscles will relax, and as the LES muscles will relax, now the food can easily pass beta from the lower esophagus. समझे बात? So the treatment of choice in patients of Achalasia Cardia beta is a surgery known as nothing else but Heller's myotomy. Hopefully clear to all of you now. It is known as the Heller's myotomy surgery. We know due to Heller's myotomy, there can be a risk of GERD beta. If you do a Heller's myotomy surgery, the patient may develop GERD. And to prevent that GERD, a lot of time we also do a prophylactic fundoplication with it. Barabar, a risk of GERD is always seen after this Heller's myotomy surgery. So definitely a lot of times beta, we may have to go for a prophylactic fundoplication as well. If you think there will be a risk of GERD after this Heller's myotomy surgery, then in those conditions, go for a prophylactic fundoplication alongside. समझे बात? चलो. Another motility disorder of esophagus is this one beta. Now what is this motility disorder of esophagus basically? So here we are having a case, nothing else but diffuse esophageal spasm beta. Now in Achalasia Cardia, what is the problem? There is spasm only in the lower esophageal sphincter or only in the lower esophagus. But in diffuse esophageal spasm beta, there is spasm throughout the esophagus. Okay? If there is spasm throughout the esophagus beta, that condition is known as DES or a diffuse esophageal spasm. Do remember, in diffuse esophageal spasm, as the spasm is throughout the esophagus, the pressure is more. And as the pressure is more, the patient will not only complain of dysphagia, but alongside the patient also complains of chest pain beta. Due to excessive pressure, the patient complains of chest pain along with dysphagia beta. As the patient comes to us with dysphagia, we know always the first line investigation is always a barium swallow. And when I do a barium swallow in a patient of diffuse esophageal spasm, I am able to get a very classical appearance beta. This has been a previous year image based question, and that classical appearance which is there is known as the corkscrew appearance, also referred to as the rosary bead appearance. Okay? We know that this appearance that you are able to see is classically known as the corkscrew appearance or the rosary bead appearance beta. So whenever the barium swallow shows me the corkscrew appearance or the rosary bead appearance beta, we know it is a classical case of DES or a diffuse esophageal spasm. Hopefully clear. Now we know in patients of diffuse esophageal spasm, investigation of choice is same, that is a esophageal manometry beta. And when I do an esophageal manometry, you will find the pressure which is there, it is exceeding more than equal to 120 millimeters of mercury. The pressure in patients of diffuse esophageal spasm is more than Achalasia Cardia. The pressure in DES usually exceeds more than 120 millimeters of mercury beta. समझे बात? Treatment की अगर मैं बात करूँ, now here also we have to just go for a myotomy surgery. It is not called as Heller's myotomy, just a myotomy surgery we call it as. We have to make incision or we have to make cuts over the muscle. Q, if you make incision or cut over the muscles beta, these muscles will relax and the esophagus will open up so that the food can easily pass through. Clear about? Chalo. Now another case basically beta, okay, that is they have. Chalo. So if I talk about basically this question first, let's go according to the questions and then I'll come back to images. We are having a 30-year-old male Kamlesh beta. Okay, you might remember him. Okay, so he has grown up. A 30-year-old male Kamlesh who is a chronic alcoholic bache presents to the ER or presents to the emergency room with complaints of chest pain and retching. Retching means the patient feels like vomiting, but no vomitus is actually coming out beta. That is known as retching episodes. He gives history of binge drinking beta. Binge drinking means drinking a lot of alcohol in a very short duration of time bache. Okay? So that is what is known as binge drinking basically. On palpation, a crepitus is felt. Matlab, when you try to palpate the patient's chest beta, you are able to feel a crackling sensation known as crepitus bache. Barabar hai baat? That is what is seen. What is the likely diagnosis? Let me know in the chat box. Whether it is a case of a Boerhaave syndrome or it is a case of Mallory-Weiss Tear. Let me know in the chat box. I've seen a lot of people are always confused between these two topics. So let me know. Very good. So we know basically beta, it is nothing else but a case of esophageal perforation. That is a Boerhaave syndrome beta. Okay, so do remember the diagnosis of this case is nothing else but a Boerhaave syndrome, which that has to be kept in mind. The diagnosis in this case is nothing else but the Boerhaave syndrome that is going to be seen. Understood? So that has to be kept in mind beta. Boerhaave syndrome is the diagnosis. What happens in Boerhaave syndrome? We know as the patient had binge drinking beta, after the binge drinking, the patient will have a lot of retching or a lot of vomiting. And due to that retching or vomiting, the intraesophageal pressure increases. And if the intraesophageal pressure increases too much, तो क्या हो जाएगा? Definitely the esophagus may rupture or the esophagus may perforate. And when the lower esophagus ruptures or the lower esophagus perforates beta, that is what is classically going to cause a Boerhaave syndrome. The Boerhaave syndrome is nothing else but a complete tear or a esophageal perforation which is seen beta. And due to esophageal perforation, the patient will have a classical triad seen beta in Boerhaave syndrome. And the classical triad of Boerhaave syndrome is known as macular striate, which is the Boerhaave syndrome in the classical triad is known as macular striate. Do remember the macular striate of Boerhaave syndrome can be remembered by the mnemonic beta that is known as CVS. When I talk about CVS, basically it is chest pain. Reason? Due to esophageal perforation, the patient may develop mediastinitis. And due to mediastinitis, patient has severe chest pain. Second, V stands for vomiting or retching beta. Vomiting or retching will be seen. And third, as the esophagus perforates, the air goes out of the esophagus and it collects below the skin, causing a subcutaneous emphysema beta. ठीक है, तो याद रखना definitely these are the three features seen over here in the patient. One is chest pain, second is vomiting, third is subcutaneous emphysema. And due to that subcutaneous emphysema, the crepitus is felt beta. समझे बात अभी? That is important. So CVS is going to be the macular striate basically, which is a feature only seen in Boerhaave syndrome. याद रखना, Mallory-Weiss Tear maybe they will give a history of an alcoholic patient itself who recently had a binge drinking. But then what is the difference? They will say patient is alcoholic, patient had binge drinking episode beta, patient had a lot of retching or vomiting. But patient does not have any chest pain over there. Patient does not have any subcutaneous emphysema over there. Patient will not have any crepitus over there. Barabar, all these features are never seen if it is a case of Mallory-Weiss Tear. Mallory-Weiss Tear mein same history is there. But followed by that, patient just has hematemesis or upper GI bleed beta. Nothing else. Clear hai baat? That is important. If I talk about Boerhaave syndrome mein, the first line investigation can be a chest x-ray. And when I go for a chest x-ray, you can see this classical picture. Kya dikh raha hai? As the esophagus has perforated, air has gone into the mediastinum, and due to this pneumomediastinum, you can see a black air shadow below the heart beta. And this black air shadow below the heart is known as the continuous diaphragm sign. So this continuous diaphragm sign, due to pneumomediastinum which is there, it is also a feature seen in patients of Boerhaave syndrome. It is never seen in Mallory-Weiss Tear beta. समझे बात? Continuous diaphragm sign is only a feature of Boerhaave, never seen if a patient is suffering from Mallory-Weiss Tear. Hopefully clear. And auscultation will let the Hammond-Krun sign beta. Yes, very good. Now, if they ask you investigation of choice, see, X-ray can be the first line investigation, but investigation of choice is a CECT or a contrast enhanced CT scan beta. So CECT or a CT with oral contrast is the investigation of choice, and you will find beta that from wherever the esophagus is perforated, the contrast will leak out from that part of the esophagus. That will confirm your diagnosis that it is a case of Boerhaave syndrome or an esophageal perforation. Treatment, we know. As this patient is having a esophageal perforation, patient may be hemodynamically unstable. So what should be your first line treatment? Let me know in the chat box. If they say a case of esophageal perforation or a Boerhaave syndrome, my first line treatment is going to be very good. Shabash. The first line treatment is to stabilize the patient beta. Okay. And that is nothing else but basic resuscitation. The first line treatment is take care of the patient's airway, breathing and circulation beta. So basic resuscitation has to be your first line treatment. Okay, give IV fluids and everything to the patient. That is the first line treatment. After this beta, then the definitive treatment if I talk about, yaad rakhna, definitive treatment is what? You have to go for surgery. In surgery, the first thing is nothing else but we should go for a emergency thoracotomy beta. As the esophagus has perforated, I have to open the thorax. That is nothing else but a emergency thoracotomy to be done. Along with emergency thoracotomy, as there is mediastinitis, I have to clean the mediastinum beta. And cleaning of mediastinum is known as mediastinal lavage. Along with that, I may also have to go for a repair beta. I may also have to go for a repair that has to be kept in mind. Samjhe baat? Now, another case that you have to remember is, here there's a question which states, patient is having a right aberrant subclavian artery beta, and this right aberrant subclavian artery, this is another diagnosis, right aberrant subclavian artery beta, it compresses the esophagus, and that is going to lead to which condition? Let me know in the chat box. A patient comes to you with dysphagia. As the patient is having dysphagia, you go for a barium swallow. When I do a barium swallow, you can see this picture. Here there is a right aberrant subclavian artery which is compressing the esophagus from outside, and that is the reason why the patient is having dysphagia. Yes. So this condition which is there, beta, it is classically known as nothing else but Dysphagia Lusoria. So Dysphagia Lusoria ka matlab, when there is a right aberrant subclavian artery which is actually going to compress the esophagus from outside beta. And as the esophagus is compressed from outside, the patient has difficulty in swallowing beta. That is known as nothing else but Dysphagia Lusoria. Samjhe baat? Next is this question over here beta. It states, we have an elderly patient who presents to us with complaints of regurgitation. Along with regurgitation, basically beta, patient is also having bad breath, that is known as halitosis, and the patient is having intermittent dysphagia beta. Okay. On pressing the neck swelling. Now, neck swelling is rare in this scenario, but in case if a neck swelling is present, so on pressing the neck swelling beta, a gurgling sound is heard. I have told you in ENT itself that day. So when you press the neck swelling beta, a gurgling sound is heard, like this kind of sound is going to be heard beta. That is classically known as which sign? When you press the neck swelling and that leads to a gurgling sound, that classically happens due to the escape of fluid, which is known as which sign? Anybody? That is classically referred to as the Boyce sign beta. Yaad rakhna, that is classically referred to as nothing else but the Boyce sign, has to be kept in mind. Barabar hai baat? And we know if Boyce sign is there along with regurgitation, halitosis, and most importantly a feature of intermittent dysphagia, so we know it is a classical case of nothing else but, all of you are right, it is a classical case of Zenker's diverticulum, which is also known as the pharyngeal pouch beta. We know it is a case of Zenker's diverticulum, also known as pharyngeal pouch. Let me know in the chat box beta. We know Zenker's diverticulum is nothing else but outpouching from the esophagus beta. Zenker's diverticulum, also called as the pharyngeal pouch, it is an outpouching from the esophageal wall basically. So the Zenker's diverticulum is a true or a false diverticulum? Let me know in the chat box. ये जो Zenker's diverticulum होता है, that is a true or false diverticulum? Let me know in the chat box. So we know basically if the diverticulum has all the layers in the wall, that is mucosa, submucosa, muscularis, it is a true diverticulum. But if any of the layer is missing, that is a false diverticulum. Very good. So Zenker's is basically an example of false diverticulum beta, because muscle layer is going to be absent in Zenker's diverticulum. It is an example of false diverticulum. Second important, it is a pulsion or a traction diverticulum. Traction means a diverticulum which happens due to a pull from outside. Pulsion means a diverticulum which is created due to increased pressure. So when there is an increased intraesophageal pressure, then the wall gets pushed outside, leading to formation of an outpouching or diverticulum. So we know Zenker's basically is an example of a pulsion diverticulum beta. Zenker's is an example of a pulsion diverticulum, has to be remembered. Shabash. Now do remember beta, we know that Zenker's diverticulum arises between two muscle fibers. That is the muscle fibers of inferior constrictor muscle called as the thyropharyngeus and the cricopharyngeus. We know between the thyropharyngeus and cricopharyngeus muscle fiber there is a triangular dehiscence beta, and we all know that this triangular dehiscence which is there, it is classically called as Killian's dehiscence beta. This triangular dehiscence which is there is known as the Killian's dehiscence, and from Killian's dehiscence itself beta, This outpouching which arises is classically known as your Zenker's diverticulum. Clear? So that is what is important. So most common site for Zenker's diverticulum, if they ask you, answer is nothing else but Killian's dehiscence. In a PYQ and FMGE exam, they also asked you that Zenker's diverticulum arises between which two muscle fiber. So yaad rakhna, we know Zenker's diverticulum usually arises between the two muscle fiber. One is known as thyropharyngeus and second is known as cricopharyngeus. So Zenker's diverticulum arises between the two muscle fibers known as thyropharyngeus and cricopharyngeus, and it arises from the Killian's dehiscence or the Killian's triangle beta. समझे बात? That is what is important. ठीक है? Next important, if I talk about basically, and that is nothing else but beta, investigation of choice if they ask you. Do remember, investigation of choice in patients of Zenker's diverticulum is nothing else but barium swallow beta. Investigation of choice in the patient is nothing else but barium swallow basically. That has to be kept in mind. If I talk about basically beta, the barium swallow, you are able to see the classical picture. क्या दिख रहा है? Here you can see there is an outpouching from the posterior wall of the esophagus. And this outpouching from the posterior wall of esophagus is known as your Zenker's diverticulum or the pharyngeal pouch beta. It has been a previous year image-based question in the FMG, so do remember this. Apart from this, do remember beta that if barium swallow doesn't help you to make a diagnosis, then for confirmation, I may also go for a CT with oral contrast or a CECT as well. But usually majority cases mein barium swallow is going to work better. Yes, that is important. Now treatment of choice if they ask you. Do remember, if the Zenker's diverticulum is large in size beta. Let's say if the Zenker's diverticulum is large in size, that is more than 2 to 4 centimeter. If the Zenker's diverticulum is large in size, that is more than 2 to 4 centimeter, I can go for a procedure that is classically known as Dohlmann's operation beta. I can go for a surgery or I can go for a procedure classically known as the Dohlmann's operation. What is Dohlmann's operation? It is a diverticulo-esophagostomy. The Dohlmann's operation that we perform is basically nothing else but beta or diverticulo-esophagostomy. क्या करते हैं इसमें? Here definitely beta, we remove the wall between the diverticulum and the esophagus. As you remove the wall between the diverticulum and the esophagus, basically beta, what happens is, see, let's say this is my Zenker's diverticulum which is seen. So what I'm going to do is, we excise this wall between the diverticulum and the esophagus with the help of linear stapler. So now the diverticulum becomes a part of the esophagus itself beta. So now there will not be any collection of food, there will not be any kind of regurgitation, no halitosis, no dysphagia, nothing is going to be seen. So this diverticulo-esophagostomy which is there beta, that is known as Dohlmann's operation, and it is considered as the best treatment done basically for a large Zenker's, usually more than 2 to 4 centimeters in size beta. समझे बात? If it is basically beta, a small Zenker's diverticulum, usually less than 2 to 4 centimeter in size. Better you can contact the team basically, they may provide you some link from where you can download maybe. That is the only advice I could give you. ठीक है? If it is small in size beta, that is less than 2 to 4 centimeters basically. If it is less than 2 to 4 centimeter, do remember beta, we can go for a surgery called as a cricopharyngeal myotomy. Okay, we can go for a procedure known as a cricopharyngeal myotomy plus minus diverticulectomy beta. Now what is this procedure? Here basically beta, what we do is, understand, just a minute, we have to go for a cricopharyngeal myotomy plus minus diverticulectomy. That is, do remember, here what we do is, this cricopharyngeus muscle, the circular muscle which is there, we are going to make incision or we are going to make a cut over this muscle. As you make an incision or cut over this cricopharyngeus muscle, it will relax beta. As this cricopharyngeus muscle is going to relax, the pressure in the esophagus decreases, and a lot of times you will find beta, after performing a cricopharyngeal myotomy, the diverticulum goes back into the normal position. A lot of times it happens that it goes back in the normal position again. But in case if it doesn't go back beta, then I have to remove it or then I have to excise it, called as diverticulectomy. ठीक है? तो small Zenker's diverticulum में I can go for a procedure known as cricopharyngeal myotomy plus minus diverticulectomy beta. ठीक है? Next important is a case, and that is nothing else but of upper GI bleeding or upper GI hemorrhage beta. Now I hope all of you are quite aware that the gastrointestinal hemorrhage or the gastrointestinal bleeding can be classified into two types, beta. One is basically known as the upper GI hemorrhage and second is known as the lower GI hemorrhage. Anybody, what is the landmark which will help us to differentiate whether it is a upper GI hemorrhage or the lower GI hemorrhage? This was a PYQ and FMGE exam. Let me know. What is that anatomical landmark, beta, above which you say there is the upper GI bleed and below which you say there is a lower GI bleed? कौन सा landmark होता है वो? Let me know. Very good, shabash. So do remember, beta, that landmark that we have is classically known as the ligament of Treitz, beta. And when I talk about ligament of Treitz, that means any bleeding above this ligament of Treitz which is there basically is known as your upper GI bleeding. Any bleeding below the ligament of Treitz which is there, beta, it is known as your lower GI bleeding. समझे बात? तो ligament of Treitz is the landmark, beta, that has to be remembered. ठीक है? Now if I talk about the most common cause of upper GI bleeding or the upper GI hemorrhage, do you remember the commonest cause of upper GI bleeding or upper GI hemorrhage is nothing else but PUD or the peptic ulcer disease, beta. The commonest cause of upper GI hemorrhage is nothing else but PUD or the peptic ulcer disease basically, followed by peptic ulcers. The second most common cause of upper GI bleeding is gastritis. So leading cause of upper GI hemorrhage, beta, is PUD or peptic ulcer disease, followed by that the second most common cause is going to be gastritis. That has to be kept in mind. There are multiple other causes for a case of upper GI hemorrhage, beta, but the leading cause is definitely peptic ulcers followed by gastritis. Now if they ask you basically that in lower GI hemorrhage what are the cause, so we know lower GI hemorrhage ka cause is different in an adult and a child, beta. The most common cause of lower GI hemorrhage in an adult, most common cause of lower GI hemorrhage in an adult is nothing else but hemorrhoids or pile, beta. Please remember the most common cause of lower GI hemorrhage in adults is basically hemorrhoids or piles basically. Whereas if they ask you most common cause of lower GI hemorrhage in children, the commonest cause of lower GI hemorrhage in children, beta, the answer is nothing else but rectal polyps. The most common cause of lower GI hemorrhage in children, answer is nothing else but rectal polyps. ठीक है? Adults में the most common cause of lower GI bleed is known as rectal polyp. Adults में the most common cause of lower GI bleed is known as hemorrhoids or piles. In children में the most common cause of lower GI bleed will be rectal polyps, beta. Let me know one point basically in the chat box, and that is melena is a feature of upper GI hemorrhage or lower GI hemorrhage. The black tarry stools or melena is a feature of upper or lower GI hemorrhage. Let me know in the chat box. Okay, the black tarry stools or melena is a feature of upper or lower GI hemorrhage. Let me know in the chat box. Very good. That is what is important to be remembered, beta. Yaad rakhna. Whenever they say hematemesis, that is blood and vomiting, ठीक है, or whenever they say melena, that is black tarry stool, both of these are features of upper GI hemorrhage itself, beta. That has to be kept in mind. समझे बात? Whereas lower GI hemorrhage में there will be fresh blood in stools, not black tarry stools. समझे बात? Lower GI hemorrhage में there is going to be the fresh blood in stool known as hematochezia. So hematochezia, that is fresh blood in stool, that is a classical feature of nothing else but lower GI hemorrhage, beta. Hopefully clear to all of you now. Yes, that is what is important. Do remember this. Now we know the leading cause of upper GI bleeding is peptic ulcers, beta, followed by gastritis. But another cause for upper GI hemorrhage is this one over here. Now what is seen over here, beta? It is this. We are having a young alcoholic patient, beta, and this young alcoholic patient comes to us after a binge drinking episode again. Okay, he comes to us after a binge drinking episode, that is drinking a lot of alcohol in a shorter duration of time. And now the patient presents to you with complaints like vomiting or retching. Along with that, there is hematemesis, that is blood in the vomitus, and somewhat pain may be there. Okay, what is the classical diagnosis? So do remember, beta, same history. Alcoholic patient, binge drinking episode, a lot of retching or vomiting. But this time, no chest pain. This time, no subcutaneous emphysema, no continuous diaphragm sign, no Hammond-Krun sign. If none of these features is there, only upper GI bleeding or hematemesis is there. Yes, very good. It is a partial tear in the esophageal wall, bache, and that partial tear in the esophageal wall is known as Mallory-Weiss tear. समझे बात? So after the same history, if macular striatum was present, we call it as a case of Boerhaave syndrome. But after the same history, if only hematemesis is present, we call it as a case of Mallory-Weiss tear beta, which is a partial tear in the lower esophagus beta. That is important. Let me know in the chat box which is the most common vessel to bleed in a patient of Mallory-Weiss tear beta. If they ask you which is the most common vessel to bleed if a patient is suffering from Mallory-Weiss tear, let me know in the chat box the answer. So we know in cases of Mallory-Weiss tear, basically beta, the investigation of choice is an upper GI endoscopy. And when I do a upper GI endoscopy, this is the classical presentation. From the lower esophageal sphincter or from the gastroesophageal junction, you are able to see a longitudinal tear or a vertical tear beta in the esophageal wall. And this partial tear in the esophageal wall is known as your Mallory-Weiss tear beta. Very good. The most common vessel to bleed in a patient of the Mallory-Weiss tear is the left gastric artery beta. The commonest vessel to bleed over here is left gastric artery. Yaad rakhna. Left gastric artery is the commonest vessel to bleed in 3 conditions. Yes, left gastric artery is the commonest vessel to bleed in 3 conditions. 1, Mallory-Weiss tear. 2nd, gastritis. And 3rd, gastric ulcers beta. Okay? 1 is Mallory-Weiss tear. 2nd is gastritis. And 3rd is gastric ulcers. These are the conditions basically beta where the left gastric artery is the commonest vessel to bleed. No, esophageal varices में it is the left gastric veins, not the artery which bleeds. समझे बात? That is important. Treatment, if they ask you basically beta, to do remember one point that the first line treatment is nothing else but basic resuscitation. I always tell you to remember one thing beta, any patient who is hemodynamically unstable, any patient who is in shock, any patient who comes to you with ongoing bleed, any patient who comes to you with ongoing seizure, any patient who comes to you after trauma, any patient who is unconscious, in all these cases, first line management is always basic resuscitation beta or stabilization of the patient. Ongoing bleeding, ongoing seizures, unconscious, trauma, shock, unstable. All these cases, my first line treatment is always basic resuscitation beta. That has to be remembered. Take care of the patient's airway, breathing, circulation, give IV fluids and all. Now, majority cases of Mallory-Weiss tear beta, they don't need any kind of treatment. Why? Because most of the cases spontaneously resolve. अपने आप bleeding रुक जाती है. तो majority cases of Mallory-Weiss tear में there is no treatment needed. Majority of them resolve spontaneously beta. Yes, some cases which will not resolve, over there we go for a angioembolization beta. Few cases which do not resolve, we go for an angioembolization in those cases. Clear about? Another cause for upper GI bleeding beta, that cause for upper GI bleeding is this one over here. What is seen? It is a case of Menetrier disease beta. If I talk about Menetrier disease, it is due to which chemical mediator? Let me know in the chat box. Menetrier disease में beta, there is hypertrophy of this gastric folds beta, or there is hypertrophy of this gastric rugae. And as these gastric rugae have undergone hypertrophy beta, you are able to see the classical giant gastric rugae beta. Barabar, as these gastric rugae have been hypertrophied, you are able to see a classical picture of a giant gastric rugae. And this hypertrophied giant gastric rugae gives you a cerebriform appearance or a brain-like appearance. Barabar, in the stomach, these hypertrophied gastric rugae gives you a very classical cerebriform appearance or a brain-like appearance beta, has to be remembered. Hopefully clear. Now I hope all of you are quite aware beta. Yes, this Menetrier disease which is there, it is due to a chemical mediator known as TGF alpha. So it is basically due to a chemical mediator known as TGF alpha or a transforming growth factor or tissue growth factor alpha beta. This TGF alpha is known to cause hypertrophy of this gastric rugae, leading to formation of this giant gastric rugae basically. Clear? Now, due to this, the patient will have two problems. One, the patient is going to have protein loss from the body, and due to protein loss, the patient will develop edema beta. The patient will develop edema. Second, patient develops metabolic acidosis. As there will be loss of bicarbonates beta, patient will develop metabolic acidosis over here. Clear? And the patient will have upper GI bleeding or hematemesis, obviously. Apart from that, do remember that this condition, Menetrier disease, is a pre-malignant condition beta. Why it is pre-malignant? Because, yes, it increases the risk of nothing else but gastric cancer or the gastric adenocarcinoma. Menetrier disease is going to have a very, very high risk of gastric adenocarcinoma beta. That is what is important. if they say in patients of Menetrier disease, the histopathological examination shows you which feature. So yaad rakhna, the confirmatory diagnosis of Menetrier disease can be done with the help of biopsy or histopath, where I'll be able to see a classical hyperplasia of foveolar epithelium beta. In a case of Menetrier disease, if you do a histopath, on that you are able to see a classical picture that is nothing else but hyperplasia of foveolar epithelium is going to be seen beta. That is what is important. The hyperplasia of foveolar epithelium confirms the diagnosis of Menetrier disease बच्चे. ठीक है? Do remember treatment in patients of Menetrier disease. Initially you can manage the patient with cetuximab. A drug basically known as cetuximab can be given in the initial management of Menetrier disease, but if the patient's condition progresses further, if the patient's condition is progressing further, it's better to go for a surgery known as gastrectomy beta, because it is a pre-malignant condition, so it's better to go for a surgery known as gastrectomy. Hopefully clear to all of you now. Chalo. So these are the points beta that you have to remember about Menetrier disease. Next is a question again, the cause of upper GI bleeding or upper GI hemorrhage beta. Here the case is what? Again we are having an alcoholic male patient beta who is a known case of CLD. What is CLD? Chronic liver disease, also called as cirrhosis. In a previous year examination when this question came, they only mentioned CLD beta, they did not mention cirrhosis. So patient is a known case of CLD, that is chronic liver disease or cirrhosis beta, and the patient presents to you with complaints of hematemesis. What is the likely diagnosis? Let me know in the chat box beta. What is the likely diagnosis over here? If this is the case which is going to be asked beta, alcoholic patient coming to you who is a known case of CLD or cirrhosis, now coming to you with complaints of hematemesis. The diagnosis has to be very good. Yes, the diagnosis has to be nothing else but esophageal varices beta. Now, do remember a lot of people marked Mallory-Weiss Tear as the answer for this question. In Mallory-Weiss Tear, yes, the patient will be a chronic alcoholic beta. But Mallory-Weiss Tear mein, please remember, there should be a history of binge drinking. Is there any history of binge drinking given in the question? No. Second, Mallory-Weiss Tear mein, there should be a history of retching or vomiting. Is there any history of retching or vomiting given in the question? No. So if there is no binge drinking, no retching or vomiting, please remember, it is more likely to be a case of esophageal varices. And we know why does it develop? Okay, patient who is a known case of CLD or cirrhosis beta is obviously going to develop a complication called as portal hypertension. And as the patient develops portal hypertension, due to this portal hypertension, patient develops esophageal varices. क्या होता है? Due to cirrhosis, patient is having portal hypertension, and as the pressure in the portal circulation is more, the pressure in this lower esophageal veins will also increase beta, because these veins drain into the portal circulation. So therefore the pressure in these lower esophageal veins increases, and you can find that these lower esophageal veins which are there, the left gastric veins which are there, they have got dilated and tortuous. And we know whenever the veins or vessels become dilated and tortuous beta, that is classically going to form the varicosities or varices. So this is what is known as esophageal varices. If this esophageal varices beta dilate too much, they may rupture, causing an upper GI bleeding or hematemesis. Clear? Do remember 2 points over here, that is, these esophageal varices which are there, they usually form at a pressure of more than 10 millimeters of mercury beta, and they usually bleed at a pressure of more than 12 millimeters of mercury. That has been a question, so be aware of this. So they form at a pressure of more than 10 millimeters of mercury, and they bleed at a pressure of more than 12 millimeters of mercury are the points to be remembered. समझे बात? Investigation of choice. Do remember beta, investigation of choice in this patient is nothing else but an upper GI endoscopy. As you are able to see on the upper GI endoscopy in the lower esophagus, we are able to see this dilated tortuous veins called as esophageal varices beta. Now treatment की अगर बात करेंगे, again patient has been brought to us in the emergency with ongoing bleed, and as the patient is having ongoing bleeding, patient may be hemodynamically unstable. So first line management has to be a basic resuscitation. Always try to stabilize the patient by taking care of the patients A, B, C. Give IV fluids to the patient if necessary. Barabar? After the patient has been resuscitated beta, then the definitive management is, we can go for the medical management And the drugs which are known to stop the bleeding in esophageal varices, beta, one is going to be IV octreotide, and even a better agent is IV terlipressin, beta. One is IV octreotide and second is IV terlipressin. Either of this drug can be given, beta. Octreotide de do, terlipressin de do. Terlipressin is better. Next important, let's say if you have tried octreotide or terlipressin, still the patient's condition does not improve, beta. So in those conditions, you have to go for procedures like, one is called as banding, the second is known as sclerotherapy. क्या करते हैं? In banding, we apply a band basically at the base of the varices, beta. If you apply a band at the base of the variceal mass, the variceal mass will not receive any blood supply and it will shrink in size, beta. So that is what is known as banding or a band ligation, beta. Barabar? So endoscopic banding or endoscopic band ligation has to be done over here. Another option is nothing else but sclerotherapy. What we do in sclerotherapy, at the base of this variceal mass, we inject a sclerosing agent. And I hope all of you know the most common sclerosing agent that we use in varicose veins, in esophageal varices, or in hemorrhoids, beta. That sclerosing agent is 3% sodium tetradecyl sulfate. Very good. Yes, that agent is 3% sodium tetradecyl sulfate, beta. That has to be remembered. Samjhe baat? So I will inject that sclerosing agent which causes fibrosis. And that leads to again shrinkage of the mass, beta. That is what is important. Samjhe baat? So either banding or sclerotherapy can be tried. If banding or sclerotherapy also doesn't help, beta, the last option that we have in a case of bleeding esophageal varices is known as TIPS, bache. What is TIPS? TIPS is nothing else but transjugular intrahepatic portosystemic shunt. Okay, transjugular intrahepatic portosystemic shunt. Matlab, we place a graft or we place a shunt between the portal veins and the hepatic veins, beta. So between the branch of portal vein and hepatic vein, you make a connection or you place a graft, beta, so that blood from the portal vein goes into the hepatic vein and the pressure in the portal circulation decreases, beta, and the bleeding stops. But till basically the surgery is performed or till the TIPS is performed, beta, the bleeding is going to be controlled with the help of a tube called as the Sengstaken-Blakemore tube. Okay, I hope you all know this. Sengstaken-Blakemore tube is a tube with two balloons, beta, a esophageal and gastric balloon. You insert this tube in the GI tract and you inflate the balloons, beta. These balloons will exert pressure on the wall and it will help to stop the bleeding or to control the bleeding till the surgery at least. Samjhe baat? Chalo. Next important is this question over here, beta. Okay. And what is this case over here? It says we are having a 4-week-old male newborn, beta. Okay, and this 4-week-old male newborn was brought to you with complaints of a projectile non-bilious vomiting. That is a non-bile containing vomiting, beta. On feeding, the peristalsis is visible. You may see peristalsis in the epigastrium from left to right side, beta. And when you palpate, you are able to feel a olive-shaped mass or olive-shaped lump basically in the epigastric region. Okay, they are asking you his mother would have taken which drug basically during her pregnancy, due to which this complication or this disease has developed. First of all, let me know, we know what is going to be the drug that the mother might have taken. Anybody? So we know here there is a 4-week-old newborn, beta, who has been brought to us with complaints of a non-bilious vomiting basically. Okay? And there is an olive-shaped lump or olive-shaped mass which is felt. This is a classical features seen in a patient suffering from CHPS or a congenital hypertrophic pyloric stenosis, beta. Apne ko pata hai that congenital hypertrophic pyloric stenosis is nothing else but when there is hypertrophy of the pyloric muscles, beta, and if there is hypertrophy of the pyloric muscle, what is going to happen? The gastric outlet will get obstructed or the gastric outlet will get blocked. And obviously, if the gastric outlet will get blocked, beta, there will be regurgitation of food, which will cause chronic vomiting in the child. Okay? So that is what is important to be remembered, which is clear. Thank you so much. Very good. It is erythromycin, beta. Yaad rakhna. The mother basically has taken erythromycin drug during the pregnancy. As the mother has taken erythromycin drug during the pregnancy, beta, that is the reason why the baby has developed this congenital anomaly or this congenital defect bache called as CHPS. Okay? So erythromycin is the drug that is basically responsible for causing hypertrophic pyloric stenosis, beta. Clear? And we know congenital hypertrophic pyloric stenosis mein, as this pyloric muscles you can see have undergone hypertrophy, that causes a functional gastric outlet obstruction. And as it causes a gastric outlet obstruction, beta, therefore the child has regurgitation causing a non-bilious vomiting. Now, do remember the symptoms in cases of CHPS only develop after 2 to 3 weeks of life. Yes, in CHPS, the symptoms do not develop immediately at birth. Okay? So, if the symptoms appear after 2 to 3 weeks of life and the symptom is non-bilious vomiting, think about a case of CHPS or hypertrophic pyloric stenosis. But if they say, beta, let me know in the chat box now. If they say the patient is brought to you or the neonate is brought to you immediately at birth with a bilious vomiting or a bile containing vomiting, then the diagnosis is likely to be, let me know in the chat box, beta. If they say the child is basically brought to you immediately at birth, not after 2 to 3 weeks, and that too with a bilious or a greenish vomiting, then it is a case of, very good, then it is a case of duodenal atresia, beta. Okay? So after 2 to 3 weeks, non-bilious vomiting, CHPS. Immediately at birth, bilious vomiting, duodenal atresia. Clear a difference? That is what is important. Now, we know in cases of CHPS, as the child will have chronic vomiting, beta, the patient will definitely is going to develop, beta, a metabolic disturbance. And that metabolic disturbance is going to be this one. This has been asked. Patient will have a hypochloremic, hypokalemic, hyponatremic, metabolic alkalosis, beta, along with paradoxical aciduria. Okay? This is the metabolic disturbance. The question on this metabolic disturbance has been asked. So it is hypochloremic, hypokalemic, hyponatremic, metabolic alkalosis with paradoxical aciduria, beta. Clear about? So do remember these points, that has to be remembered. Now in patients of CHPS, beta, initially I can go for a X-ray abdomen or a barium meal. Yes, I'm saying barium meal because we are talking about stomach now. And when I do, when I talk about the barium meal, we are able to see the two classical signs, beta. The first sign that I'm able to see over here is this. Here you can see this is the narrow pylorus or the narrow pyloric lumen, which appears like the string, beta. Barabar? So one, I'm able to see the classical string sign. Barium meal may show me the classical string sign. And second is this. Here you can see, beta, as soon as the contrast goes or the barium goes in the duodenum, it appears like a mushroom basically. Okay? So do signs which are seen on the barium meal, beta, in a case of CHPS. One is going to be the mushroom sign and second is going to be the string sign. These are the two classical signs, beta, seen on the barium meal in a patient suffering from CHPS. Whereas if I do a X-ray abdo, beta, on X-ray abdomen, this is the classical sign seen. We know here only gastric bubble is visible, bache, and that is the reason we call it as the single bubble sign. As only gastric bubble is going to be visible over here, we classically refer it to as the single bubble sign, beta. That has to be kept in mind. No issues with this, anybody? Now please let me know in duodenal atresia, X-ray abdomen will show you which sign basically. Let me know in the chat box. In cases of duodenal atresia, the X-ray abdomen shows you which sign. Let me know in the chat box. Very good. It is the classical double bubble sign, beta. Yaad rakhna. Single bubble sign, CHPS. Double bubble sign, duodenal atresia, annular pancreas, and Ladd's band, beta. Double bubble sign is seen in duodenal atresia, annular pancreas, and Ladd's band. Triple bubble sign, jejunal atresia. Triple bubble sign is a feature of jejunal atresia. And lastly, multiple bubble sign is a feature of aerial atresia, beta. Multiple bubble sign is a feature of aerial atresia. Samjhe baat? That is important to be remembered. Now, we know any abdominal problem in children, the investigation of choice is usually an ultrasound abdo. Whereas any abdominal problem in adults, the investigation of choice is usually a CECT abdo. Clear hai baat? So this is usually followed, beta, majority conditions में. One or two conditions can be exception, otherwise ये rule follow होता है. बच्चों में go for ultrasound, adults में go for CECT. ठीक है? So investigation of choice is an ultrasound abdo, beta. And when I'm going to do an ultrasound abdomen, you are able to see that the pylorus which is there, it is extremely thick. And the pyloric thickness is more than 4 millimeter, beta. The pylorus is very thick. The pyloric thickness is usually more than 4 millimeters. That has to be remembered. That confirms your diagnosis, beta. Clear hai? Now, as the child has been brought to us in a case of chronic vomiting with a lot of electrolyte disturbances and dehydration, the first step is always giving IV fluids to the child, beta. We know the IV fluid of choice that we should give in this patient is nothing else but beta. We have to give a half normal saline, that is 0.45% NaCl plus 5% dextrose for nutrition. Okay, plus 5% dextrose for nutrition plus minus KCl, that is potassium chloride, can be given alongside. So half normal saline plus 5% dextrose plus minus KCl beta. This is the fluid of choice that I will prefer to be given in a patient of CHPS bachche. Now, in a previous year examination, this fluid was not an option. Half normal saline plus 5% dextrose with or without KCl was not an option. So in those conditions, basically, the second best answer is normal saline. Then. If this fluid is not an option, the second best option is NS, that is normal saline beta. Please let me know in the chat box. Yesterday itself I've told you which fluid has to be avoided or which fluid is contraindicated if the patient is suffering from CHPS beta. Which fluid has to be avoided or it is contraindicated if a child is suffering from CHPS? Let me know in the chat box. Very good, shabash. We know beta, we have to avoid the fluid known as RL, that is Ringer's lactate beta. Reason? We know when the lactate is broken down, it releases bicarbonates, and bicarbonates are alkaline in nature. Already the child is suffering from metabolic alkalosis beta. Do you want to worsen the metabolic alkalosis? No. That's the reason definitely beta. Better is to avoid using Ringer's lactate in the patient beta. That has to be remembered. Clear? Now, after this you have to take up the child for surgery. PYQ tha, which electrolyte disturbance you are going to correct in the child before surgery. Do remember beta, we have to correct hypokalemia, that is low potassium, and hypochloremia, that is low chloride levels beta. So hypokalemia and hypochloremia will be the priority in which basically beta we have to correct the electrolyte disturbances before surgery. If you do not correct the hypokalemia beta, patient will have a high risk of paralytic ileus after the surgery. समझे बात? तो इसीलिए we have to correct the hypokalemia for sure. Treatment of choice अगर पूछेंगे तो we know beta, treatment of choice is nothing else but a surgery called as a Ramsted's pyloromyotomy beta. The surgery which is there basically is nothing else but called as a Ramsted's pyloromyotomy. That is nothing else but beta. Do remember we have to make an incision over the pyloric muscle. As you make incision over the pyloric muscles beta, these pyloric muscles are going to relax, and as the pyloric muscle relax, the pyloric outlet opens up or the gastric outlet opens up, and there will be a proper drainage of food from stomach into the duodenum beta. Okay, so Ramsted's pyloromyotomy has to be done. No issues with this. Next is the question basically beta, and that states we are having a young female, and this young female was brought to us with complaints of chronic abdominal pain, and after that you have planned a surgery. Once you have planned a surgery beta, this given collection was retrieved or it was removed from her stomach basically beta. What is this given collection you are able to see from her stomach? This collection from her stomach basically is nothing else but collection of hair beta. Obviously normal individuals are not going to eat hair, so she is suffering from a psychiatric disorder beta, and therefore she has eaten up this hair basically, and that's the reason these hairs have collected in the stomach beta. So it is a classical diagnosis of nothing else but trichobezoar beta. Barabar, it is a classical diagnosis of nothing else but a condition known as trichobezoar. Do remember this problem. Okay, collection of substances in the stomach is known as bezoar, and if those if that substance is hair, then we call this condition as a trichobezoar. Do remember beta, trichobezoar happens if the female is suffering from a psychiatric disorder known as trichotillomania. Okay, trichotillomania mein this female is going to have an irresistible urge or irresistible desire to pull out her own hair. वो खुद के बाल नोचती है बेटा, ठीक है? And as she will pull out her own hair, that is trichotillomania. After that, she will eat those hair, that is trichophagia. And due to trichophagia, this collection will develop known as trichobezoar. Treatment has to be a surgical removal beta. But after that, we are going to refer the patient to very good. We have to refer the patient to a psychiatrist beta, and this was a previous year question. So after removing this trichobezoar from her stomach beta, always refer her to a psychiatrist or for a psychiatric consultation beta, ठीक है, to treat the trichotillomania disorder. समझे बात? Now if I talk about bariatrics beta, what is bariatrics? The surgeries which are done for the purpose of weight loss. After that you can take your break. If I talk about the bariatric surgeries, basically beta, the first one, identify what is this bariatric surgery done. So as I've told you, bariatric surgery matlab the surgery that is done for the purpose of weight loss beta. ठीक है, तो bariatric surgery or the metabolic surgery is the surgery is done for the purpose of weight loss. It is usually done beta whenever the patient has tried lifestyle modifications, pharmacotherapy, psychotherapy, almost everything, but still the patient cannot lose the weight beta. In those conditions, we go for bariatric surgery. It can be done if the patient is morbidly obese, that is, whenever the patient's BMI or body mass index is more than 40. So whenever the patient's BMI or body mass index is more than 40 beta, with or without comorbidities, then you can surely go for a bariatric surgery in this patient. ठीक है. Now very good, the first bariatric surgery that you can see beta, क्या दिख रहा है इसमें? You can see that we have used a linear stapler, and with the help of linear stapler you have cut the stomach along the greater curvature. As you cut the stomach along greater curvature beta, this part is removed and a part of stomach which is left behind, it is looking like a sleeve beta. Therefore this procedure that you are able to see, or the surgery that we are able to see, is known as a sleeve gastrectomy. And do remember, sleeve gastrectomy is the most common bariatric surgery done till date. Okay, so sleeve gastrectomy is the commonest bariatric surgery done beta nowadays. Okay, here we use a linear stapler and cut out the stomach so that the size of stomach will decrease, so the patient's appetite will also decrease beta, and definitely the patient will have weight loss. If appetite is less, obviously the patient will have weight loss. Next important is this bariatric surgery. क्या किया इसमें? Let me know the name of the surgery. What we have done? We have just made a gastric pouch, but as you can see, we have just made a gastric pouch and we have pulled up a jejunum and we have connected a jejunum directly to this gastric pouch. So now what will happen? The food will come from the esophagus to this pouch and it will immediately enter the jejunum beta. Yes, the food is going to bypass the stomach and the duodenum. The food will not go into the stomach or duodenum beta. The food will directly enter to the jejunum now. Okay? And this second anastomosis is done over here. Why? Reason is basically we want the acid, the intrinsic factor and the bile along with pancreatic secretions from stomach and duodenum respectively beta for digestion of food. Okay? The food will directly go in jejunum and the second connection or second anastomosis is done for all the secretions beta. Okay? So now what will happen, as the food directly goes from the esophagus to the jejunum, if the patient tries to eat a lot of food at a time beta, patient immediately starts experiencing epigastric pain, epigastric fullness, nausea, vomiting like symptoms, known as which complication or which condition beta? Let me know. If the patient in this after the surgery tries to eat a lot of food, patient complains of epigastric pain, fullness, nausea, vomiting like features. It is known as which condition? And this surgery, wherever we have two anastomosis that we make beta, or wherever an extra limb is created like this surgery is known as the Roux-en-Y surgery. So this is the best bariatric surgery beta that we do. It is known as nothing else but the Roux-en-Y gastric bypass surgery beta. Okay, this is nothing else but classically known as the Roux-en-Y gastric bypass surgery. Do remember, a picture of Roux-en-Y gastric bypass surgery has been asked in a previous year FMGE. They have asked the pictures of two surgeries till date. One was basically the Whipple surgery for pancreatic cancer, and second was a Roux-en-Y gastric bypass surgery for weight loss. समझे बात? That is important. Yes, it is a feature of early dumping syndrome that I told you. तो अगर patient ज़्यादा खाना खाने की कोशिश करेगा, if the patient tries to eat more, definitely the patient will have epigastric fullness, nausea, vomiting like symptoms, which are the features of early dumping syndrome. Very good. Therefore, the patient avoids large meals and the patient is eventually going to have weight loss due to that. समझे बात अभी? चलो, great. Now take your break basically. Now I'm not giving a very long break, ठीक है, because we are taking a YouTube session. So make sure keep the break as short as possible. Okay, so usually around 20-25 minutes break is fine. You may grab something to eat. Any which ways, you have to keep on writing. Sorry, you don't have to keep on writing. You just have to listen most of the time. So make sure, bache, that take a shorter break, 20-25 minutes max, and then we'll come back and we'll restart the session again. Okay, and we'll continue further. Chal. Class will be till evening, beta. Hopefully बच्चों I'm audible. Let me know if the audio visuals are clear. Shall we start? Bolo, shall we start? Chalo, let's start now. The next is going to be peptic ulcer disease, beta. I hope all of you are quite aware that peptic ulcer disease means what? The ulcers which usually develop due to hypersecretion of HCl or due to hypersecretion of acid beta. That is known as peptic ulcers. Wherever peptic ulcers happen at two sides, one is going to be the duodenum, second is going to be the stomach. We know the most common site for the peptic ulcer which is there beta, it is duodenum. Yes, duodenal ulcers are always more common as compared to gastric ulcers beta. Right, so duodenal ulcers are always much more common as compared to gastric ulcer. That has to be kept in mind, right? So we know in duodenum the ulcers form at the first part of the duodenum beta or the D1, whereas in stomach the ulcers they usually form beta along the lesser curvature. In stomach the ulcers usually form along the lesser curvature. Yes, there are various causes or various risk factors for peptic ulcer disease beta. It could be smoking, alcohol, Helicobacter pylori or H. pylori infection. It can be spicy food, okay? Stress. These are all the conditions beta which can lead to a peptic ulcer disease. Now, if they say patient is having peptic ulcer disease, so patient will come to us with complaints of epigastric pain. Along with epigastric pain, patient will have symptoms of dyspepsia, that is bloating, indigestion, okay? Patient may have nausea and vomiting as well. These kind of features के साथ if the patient comes to you can think about peptic ulcer disease. Investigation of choice. Do you remember investigation of choice in patients of peptic ulcer diseases? Upper GI endoscopy plus minus biopsy. Now we know in case if you are able to see something suspicious beta, then you have to take a biopsy also. In case if you are able to see something suspicious, then you take a biopsy as well. Okay? So it is going to be upper GI endoscopy plus minus biopsy, which is the investigation of choice in patients of peptic ulcer disease beta. In case if the patient is diagnosed with peptic ulcer, the first line management is always lifestyle modifications, right? We know the first line management is lifestyle modifications. Same as GERD, you will advise the patient for weight loss to quit smoking and alcohol, avoid tea, coffee, carbonated beverages, and take small frequent meals beta. These are going to be the advices given in lifestyle modification if a patient is basically suffering from peptic ulcer disease beta. That has to be kept in mind. Along with lifestyle modifications, the another advice that I will give is definitely medical management. And the drug of choice or treatment of choice for peptic ulcer disease we know beta is nothing else but PPIs or proton pump inhibitors. I have told you GERD, gastritis as well as peptic ulcer disease. In all these three conditions, the treatment is lifestyle modifications along with the proton pump inhibitors beta, that is lansoprazole, pantoprazole like agents. Okay? So PPIs are not only the drug of choice, even the treatment of choice in patients suffering from peptic ulcer disease. Clear? Now, if they ask you basically that what is the treatment which is done if medical management fails, that is if you are given PPI for a very long duration beta, still the patient's condition does not improve. In those conditions, we proceed to surgeries beta, and the surgeries that we do basically is going to be, please remember, if it is a case of gastric ulcer beta, what we have to do in gastric ulcer, we can go for these kind of surgeries beta. What is done over here? First, we know the commonest site for a gastric ulcer is along the lesser curvature of the stomach in the antrum basically. So you can see here we have done an antrectomy or we have removed the antrum beta. And after doing an antrectomy beta, we connect the stomach and the duodenum basically. This is known as gastroduodenostomy. And when I do a gastroduodenostomy, that is nothing else but called as my Billroth 1 operation beta. That is classically known as my Billroth 1 surgery. Second picture mein again we have done an antrectomy or we have removed the antrum beta. But after removing the antrum, as the gap between the stomach and the duodenum was more, therefore I cannot go for a gastroduodenostomy. So here we have connected the stomach to the jejunum beta, called as gastrojejunostomy, known as your Billroth 2 surgery beta. Okay, that is known as your Billroth 2 surgery or the gastrojejunostomy. Samjhe baat? So if we do a gastroduodenostomy, that is a Billroth 1 surgery. If I do a gastrojejunostomy, that is a Billroth 2 surgery. And third important picture is this one. Here what we have done beta, here you can see you have connected the stomach to the jejunum, that is a gastrojejunostomy, and here you have done a jejunojejunostomy. So you have done 2 anastomosis and an extra limb is created. We know whenever 2 anastomosis are done and an extra limb is created, this surgery is known as the Roux-en-Y surgery. So this is what is known as the Roux-en-Y gastrojejunostomy beta. This is known as Roux-en-Y gastrojejunostomy surgery. Samjhe baat? So do remember, if a patient is diagnosed with gastric ulcers beta, the surgery or the treatment that we do are basically called as the Billroth surgeries. Either we can go for Billroth 1, that is gastroduodenostomy, or a Billroth 2, that is the gastrojejunostomy. And in case beta, if both are not recommended, then your better surgery is going to be a Roux-en-Y gastrojejunostomy beta. Samjhe? So these are the surgeries that we do for gastric ulcer. Another surgery, if I say you have tried PPS or you have tried proton pump inhibitor, but the patient's condition does not improve in a case of duodenal ulcer, so what is going to be the surgery beta? The surgeries that we recommend for a case of duodenal ulcer is nothing else but a vagotomy surgery. Do remember, majority duodenal ulcers do not need any kind of surgery beta, because majority duodenal ulcers respond very well to PPS only. But if it is a case of a recurrent duodenal ulcer, in those conditions we perform a vagotomy, that is, we cut the vagus nerve beta. As you cut the branches of the vagus nerve, basically the nerve supply to the parietal cells is gone. If nerve supply to parietal cells is gone, the secretion of HCl or the secretion of acid is going to decrease beta. Samjhe baat? That is what is important. Understood? Now important is, if I talk about vagotomies beta, please tell me the highest risk of recurrence is going to be seen with which vagotomy? The highest risk of recurrence beta is going to be seen with which vagotomy? Let me know in the chat box. Truncal vagotomy, selective vagotomy, or the highly selective vagotomy? Let me know in the chat box. So highest risk of recurrence basically is usually seen with which type of vagotomy beta? So I hope all of you are quite aware. Highest risk of recurrence is usually seen with highly selective vagotomy bache. The highest risk of recurrence is seen with the highly selective vagotomy. And do remember beta, that when I do a highly selective vagotomy, basically एक बात याद रखना, that the recurrence which is there basically, that happens due to which nerve? So that recurrence which is there beta, it usually happens due to the criminal nerve of Grassi. This has been a question once, that in a case of duodenal ulcer or peptic ulcer beta, when I do a surgery known as vagotomy, but even after vagotomy, if the patient is having recurrence, which among the following nerve is responsible? The answer is the criminal nerve of Grassi. This criminal nerve of Grassi is the branch of posterior division of vagus nerve. This is the nerve that is responsible for recurrence beta. Samjhe baat? Chalo. Now if they ask you, after the peptic ulcer surgeries, that is either after a Billroth surgery or after a vagotomy surgery, the patient may develop multiple nutritional deficiencies beta. Why? Obviously in vagotomy surgery, you are cutting the nerve supply to parietal cells, so there is decreased secretion of acid and intrinsic factor. We know. And in Billroth surgery, you are doing an antrectomy. Okay, again, so in both these conditions beta, there will be nutritional deficiencies seen. The commonest nutritional deficiency seen after the gastrectomy surgery, gastric cancer surgery, or peptic ulcer surgery, answer is going to be iron followed by vitamin B12 beta. Reason? Iron needs HCl or acidic medium for its absorption. So if acid secretion will decrease, iron absorption will also decrease beta. So most common nutritional deficiency is going to be iron deficiency beta, followed by second most common nutritional deficiency will be vitamin B12 or cobalamin. Reason? We know the production of intrinsic factor of Castle will decrease, so absorption of vitamin B12 will also decrease beta, causing vitamin B12 deficiency or a megaloblastic anemia. Sanjay baat? That is important. In a PYQ, they asked a question beta, and that was, a patient after a Billroth surgery starts complaining of fatigue, pallor, and tingling sensation. What is the likely supplement which will help in treating the patient's condition? After Billroth surgery, patient starts complaining of fatigue, pallor and tingling sensation. Which supplements will help in treatment of the patient? Let me know in the chat box. Very good, shabash. If they would have only said fatigue and pallor beta, then I would have thought about iron deficiency anemia and the answer would have been iron. But as they have said tingling sensation also, so we know tingling sensation happens due to peripheral neuropathy. Okay, so along with anemia, if there is peripheral neuropathy, that is usually due to vitamin B12 deficiency. So answer has to be vitamin B12 supplements beta. समझे बात? So that is how the difference will occur. Another complication of this peptic ulcer surgery can be dumping syndrome beta, right? Another complication of this peptic ulcer surgery is going to be dumping syndrome. There are two types of dumping syndrome that we have. First is an early dumping syndrome. Do remember, early dumping syndrome mein within 10 to 15 minutes of food intake beta, patient starts complaining of features like epigastric fullness, epigastric pain, nausea, vomiting, bloating. So within 10 to 15 minutes, if these symptoms will appear, that is the case of early dumping syndrome beta. Late dumping syndrome mein, the patient is going to have symptoms after 45 minutes to 1 hour of food intake beta. So after 45 minutes to 1 hour after food intake, if the patient develops symptoms of hypoglycemia, hypoglycemia means the patient will have symptoms like tremors, palpitations, sweating, dizziness, these kind of symptoms of rebound hypoglycemia 45 minutes to 1 hour after food intake if the patient sees. That is a classical case of late dumping syndrome beta. That is what is important to be remembered. Clear about? Beta, INR CT I need to record the lectures first. Okay, I am about to record it for NEET and INR. Once they are done, you can basically get the update on my Insta itself. Clear? Or in my Telegram. Now do remember beta, treatment if they ask you, you have to definitely avoid large meals in the patient beta. Okay, treatment ke liye you should avoid large meals. Reason is if the patient takes a lot of if the patient take large meals beta, then the risk of dumping syndrome is going to increase. Second important, you should also avoid hyperosmolar food or highly concentrated food, sugar rich food. So after these peptic ulcer surgeries, always advise the patient, do not take large meals, do not take hyperosmolar food. But if the patient does that, patient will develop dumping syndromes beta. Clear? So advise the patient, dietary advice has to be avoid large meals and avoid hyperosmolar food. Rather, take small frequent meals beta. After every 2 hours, you can take small frequent meals basically. That is what is important. Understood? That is the advice in the treatment of dumping syndrome. If that doesn't help, you may give IV octreotide in the patient beta. Yes, if dietary advice doesn't help, give IV octreotide. And if that also doesn't help, then convert that Billroth surgery into Roux-en-Y surgery beta. Convert the Billroth surgery to Roux-en-Y surgery. Clear? Now important is, if they ask you what is the most common complication of peptic ulcer disease, do remember beta, the most common complication of PUD or peptic ulcer disease is bleeding or upper GI hemorrhage beta. Okay, we any which ways know na, most common cause of upper GI bleeding or upper GI hemorrhage is peptic ulcer disease. So irrespective of gastric ulcer or duodenal ulcer, the more common complication or the most common complication of PUD is bleeding beta. Tell me which is the most common vessel to bleed in patients of peptic ulcer disease beta. Which is the most common vessel to bleed in patients of peptic ulcer disease? Let me know in the chat box. Let me know in the chat box beta. Which is the most common vessel to bleed in patients of peptic ulcer disease? I hope all of you are quite aware. Very good. Yes, the most common vessel to bleed beta in cases of peptic ulcer disease is nothing else but the gastroduodenal artery beta. Okay, so it is the gastroduodenal artery which is the commonest vessel to bleed in a patient suffering from peptic ulcer disease. That has been a PYQ, so be aware of this point. Clear? That is one thing. Second important, if I give you a very classical case, and what is that? Let's say the patient is the known case of peptic ulcer disease beta, and after a few days of peptic ulcer disease, the patient starts developing symptoms of peritonitis. What is the likely diagnosis? The patient may be taking NSAIDs beta. Okay, either the patient will be taking a lot of NSAIDs, that is non-steroidal anti-inflammatory drugs, or the patient may be a known case of PUD or peptic ulcer disease beta, or sometimes if there is a penetrating trauma, and followed by that patient comes to you in the emergency beta. Okay, patient presents to you in the emergency with complaints of nothing else but peritonitis. That is, the patient will have a severe pain. The patient is having a severe abdominal pain. Okay, and other signs of peritonitis. What is the likely diagnosis you are going to make, beta? Patient taking NSAIDs or patient is a known case of peptic ulcer disease comes to us basically, beta. Okay, so please remember, patient comes to us basically. Yes, in cases of early dumping syndrome, there is rapid influx of fluid in the bowel, and in late dumping syndrome, there is a persistent rise in the insulin levels causing rebound hypoglycemia. Very good. So, yaad rakhna beta, in these conditions, the diagnosis is going to be nothing else but a case of perforation peritonitis, also called as a hollow viscous perforation, beta. Barabar, if this is the case, we know the diagnosis of this case is nothing else but perforation peritonitis, also known as hollow viscous perforation. Now, if there is a hollow viscous perforation, that is perforation of the stomach or the bowel, beta, we know the patient will develop peritonitis. But apart from that, if I do a X-ray, X-ray shows me which classical sign, beta. In a case of hollow viscous perforation, let me know in the chat box. X-ray shows me which classical feature. Please let me know in the chat box, beta. Please let me know, beta. X-ray is going to show me which classical sign. Okay, very good. The X-ray in cases of hollow viscous perforation, beta, shows me the classical gas under diaphragm. It shows me the classical gas under diaphragm. That has to be kept in mind. No issues with this. So it shows me the classical gas under diaphragm, beta, also called as nothing else but the cupula sign or the moustache sign basically. It is also called as the cupula sign or the moustache sign. So whenever you are able to see a classical gas under diaphragm, beta, also known as the cupula sign or the moustache sign, okay, that is what is a classical feature of peritoneum. Sorry, that is a classical feature of pneumoperitoneum, and pneumoperitoneum happens due to the hollow viscous perforation. Hopefully clear. तो याद रखना, जब भी hollow viscous perforation होगा, X-ray abdomen shows a classical gas under diaphragm, also known as cupula sign or moustache sign, beta. That has to be remembered. Investigation of choice will be the CECT in this scenario. Okay, investigation of choice will be a CECT, or you can do a CT with oral contrast. And if they ask you treatment, so do remember, first line treatment has to be basic resuscitation. Again, as this patient of hollow viscous perforation may be hemodynamically unstable, so the first line treatment has to be a basic resuscitation. Whereas if they ask you what is going to be the definitive treatment, so do remember, definitive treatment is nothing else but an exploratory lap, that is exploratory laparotomy. You have to open the abdomen of the patient, beta. After doing exploratory laparotomy, sorry, after doing exploratory laparotomy, beta, we have to do a peritoneal lavage. Okay, we have to do a exploratory laparotomy. Along with that, we do a peritoneal lavage, beta. And along with peritoneal lavage, we may go for an immediate repair or a delayed repair, right? The stomach or the intestine which is perforated, we have to patch it up. And we know, basically to patch it up, basically we are going to use the omentum, beta. Barabar? To patch this perforated part, we are going to use the omentum, and that is classically known as Graham's omental patch repair. That is classically known as nothing else but the Graham's omental patch repair, which was a PYQ in the examination. समझे बात? तो do remember, if it is a case of a hollow viscous perforation, which is a sarkari question in the FMGE exams, याद रखना बेटा, that you have to go for a definitive surgery, that is exploratory laparotomy plus peritoneal lavage, and followed by that you have to go for a Graham's omental patch repair. Sometimes we have to go for an immediate Graham's omental patch repair if there is less contamination. Sometimes we have to go for a delayed Graham's omental patch repair if there is more contamination. Clear hai baat? So that is what is important to be remembered. Do you remember this major complication of peptic ulcer disease or NSAID intake known as hollow viscous perforation, which is very, very important. Clear hai baat yahan tak? Hopefully. ठीक है? No issues with this. Chalo. Next important, if I talk about, and that is this question over here, that states a neonate has presented to you, beta, with complaints of a bilious vomiting. The neonate has presented to you with complaints of bilious vomiting, beta, at birth. We have already discussed. If the neonate is having non-bilious vomiting after 2 to 3 weeks of life, we know it is a case of CHPS or a hypertrophic pyloric stenosis. But if that neonate presents to us with bilious vomiting immediately at birth, we know it is a classical case of nothing else but duodenal atresia beta. It is a classical case of nothing else but duodenal atresia. Do remember, in cases of duodenal atresia, we know, okay, the symptoms will appear immediately at birth, and it is mainly a bilious or a greenish vomiting which is seen. Because the regurgitation happens from the duodenum, so it is mixed with bile beta. The vomitus is going to be mixed with bile. Important is, if you do a X-ray abdomen in a patient suffering from duodenal atresia, that X-ray abdomen shows me classical feature known as the double bubble sign. We have discussed that if it is a case of CHPS or hypertrophic pyloric stenosis, then we are able to see the classical single bubble sign on X-ray abdomen. But if it is the case of duodenal atresia, then we are able to see the classical double bubble sign on X-ray abdomen. Has to be kept in mind, beta. Has to be kept in mind. Now I have told you that majority cases mein abdominal problems in children are diagnosed with ultrasound, and abdominal problems in adults are diagnosed with CCT. But duodenal atresia is an exception to this. Here in duodenal atresia, the investigation of choice is a CCT abdo or a contrast enhanced CT scan of abdomen beta. Okay, where you do a CT with oral contrast. Okay, you have to do a CT with oral contrast in this case. No issues with this. Do remember this. Okay, yes, triple bubble sign is seen in jejunal atresia and multiple bubble sign is seen in aerial atresia. Clear? Now treatment क्या है? We know duodenal atresia मतलब क्या है? तो we know both the ends of duodenum are not connected to each other. If both the ends of duodenum are not connected to each other, we have to make a connection. That is, we will perform a duodenal anastomosis or a duodenostomy beta. Let's say if both the ends are very far away from each other. So if both the ends are far away from each other, I cannot pull them. In those conditions, we go for a jejunal anastomosis or a duodenostomy beta. Clear है बात? तो याद रखना, majority cases में you can go for a DD-stomy or a duodenostomy. But if both the ends are far away from each other, go for a DJ-stomy, that is duodenostomy. Hopefully clear है यहाँ तक? चलो. Do remember this point. Next important is this point over here, and that is nothing else but about the intestinal obstruction or the bowel obstruction. Okay? It is a case of nothing else but intestinal or bowel obstruction. Now here, if they ask you about the clinical features, so we know whenever there is any kind of intestinal obstruction or bowel obstruction, the patient will come to us with complaints like inability to pass stools, that is constipation, inability to pass flatus or inability to pass gas, that is obstipation, abdominal pain, a colicky abdominal pain can be seen, and abdominal distension beta. Right? These are definitely the causes. These are the symptoms which are present in a patient of intestinal obstruction or bowel obstruction. Whenever a case of intestinal or bowel obstruction comes to us, the first line investigation is always the X-ray abdomen beta. The first line investigation has to be always the X-ray abdomen. That has to be kept in mind. Now when you do a X-ray abdomen, it has to be done in two views. Yes, X-ray abdomen for bowel obstruction is done in two views. One is going to be the erect view when the patient is standing, and second is the supine view when the patient is lying down. ठीक है, तो X-ray abdomen for bowel obstruction is done in two views beta. One is the erect view and second is supine view. Erect view पे you will get to know whether obstruction is present or absent. Erect view पे पता चलेगा कि obstruction है भी या नहीं है. And second, supine view pe you will get to know what is the exact site or what is the exact location of obstruction. Clear? Now here, how do you get to know on erect view whether the obstruction is present or absent? So you can see beta here, the bowel loops which are there, they are not continuous. There are breaks in bowel loops which are seen, and this is classically known as air fluid levels. So when there are more than 3 air fluid levels that you are able to see beta, we say it is a case of nothing else but bowel obstruction. So if the X-ray abdomen erect view shows me more than 3 air fluid levels, so we know it is surely a case of bowel obstruction, has to be remembered. Clear? Apart from that, X-ray abdomen supine view pe, how do you get to know what is the location? Do remember, if the distended bowel loops are in the periphery, okay, if the distended bowel loops are in the periphery and they show hostrations beta, we know it is the case of large bowel obstruction. Distended bowel loops in the periphery with hostrations seen, so it is the case of large bowel obstruction. But if distended bowel loops are in the center If distended bowel loops are in the center, we know it is a case of small bowel obstruction. We know it is a case of small bowel obstruction. Now, here you can see that the distended bowel loops are in the center. So it is a picture of a small bowel obstruction. Now in small bowel obstruction, whether it is jejunal or ileal obstruction, for that you have to see this continuous mucosal fold. Yes, this continuous mucosal folds known as valvulae conniventis. They are giving us a very classical pattern called as step ladder pattern. So if I am able to see beta the step ladder pattern in these distended bowel loops, if I am able to see the step ladder appearance or step ladder pattern in the distended bowel loops, we know it is a case of jejunal obstruction. We know it is a case of jejunal obstruction. समझे बात? तो distended bowel loops in the periphery with hostrations is a feature of large bowel obstruction. Distended bowel loops in the center is a feature of small bowel obstruction. And if step ladder appearance or step ladder pattern is seen, then we know it is a case of jejunal obstruction. समझे बात यहाँ तक? चलो. Next important if I talk about is the treatment. If I talk about, sorry, what is the investigation of choice? X-ray abdomen is the first line investigation, but investigation of choice has to be CECT abdo beta. Investigation of choice has to be a CECT abdomen or a contrast enhanced CT scan of abdomen. Now, if they ask you what should be the treatment, do remember in majority cases of intestinal obstruction or bowel obstruction, the treatment is usually conservative in nature. And whenever I say conservative management in surgery beta, whenever I talk about conservative management in surgery, yaad rakhna, conservative management in surgery includes 4 things. First, keep your patient NPO, that is nil per oral or nil by mouth basically. Clear? Second important, give IV fluids to the patient beta. Okay, give IV fluids. Third, give IV antibiotics. And fourth, for pain relief, give analgesics. So NPO, IV fluids, IV antibiotics and analgesics. That is included in the conservative management. Along with that, as it is a case of bowel obstruction, I also have to do a decompression of the bowel. To release the gas basically, okay, we have to do decompression of the bowel. That is done by insertion of the nasogastric tube or the Riles tube beta. You have to insert the NG tube, okay, and that is nothing else but done for decompression of the bowel. Understood? Now, in case beta, if you have tried conservative management, but the patient's condition does not improve, matlab, if conservative management fails, then in those conditions beta, you have to go for a surgery known as the exploratory laparotomy beta. Clear hai baat? To yaad rakhna that if in case conservative management fails, in those conditions you have to go for a surgery, and that surgery is known as a exploratory laparotomy. Hopefully clear to all of you now? Chalo. So this is what is important to be remembered. Now if I talk about the 2 types of obstruction, one obstruction basically is nothing else but called as dynamic obstruction, second is adynamic. What is the basic difference between both of them? To yaad rakhna beta, dynamic obstruction means when there is some kind of physical obstruction in the bowel. Okay? So let's say if there is some kind of physical obstruction in the bowel, but the motility of the bowel is absolutely normal or the motility of the bowel is absolutely intact, this kind of obstruction is known as dynamic obstruction. Second is adynamic obstruction. Adynamic obstruction mein you can see there is no physical obstruction in the bowel. Yes, there is no physical obstruction in the bowel beta, but the motility of the bowel is absent or the peristalsis in the bowel is absent. That is known as adynamic bowel obstruction. Got it? So dynamic obstruction means when there is some kind of physical obstruction, whereas adynamic means there is no physical obstruction, but the problem is bowel is not motile, bowel is not performing peristalsis. समझे बात? So do remember that dynamic obstruction का most common cause is nothing else but adhesions. Very good. The most common cause of dynamic bowel obstruction is adhesions beta. That is, if the bowel wall or if the intestinal wall gets stuck to each other, एक दूसरे से अगर चिपक जाती है, तो most common cause of dynamic bowel obstruction are going to be adhesions followed by strictures beta. So leading cause of dynamic bowel obstruction are adhesions. Whereas most common cause of adynamic bowel obstruction, if they ask you, most common cause of adynamic bowel obstruction is nothing else but paralytic ileus. So we know the most common cause of adynamic bowel obstruction is paralytic ileus. Matlab the intestine or the bowel is paralyzed or there is no peristalsis in the bowel beta. That condition is known as paralytic ileus. Let me know in the chat box What is the most common cause of adynamic bowel obstruction or paralytic ileus? Let me know in the chat box. This was the PYQ. Most common cause of paralytic ileus. What is going to be answer? The most common cause of paralytic ileus. Answer is going to be the most common cause of paralytic ileus. Very good. So please remember the leading cause or the most common cause of paralytic ileus is nothing else but surgery beta. याद रखना, most common cause of paralytic ileus is nothing else but surgery. समझे बात? तो most common cause of paralytic ileus is surgery. That has to be kept in mind. ठीक है, during surgery if there is bowel handling beta, that can lead to paralytic ileus or a adynamic bowel obstruction. But another PYQ was, which is the most common dyselectrolytemia or the most common electrolyte disturbance which is known to cause paralytic ileus. तो अगर ये पूछा जाता है the commonest electrolyte disturbance known to cause paralytic ileus, then I hope all of you are quite aware. The answer has to be hypokalemia or low potassium levels. The most common electrolyte disturbance known to cause paralytic ileus, answer is hypokalemia or the low potassium levels. Hopefully clear to all of you now. Very good. Yes. So we know if a patient is having adynamic bowel obstruction or a paralytic ileus, the treatment is nothing else but just treat the underlying electrolyte disturbances. As you treat the underlying electrolyte disturbances, beta, please remember the motility of the bowel will be regained and the patient's adynamic bowel obstruction will get resolved. Okay, the patient's condition will improve. Hopefully clear. Chalo. Next important is this question over here, which states a patient presents in the casualty with complaints of abdominal pain, abdominal distension, constipation or obstipation, and vomiting beta. So all the features of bowel obstruction or all the features of intestinal obstruction are there. Okay? If you check the X-ray abdomen, it gives you this classical feature. What is this classical feature seen? X-ray abdomen is showing me a very classical feature, that is two fluid levels beta. And this two fluid levels which are seen on X-ray abdomen looks like the coffee bean. Very good. Yes, it is classically known as nothing else but the coffee bean sign. This X-ray abdomen which is there, it is going to show me the classical coffee bean sign, has to be remembered. Whereas if you see the barium enema, on that barium enema beta, again a classical feature or a smooth tapering is seen. That barium enema shows me a smooth tapering, classically called as the bird beak appearance. Okay? This bird beak appearance can also be referred to as the bird of prey sign or the ace of spade sign beta. Bird of prey or the ace of spade sign as well. Okay? हमें पता है any patient coming to us with complaints of bowel obstruction and X-ray abdomen showing coffee bean sign or the barium enema showing the bird beak appearance has to be a case of nothing else but sigmoid volvulus. Very good. Sigmoid volvulus means the sigmoid colon which is there beta, it will undergo twisting or it will undergo malrotation. Clear about? So that is what is important. So diagnosis in this case is nothing else but sigmoid volvulus beta. And as the sigmoid volvulus happens or as the sigmoid colon undergoes a twisting or malrotation, the patient has all the features of bowel obstruction over here. समझे यहाँ तक बात? Now if I talk about sigmoid volvulus में, you can go for X-ray abdomen as your first line investigation, but investigation of choice is nothing else but CECT abdo. ठीक है? The investigation of choice which is there, it is nothing else but a CECT abdomen or a contrast enhanced CT scan of abdomen. No issues with this? Hopefully clear. Chalo. Next important, if I talk about now, what should be the treatment? So yaad rakhna, the treatment in this condition is nothing else but, we know the sigmoid colon is twisted beta. So what I have to do, if my patient is stable, if there are no complications, what I do is, I will insert a sigmoidoscope via the anal canal. And with the help of the sigmoidoscope, I will release the gas or I will release the pressure beta, so that the sigmoid colon comes back into the original position. That is called as sigmoidoscopic decompression. So the sigmoid colon which was twisted, by decompression beta, we will bring back the sigmoid colon in the normal position. Once this decompression is done, once the sigmoid colon has come back to the normal position, followed by that, we have two options. Either I can go for removal, that is sigmoidectomy, or I can go for fixation, that is sigmoidopexy. But as we know, the risk of recurrence in volvulus is very, very high. it's better to go for a removal, that is a sigmoidectomy beta. समझे बात? So if it is the case of sigmoid volvulus, go for a sigmoidoscopic decompression, followed by that better is to go for a sigmoidectomy. ठीक है? This is the treatment in a case of volvulus if my patient is stable. Let's say if my patient is unstable, that is if my patient is having some complications like there is strangulation, perforation, peritonitis, these kind of complications, if they are present beta in a case of sigmoid volvulus, then very good, we have to go for a procedure, and that surgery which is there, it is classically known as the Hartmann's surgery or the Hartmann's procedure. Clear? That procedure is known as the Hartmann's surgery or the Hartmann's procedure. Hopefully clear to all of you now. So that has to be remembered. What we do in Hartmann surgery, we basically have to, in Hartmann surgery beta, we basically have to perform an exploratory laparotomy. We will do a peritoneal lavage. After that, we have to do a sigmoidectomy or a removal of sigmoid colon and a colostomy for a few days beta. Yes, I don't go for an immediate anastomosis due to infection. I do a colostomy for a few days and delayed anastomosis will be done. That is known as a Hartmann surgery. Clear? Chalo. Now let me talk about the next condition beta, and the next condition is this. Please tell me what is the diagnosis in this condition. You are able to see the intestine or you are able to see the bowel beta, and from the intestine or bowel you are able to see this classical appearance. Exact previous year image was asked beta. This is the same image. You can see this is your fatty tissue or the mesentery beta. So on the anti-mesenteric border you are able to see an outpouching from the bowel. And very good, this outpouching from the bowel beta on the anti-mesenteric border is classically known as your Meckel's diverticulum. Shabash. Yes, the diagnosis of this case is nothing else but Meckel's diverticulum. As we know, Meckel's diverticulum is present since birth. It is a congenital diverticulum, and as it contains all the layer in the wall, mucosa, submucosa, muscularis, so we know it is a true diverticulum. So Meckel's diverticulum, unlike Zenker's, is a true diverticulum, has to be kept in mind beta. Okay, Meckel's is a true diverticulum. Do remember this point. Next important is, please tell me that Meckel's diverticulum happens due to partial patency of which embryological structure. Now we know during the fetal life beta, there is a embryological structure known as a duct present between the midgut and the umbilicus. Now this duct should disappear beta at birth, but in case if this duct is completely patent, or if this duct is completely open even after birth, then the meconium will come out from the baby's umbilicus beta. And if meconium comes out from the baby's umbilicus, we know that the vitello-intestinal duct is completely patent, and that is known as vitelline fistula. But if this vitello-intestinal duct is partially patent, then it leads to formation of an outpouching beta from the intestinal wall. And this outpouching from intestinal wall is known as Meckel's diverticulum. So yaad rakhna, Meckel's diverticulum happens due to the partial patency of an embryological structure known as vitello-intestinal duct, also known as omphalomesenteric duct. So when the vitello-intestinal duct or omphalomesenteric duct will be partially patent, that condition leads to Meckel's diverticulum. Hopefully clear. Now we know Meckel's diverticulum is the one which follows the rule of 2. And what do I mean by rule of 2? Rule of 2 literally means it is going to be seen in 2% of the population. It is going to be around 2 inches long beta. Third, it is 2 feet proximal from the iliocecal junction. So it is 2 feet proximal or before the iliocecal junction. Okay, and 20% patients may have an ectopic mucosa. And 20% patients who have an ectopic mucosa, out of them, the most common ectopic mucosa present in Meckel's diverticulum will be, let me know in the chat box, this was a PYQ again. The most common ectopic mucosa present in Meckel's diverticulum is going to be, very good. The most common ectopic mucosa present in Meckel's diverticulum is the gastric mucosa followed by pancreatic mucosa. Shabash. Yes, the most common ectopic mucosa present in Meckel's is going to be the gastric mucosa followed by the pancreatic mucosa, has to be kept in mind. No issues with this. So do remember this point as well. Next, we know majority patients of Meckel's diverticulum will be completely asymptomatic. Yes, majority cases of Meckel's diverticulum will be completely asymptomatic beta, but some patients may have symptoms, and those people who may have symptoms beta are basically going to present with bleeding per rectum. Okay? So if they ask you what is the most common presentation in Meckel's, answer is nothing else but bleeding per rectum has to be remembered. Now, if they ask you what is investigation of choice, do remember this is different and has to be remembered. Investigation of choice in patients suffering from Meckel's diverticulum is nothing else but a technetium 99. आगे क्या? Technetium 99 is a radioactive substance used in multiple scans. मुझे स्कैन का नाम चाहिए, तो आंसर इज नथिंग एल्स बट अ टेक्नीशियम 99 per technate scan. This is important. Reason is there will be 2 or 3 options with technetium 99. तब क्या करोगे? So do remember it is the technetium 99 per technate scan which is considered as the investigation of choice for Meckel's diverticulum. Let me know in the chat box beta that technetium 99 system EB scan is the investigation of choice for which condition. If they mention somewhere that a technetium 99 system EB scan is usually done for which condition, let me know in the chat box. Technetium 99 system EB scan is done for which organ? Very good. Technetium 99 system EB scan is done for the parathyroid gland. So if they say there is a parathyroid adenoma, and if you have to find out that parathyroid adenoma beta, the investigation of choice is going to be a technetium 99 system EB scan. This was a PYQ in the FMGE examination. Understood? Chalo. Next important, if I talk about this, if they ask you what should be the treatment, so do remember, if the Meckel's diverticulum is having a wide mouth and a wide base, do not do anything. Just leave the Meckel's diverticulum as it is. Yes, if it is having a wide mouth and a wide base, it will not get obstructed. So I will leave it as it is. But if the Meckel's diverticulum is having a narrow mouth or a narrow base, we know if Meckel's diverticulum will have a narrow mouth or a narrow base, the chances of obstruction or the chances of perforation will be very, very high. That's the reason here we better go for removal. And we know removal of diverticulum is nothing else but called as diverticulectomy. So if a Meckel's diverticulum has a narrow mouth and a narrow base, go for a removal, and that is nothing else but known as diverticulectomy. Clear yahan tak? Chalo. Next, there is the question bit over here which states an infant presents to you with complaints of bowel obstruction. Okay, an infant or a child less than 2 years of age commonly presents to you with complaints of bowel obstruction, and there are red currant jelly stools, very classical feature. Blood plus mucus containing stools known as red currant jelly stools, and on palpation you are able to feel a sausage shaped lump in the abdomen. There is a sausage shaped lump in the abdomen. What is the likely diagnosis? So I hope all of you are quite aware. Bowel obstruction in an infant can be seen in multiple conditions, but red currant jelly stools and a sausage shaped lump is going to be the keyword of the question. And yes, it is a classical diagnosis of nothing else but intussusception. Very good. It is a classical diagnosis of nothing else but intussusception. ठीक है, याद रखना. So intussusception means when one part of the bowel goes in the adjacent part of the bowel, causing a bowel obstruction. That is known as intussusception. याद रखना एक point बेटा, that intussusception which is there, it is more commonly seen in smaller children less than 2 years of age, and the commonest site is the ileocecal junction or the ileocolic junction. Okay, so ileocecal junction or ileocolic junction where there is intussusception, and the leading cause is going to be hypertrophy of Peyer's patches. The leading cause can be hypertrophy of Peyer's patches. We know, as the patient is brought to us beta, investigation of choice if they ask you. So we know in a child abdominal problems के लिए investigation of choice can be an ultrasound abdomen. Yes, if the patient is an adult, we may have to go for CCT, but otherwise बच्चों के लिए you can just do an ultrasound abdomen. And when I do an ultrasound abdomen, a very classical feature is seen. Okay, one loop of the bowel inside another loop of the bowel, showing us a very classical target sign, also known as the donut sign, right? So this is the classical target sign, also called as donut sign. So do remember that whenever the ultrasound abdomen shows a target sign or donut sign, it is a classical feature of intussusception, has to be remembered. Clear? Now, if they ask you what is the gold standard investigation, so I hope all of you are quite aware. Gold standard investigation in a case of intussusception is nothing else but barium enema beta. Yes, so gold standard investigation for intussusception is nothing else but barium enema. And when I do a barium enema, why does gold standard? Reason, This barium enema will not only help us in diagnosis, but it will also help us in treatment of a case of intersusception. Therefore, we call it as the gold standard investigation. In this condition beta, on this barium enema beta, we are able to see a very classical feature. And what is this sign called as? This sign that you are able to see, it looks like the claw. Okay, so definitely this is classically known as the coiled spring sign. So if you see the barium enema, that is showing you the classical coiled spring. This is the claw sign beta. If you see the barium enema, this is the one that I have highlighted. It is classically known as the claw sign, also known as pincer sign. Okay, this is known as the claw sign or pincer sign, and this one over here is my coiled spring sign. There are two signs on the barium enema in a patient of intersusception. One is this claw sign which is seen, and second, this one is the coiled spring sign. Hopefully clear? Chalo. So these are the points that you need to remember. Now, what is the treatment? We know in cases of intersusception, we might have done a barium enema. Now, with the same catheter beta, either you can inject a lot of air or you can inject a lot of fluid. If you are injecting a lot of air or fluid, there will be a lot of pressure from below, and as there is a lot of pressure beta, this part which is there, which has gone inside, slowly will get reduced. Barabar? So as you push a lot of air or fluid, slowly this part will come outside beta, and this will be called as either a pneumostatic reduction or a hydrostatic reduction. If you use air, it is pneumostatic. If you use fluid, that is hydrostatic reduction. Clear? Let's say if you have tried pneumostatic or hydrostatic reduction, but if it fails, matlab, even after this pneumostatic or hydrostatic reduction, patient's condition does not improve. In those conditions, you have to go for a manual reduction. In those cases, we have to go for a manual reduction beta. We will do an exploratory laparotomy and we will do a manual reduction. Very good. We know the classical rule that we follow during a manual reduction of intersusception, and that is never pull, always push. So always keep on pushing the distal part beta. Always keep on pushing the distal part so that slowly the part which has gone inside will get reduced. Barabar? Never pull, always push. If you try to pull, there will be a risk of strangulation or perforation. Samjhe baat? That is important. Let me know. Integration with PD and PSM, which vaccine is commonly associated with intersusception? Which vaccine is commonly associated with intersusception? Let me know in the chat box. It is because of the bleeding beta. There's blood plus mucus coming out in stool, therefore it looks like a red currant jelly. समझे बात अभी? Very good. The vaccine that is commonly associated with intersusception. Do you remember? The vaccine that is associated with intersusception is the rotavirus vaccine. So one of the important side effect of adverse events of the rotavirus vaccine is the intersusception. One thing. Second important, if I talk about, is nothing else but red currant jelly stool is a feature of intersusception. But red currant jelly sputum is seen in which pneumonia? Let me know in the chat box. Red currant jelly stool is a feature of intersusception, but red currant jelly sputum will be seen in which pneumonia? Let me know in the chat box. Very good. Red currant jelly sputum will be a feature of Klebsiella pneumonia. Red currant jelly sputum is a feature of Klebsiella pneumonia. Clear about? Very good. Next important, if I talk about beta, and that is this question over here. What is the question saying? We are having a neonate who was brought to the ER or who was brought to the emergency room with complaints of no passage of meconium since birth. Okay, the child haven't passed the meconium or the first stool since birth. Now therefore we do a DRE, digital rectal examination beta, and when I do a DRE in this child, a gush of meconium floods out. Matlab, as soon as you do DRE and you stimulate the rectum, a gush of meconium is coming out or a flood of meconium is coming out beta. What is the likely diagnosis? The likely diagnosis in this case is nothing else but, very good, it is going to be a case of Hirschsprung's disease, also known as congenital aganglionosis. Barabar? It is a case of Hirschsprung's disease, also known as congenital aganglionosis. Now what is the problem in this condition? We know in some part of the intestine or in some part of the bowel, the ganglionic cells are absent. If the ganglionic cells will be absent beta, obviously we know that the intestine is not going to be stimulated, and if the intestine is not stimulated only, that part of the bowel which is aganglionic, it will remain collapsed. Barabar, the part of the bowel which is aganglionic, it will remain collapsed beta. There will be no peristalsis, or there will be no movement over here. And as a part of the bowel which is aganglionic is collapsed, therefore the patient is not able to pass the meconium. Okay? So this is a classical case of nothing else but Hirschsprung's disease, also known as congenital aganglionosis or congenital megacolon, also you can call it as. Clear? So we know in cases of Hirschsprung's, do you remember there is absence of ganglionic cells in two plexuses. Okay, there is absence of ganglionic cells in the Meissner's plexus as well as the Auerbach's or the Menetrier plexus. Yes, in Achalasia Cardia we have discussed there was loss of ganglionic cells only from the Auerbach's or the Menetrier plexus. But in Hirschsprung's there is absence of ganglionic cells in both the plexuses, Meissner's as well as the Auerbach's plexus. Both the plexuses are involved. याद रखना. ठीक है. If they ask you what is the most common site, so do remember the most common site which is there in cases of Hirschsprung's disease. The most common site in cases of Hirschsprung's disease is nothing else but rectosigmoid. That is rectum followed by sigmoid colon. So rectosigmoid is the commonest site where the patient is going to have Hirschsprung's disease. ठीक है? Rectosigmoid is the commonest site where the patient is going to have Hirschsprung's disease. Now if they ask you what is the investigation of choice, how to confirm the diagnosis of Hirschsprung's disease, so do remember the investigation of choice in this case is nothing else but a rectal biopsy. We have to go for a rectal biopsy, and on that rectal biopsy we need to check whether the ganglionic cells are present or absent. Yes, so go for a rectal biopsy, and on that rectal biopsy you will find beta that the ganglionic cells are absent. If the ganglionic cells are actually going to be absent, we know it is a sure shot case of Hirschsprung's disease. But on rectal biopsy we will only get to know whether the ganglionic cells are present or absent, or whether it is a case of Hirschsprung disease or not. But if I want to know that how much is the extent of Hirschsprung disease, that is how much length of the intestine or the bowel is aganglionic, to know the extent of the disease. Okay, if I want to know the extent of the disease, I can go for a barium enema. If I want to know the extent of the disease or the length of aganglionic segment, I have to go for a barium enema. And on barium enema, we are able to see this classical picture. Can you see all this part which appears to be collapsed? All this segment which appears to be collapsed, it is aganglionic. Okay, that is going to be aganglionic. So this is the aganglionic segment that is collapsed. And this proximal segment which you are able to see, which is distended, this proximal distended segment is actually normal. Yes, the proximal distended segment which is forming the megacolon, that is actually normal. The problem is in the collapsed segment or the aganglionic segment. समझे बात यहाँ तक? ट्रीटमेंट हमें पता है सर्जरी में वी ओनली अप्लाई वन लॉजिक. अगर कुछ खराब है उसको निकालो, बाकी नॉर्मल वाली चीजें जोड़ दो. बराबर? तो डेफिनेटली वी अप्लाई द सेम लॉजिक. वी हैव टू कट इफ एनीथिंग इज प्रॉब्लमैटिक एंड जॉइन द नॉर्मल पार्ट्स. So here also we cut the aganglionic segment, that is known as resection, and we join the normal segments, that is anastomosis. So the surgeries of Hirschsprung's disease are based on a basic principle of resection and anastomosis. The name of surgeries in Hirschsprung's disease will be, first one is known as the Duhamel's surgery or the Duhamel's operation. Second one is known as the Swenson surgery or the Swenson's operation. And third one is the Sovan-Parks surgery or the Sovan-Parks operation. Hopefully clear to all of you now. So these are the points that you have to remember at any cost. Clear with this? So that is what is important. Now let me know in a chat box, beta, we know if a neonate has been brought to you with no passage of meconium and DRE leads to flooding of meconium or a gush of meconium, we know it is a case of Hirschsprung disease. But another case if I ask you, and that is again a neonate has been brought to you, beta, with no passage of meconium. ठीक है, a neonate has been brought to you with no passage of meconium and therefore you do a DRE. But even on doing DRE, beta, even on doing a DRE or even on doing a digital rectal examination, no passage of meconium happens. On DRE also, there is no meconium which comes out, there is no passage of meconium. Then what is going to be your likely diagnosis? We know neonate is having no passage of meconium since birth, therefore you have done a DRE or digital rectal examination. But even on doing DRE, if there is no passage of meconium, then this is a classical diagnosis of which condition? This is a classical case of which condition? Let me know. Bolo. This is a classical case of nothing else but pediatric cystic fibrosis. We know cystic fibrosis or mucoviscidosis which is there. In that condition, what is the problem? In that condition, beta, the meconium of the patient is extremely hard. And as the meconium is extremely hard, do remember, even on doing DRE, the meconium does not pass out. Clear hai baat? तो याद रखना, if gush of meconium comes out, it is Hirschsprung disease. If no gush of meconium even after DRE, it is a case of cystic fibrosis due to the CFTR gene mutation. समझे बात? चलो. Now, here there is another question, and that says, we are having an elderly patient who was diagnosed with anal cancer. So we know that anal cancer which is there has to be a squamous cell carcinoma. Okay, 3 sites in GIT where squamous cell carcinoma is common. One is oral cavity, second is esophagus, and third is anal canal. So it is going to be a squamous cell carcinoma commonly. And now if they ask you what should be the treatment, so very good. We know the treatment is going to be chemoradiation. But do remember, beta, anal cancer which happens, okay, the basic reason behind anal cancer which is there, it could be immunocompromised patient or a viral infection. And what is that viral infection? We all know HPV or the human papilloma virus. The high risk serotypes known as 16 and 18. So anal cancer which is there, it happens basically due to the HPV or the human papilloma virus, high risk serotypes like 16 and 18. That has to be kept in mind. Samjhe baat? Whereas we know if the patient is having anal cancer, he comes to us with a complaint of ulceroproliferative growth in the anal canal. And the investigation of choice for this has to be biopsy then. If I do a biopsy, we know on biopsy or histopath, we get to know it is a case of squamous cell carcinoma. And as it is going to be a case of squamous cell carcinoma, keratin pearls will be seen. Okay? So biopsy or histopath which is there, it confirms it is a case of squamous cell carcinoma and keratin pearls are going to be observed. Treatment. Now we know in cases of anal cancer, if you try to go for a surgery, beta, do remember 100% cases mein the anal sphincters will get damaged. And if the anal sphincters will be damaged during surgery, the patient will have a complication of anal incontinence or fecal incontinence. So if you don't want this complication of anal or fecal incontinence, in those conditions, what should be done for treatment? In those conditions, it's better that rather than going for a surgery, go for nothing else but a chemoradiation. Yes, a simultaneous chemotherapy plus radiotherapy has to be done, beta. This was a PYQ also. So anal cancers are not primarily treated by surgery. Anal cancers are primarily treated by a chemoradiation. And that chemoradiation is given according to a regime known as Negro's regime. We know the chemoradiation given in anal cancer, it is given according to a regime classically referred to as the Negro's regime. Has to be remembered. Clear about? Chalo. Next one, if I talk about, is a case, and that is nothing else but a case of rectal prolapse. We know what is rectal prolapse? When the rectum of a patient will start hanging outside the anal canal. Let's say this is the anal canal of the patient and this is the rectum of the patient that is hanging outside the anal canal, as you are able to see in this picture. So this is the case known as rectal prolapse. We know whenever the perineum of the patient becomes weak or lax, the risk of genital prolapse or rectal prolapse is going to increase. Clear? So we know recurrent episodes of diarrhea or obstructed labor, these are the risk factors which will make the perineum lax, and as the laxity of perineum increases, the patient will have a higher risk of rectal prolapse, beta, or the rectum may hang out from the anal canal. Now there are two types of rectal prolapse. One is going to be a partial thickness rectal prolapse. Second is a full thickness rectal prolapse. Partial thickness rectal prolapse mein only the mucosa is going to hang out. So when only the mucosa is hanging out of the anal canal, we call it as the case of partial thickness rectal prolapse. Whereas if all the layers of rectum are hanging out, or if I say if the whole rectum is hanging out, then it is a case of full thickness rectal prolapse. Do remember, partial thickness rectal prolapse is more commonly seen in children, whereas full thickness rectal prolapse is more common in adults or especially the elderly patients. Clear? Now, if they ask you what should be the treatment, so we know if it is diagnosed as a case of rectal prolapse, Do remember, if it is a partial thickness rectal prolapse in a child and it is the very first episode, if it is the very first episode beta, so for the very first time don't go for any surgery. Okay? For the very first time don't go for any surgery, just go for digital repositioning. That is what you just have to push back the rectum with the help of your digits or with the help of your fingers. That's it. ठीक है, वापस उसको ढकेल दो अंदर. So if it is the very first episode of a partial thickness rectal prolapse in a child, just go for a digital repositioning. If it is a recurrent case of partial thickness rectal prolapse, then we have to go for a surgical procedure, and that surgical procedure is known as Thiersch wiring beta. That surgical procedure is known as Thiersch wiring. In Thiersch wiring, circumferentially or around the anal canal beta, we pass a Thiersch wire or we pass a purse string suture at times. And with the help of that purse string suture or with the help of this wire, we are going to tighten up the anal canal. Reason, if you tighten up the anal canal beta, now the rectum is not going to prolapse or the rectum is not going to hang out. समझे बात? That is important. So you have to tighten up the anal canal so that the rectum does not hang out. Clear? Next, if I talk about a full thickness rectal prolapse, in full thickness rectal prolapse, we have some perineal surgeries and some abdominal surgeries. Do remember, perineal surgeries that we do can be again Thiersch wiring, Delorme's repair, Altemeyer's repair, whereas the abdominal surgeries which we do, that abdominal surgeries are going to be surgeries like Wells repair or a Repstein's repair. That is nothing else but rectopexy. You have to pull up the rectum via the abdomen and you have to fix it properly with the help of a mesh beta. And that is known as nothing else but a rectopexy. So either you can do a Wells rectopexy or you can do a Repstein's rectopexy. Apart from that, as I've told you, perineal surgeries can be done. And these perineal surgeries which are there, they are going to be the surgeries like Altemeyer's repair or the Delorme's repair. These are going to be nothing else but the Altemeyer's repair or the Delorme's repair. These are the perineal surgeries that we do. So abdominal surgeries like rectopexy or perineal surgeries like Altemeyer's or Delorme's repair can be done if it is the case of full thickness rectal prolapse. Hopefully clear? Chalo. Next, a recent question in the FMGE examination, though we did not expect this question basically very commonly in the FMGE exams, but still there was a question, so therefore I have included it. Do remember, if I talk about a case of mesenteric cyst. Now when I talk about a mesenteric cyst, we know cyst is nothing else but a sac which contains fluid. Barabar, cyst is nothing else but any sac which contains fluid is known as cyst. So whenever there is collection of fluid inside the mesentery, whenever there is collection of fluid in the mesentery, we call it as the case of mesenteric cyst. Do remember, mesenteric cyst can be of various types. The most common type of mesenteric cyst is known as a chylolymphatic cyst. The commonest type of mesenteric cyst is known as a chylolymphatic cyst, whereas the second most common is known as a enterogenous or an enterogenic cyst. Now, in cases of mesenteric cyst, there is a classical triad. Please let me know the name of this triad. What is the classical triad? First is, patient will have a soft fluctuant swelling in the umbilical region. So when you palpate the umbilical region, you are able to feel a soft fluctuant swelling. Second, the swelling which is there, it is mobile in the direction perpendicular to mesentery beta. The swelling is mobile in a direction perpendicular to the mesentery. Let's say if this is the mesentery, I can move the swelling perpendicular to the mesentery. And third, there is zone of resonance all around the swelling. So when you percuss around the swelling, you are able to get a resonance, not a tympanic sound. Clear? So this is classically a triad seen in patients of mesenteric cyst. Very good. It is classically known as the Tillot's triad. This classical triad which is there, it is nothing else but called as the Tillot's triad. Hopefully clear hai? So yaad rakhna, Tillot's triad which is there, it is very classically seen if a patient is suffering from a mesenteric cyst. Clear? Now, in cases of mesenteric cyst, investigation of choice you can do is nothing else but a CCT again. Okay, investigation of choice in both the conditions is a CCT abdomen. But if they ask you what should be the treatment, now in the recent examination they have asked about treatment itself. Now we know more common is going to be a chylolymphatic cyst, and for chylolymphatic cyst the treatment is nothing else but enucleation. What do I mean by that? We just have to remove the chylolymphatic cyst, nothing else. Okay? So treatment in a case of chylolymphatic cyst is nothing else but enucleation, that is removal of the cyst only. But if it is a case of a enterogenous cyst, Now enterogenous cyst is the one which contains bowel elements. So if there are bowel elements or if there are intestinal tissue in the cyst, that is known as the enterogenous cyst. Agar enterogenous cyst hai, so we have to cut that part which is having the cyst and join the remaining part. That is nothing else but resection and anastomosis. So if it is an enterogenous cyst, then you have to go for a resection and anastomosis. Hopefully clear hai baat? Chalo, great. Next is a question beta that says a male patient presents to us with complaints of perianal pain. Along with perianal pain, patient is having pus discharge. And when you examine, you are able to see this classical picture. This is the anal canal, as you can see. In the line of anal canal beta, or in the midline, that is in the natal cleft or in the butt crack, you are able to see these multiple openings. And these multiple openings which are there, from them definitely there is a pus discharge happening. Pus discharge is not happening from the rectum. Yes, it is a classical case of nothing else but pilonidal sinus, not anal fistula. Anal fistula mein, please remember, there is a connection with the anal canal also, and therefore in perianal fistula, the pus discharge also happens from rectum. Here it is not happening from rectum. Here the pus discharge is only happening from these openings. So it is nothing else but a classical case of pilonidal sinus. ठीक है, तो याद रखना, it is also known as jeep driver's bottoms disease, as you all might be aware. So this jeep driver's bottoms disease mein, the patient will have multiple sinuses, multiple pilonidal sinuses beta, and all these sinuses are going to drain pus, or all these sinuses are going to discharge pus. Okay, this condition is classically known as pilonidal sinus. It commonly happens in the natal cleft or in the butt crack. Investigation of choice. If I want to see the sinuses, we know the best radiological investigation for the perineal structure is MRI. So for all the perineal structure, the best radiological investigation is MRI. So we can do a MRI for looking at the sinuses properly. Treatment now. Once you have diagnosed it as a case of pilonidal sinus, do remember the treatment which is there is nothing else but Bascom surgery. Okay, what we are going to do? We are actually going to excise this tissue over here. Okay, yes, we are going to excise the skin and the tissue from here, and then we are going to close this openings or close the sinuses. Okay, so do remember, we have to excise this tissue and the skin from here, and that is classically known as Bascom surgery. This was a previous year question beta. Yaad rakhna that pilonidal sinuses are treated with, answer is Bascom surgery, where we do excision of that area or excision of the tissue which contains this pilonidal sinuses. Whereas another option which is there is nothing else but a rhomboid or a Limburg flap. You might have seen now, you raise a rhomboid shaped flap beta, and then you turn the flap and you cover the area which is exposed, right? So you are going to raise a rhomboid flap from here. You definitely turn the axis of the flap and you cover the exposed area. That is known as the rhomboid or the Limburg flap. Clear hai? Chalo. So in a PYQ they asked you, a picture of rhomboid flap was given and they asked you, the below given flap is used for the treatment of, answer is nothing else but pilonidal sinus. Clear? Now next condition which is there, it is nothing else but hemorrhoids. We know hemorrhoids is also known as piles, also known as bawasir beta. Now what is basically hemorrhoids? To understand, whenever the pressure in the rectal sinusoids, okay, whenever the pressure in the rectal veins or the rectal or not exactly veins, sinusoids I will prefer calling them. So whenever the pressure in the rectal sinusoids will increase, these rectal sinusoids will get dilated and they will become tortuous. These dilated and tortuous sinusoids are classically called as hemorrhoids. We know if the pressure in this sinusoid increases too much, or if the pressure in this varices increases too much, they may rupture and that can cause bleeding per rectum. Clear? I hope all of you are quite aware that hemorrhoids can be of two types, and that depends on the location, right? In the anal canal we have a line, and that line which is there is known as the dentate line. Barabar? In the anal canal we have a line that is classically known as the dentate line. Yaad rakhna, all the hemorrhoids that are above the dentate line are called as my internal hemorrhoids. All the hemorrhoids which are below the dentate line are known as your external hemorrhoids. We know that above dentate line it is internal hemorrhoid, below dentate line is external hemorrhoid. Do remember, internal hemorrhoids are much more common. Internal hemorrhoids are very, very common, and remember always that internal hemorrhoids are painless. Why? Because the area above dentate line is supplied by hypogastric nerve plexus, and this hypogastric nerve plexus which is there, it does not carry any pain fibers. Okay, so above dentate line any problem is always painless because the hypogastric plexus does not carry pain fibers. But if there is any problem below the dentate line like the external hemorrhoid, it is extremely painful. Reason? The area below dentate line is supplied by the branches of pudendal nerve, and as it is supplied by the branches of pudendal nerve, it carries pain fibers, so it causes a lot of pain. ठीक है, above dentate line painless, below dentate line painful. Clear? Chalo, now we know hemorrhoids mein the most important risk factor is going to be constipation. So they will give you a history of chronic constipation in the patient, and followed by that they will say that the patient is having painless bleeding per rectum. They will say the patient is having painless bleeding per rectum, and we know painless bleeding per rectum which is there, it is because of the internal hemorrhoids or the internal piles. Painless bleeding per rectum which is there, it is because of internal hemorrhoids or internal piles, which are much more common. External hemorrhoids are always painful. Do remember that point. Clear? Now another classification is, do remember, if you consider anal canal as a clock beta, any hemorrhoid at the 3 o'clock, 7 o'clock and 11 o'clock position, अगर एक घड़ी की तरह मान लो तो 3, 7 and 11 o'clock position पे if there are any hemorrhoids, these have to be considered as primary hemorrhoids. This was the PYQ again. So any hemorrhoids which are seen at the 3, 7 and 11 o'clock position, these are referred to as primary hemorrhoids. Any hemorrhoids in the 3, 7 or 11 o'clock position are considered as the primary hemorrhoids or the primary piles. Anywhere else apart from this are secondary hemorrhoids. इसके अलावा कहीं और हो तो those are considered as secondary hemorrhoids. ठीक है, तो 3, 7, 11 o'clock will be primary hemorrhoids, has to be remembered. Chalo, great. Now if I talk about in cases of hemorrhoids, what is going to be the investigation of choice? Let's say patient comes to you with a complaint of mass coming out and bleeding per rectum. Okay, you suspect it to be a case of hemorrhoids. So what is going to be the investigation of choice if a patient is diagnosed with hemorrhoids? The investigation of choice in a case of hemorrhoid is nothing else but, very good, proctoscopy. The investigation of choice in a patient suffering from hemorrhoid is nothing else but proctoscopy to be done. Okay, so proctoscopy is needed just to diagnose hemorrhoids. Please tell me, proctoscopy is absolutely contraindicated in which condition? Proctoscopy is absolutely contraindicated in which condition? Let me know in the chat box. Now do remember there are 4 degrees or 4 grades of hemorrhoids. If I talk about these 4 grades of hemorrhoids, is the first degree hemorrhoid mein there is no prolapse, that is no mass is hanging beta, there is only bleeding per rectum. So first degree hemorrhoids mein there is no prolapse, only bleeding. Second degree hemorrhoids mein yes, a mass comes outside or there is a prolapse of mass upon bearing down, but it shows a spontaneous reduction. ठीक है, it basically goes back spontaneously on its own, अपने आप वापस चला जाता है वो मास अंदर. Next, third degree hemorrhoid. Okay, third degree hemorrhoid में yes, a mass comes out, that means there is a prolapse upon bearing down, but it needs a manual reduction. So once the mass comes outside, you have to push it back manually. That is known as third degree hemorrhoid. And last, fourth degree hemorrhoid, if I talk about, the mass is always prolapsed outside and it cannot be reduced manually. The mass is always hanging outside and it cannot be pushed back or it cannot be reduced manually. That is what is important. समझे बात यहाँ तक? So do remember, first degree, no prolapse. Second degree, spontaneous reduction. Third degree, manual reduction. Fourth degree, no reduction possible. Clear? It is usually contraindicated in cases of anal fissure because they are extremely painful. It is contraindicated in cases of anal fissure because they are extremely painful. Okay? Now, in cases of hemorrhoids, do remember, if it is a case of first degree hemorrhoid, you will just go for lifestyle modification. So first degree hemorrhoids may advise lifestyle modification just to prevent constipation in the patient. That is, advise the patient high fiber diet. Okay, advise high fiber diet. Also advise plenty of fluids. Okay, and you can also ask the patient to avoid fatty meals or meat beta because that increases the risk of constipation. Okay, so high fiber diet, plenty of meals, that is what is important to be remembered. Clear? Next important, if I talk about a second degree hemorrhoids. If I talk about second degree hemorrhoids, do remember Here there are two options that I can have. One is known as banding. Now what do I mean by banding? Here we are actually going to apply a rubber band at the base of the hemorrhoidal mass. If you apply a band at the base of the hemorrhoidal mass, the blood supply to the hemorrhoidal mass will not be there, and therefore the mass is going to fall off. Okay? As you apply the rubber band at the base of the hemorrhoidal mass, do remember the blood supply to the hemorrhoidal mass is cut off, and therefore the mass undergoes necrosis and it falls off eventually. Clear about that? Is important. Followed by banding, the another procedure which is there is known as sclerotherapy. Okay, like we did in cases of varices, esophageal varices. Similar manner, here also we can go for a sclerotherapy when we can inject a sclerosing agent at the base of hemorrhoids, and this sclerosing agent is most commonly the 3% sodium tetrahedral sulfate, right? The most common sclerosing agent used is 3% sodium tetrahedral sulfate. So do remember, banding is always the preferred procedure. Reason, it is much safer as compared to sclerotherapy. But if banding cannot be done, or if banding is tried, then you may go for nothing else but sclerotherapy. Hopefully clear hai? Chalo. Next important, if I talk about a case of 3rd or 4th degree hemorrhoid. Do remember, 3rd and 4th degree hemorrhoids mein, we prefer going for a surgery. And the surgeries that we do for a 3rd or 4th degree hemorrhoid, they can be of two types. One is, I can go for a stapled hemorrhoidopexy. Yesterday itself we have discussed, we can use a circular stapler. And with the help of the circular stapler, we can definitely cut, and we can definitely cut the hemorrhoids and immediately staple the base, right? So we know we can use the circular stapler and go for a stapled hemorrhoidopexy, which is actually considered as surgery of choice in majority cases of 3rd and 4th degree hemorrhoids nowadays. But another procedure is known as hemorrhoidectomy, the conventional hemorrhoidectomy. इसमें क्या करते हैं? Obviously we have to excise or we have to remove the hemorrhoidal mass. That is known as hemorrhoidectomy. Do remember this, ठीक है? So stapled hemorrhoidopexy will have less discomfort, better recovery or faster recovery, and less bleeding. Okay, but hemorrhoidectomy is usually preferred whenever there is going to be a recurrence. Recurrence के cases में we have to better go for a hemorrhoidectomy then. ठीक है? चलो. Next is this case over here, which states that a patient complains of painful bleeding per rectum. A patient is complaining of painful bleeding per rectum, and the patient gives history of constipation and hard stools. Okay, the patient is giving history of constipation or hard stools. What is the likely diagnosis? So if the person is going to have constipation or hard stools, when these hard stools will pass out of the anal canal, they will cut the anal epithelium or they will cut the anal canal beta, and that is actually going to cause this classical anal fissure. This cut or this breach that you are able to see, it is nothing else but classically known as anal fissure. Samjhe baat? So do remember, the diagnosis in this condition is nothing else but anal fissure, also called as fissure in ano. This condition is classically known as anal fissure, also called as fissure in ano. Okay? So whenever they say patient comes to you with complaints of painful bleeding per rectum along with a history of constipation or hard stools, one of the leading cause is anal fissure. And if there is anal fissure, do remember, investigation is just external inspection. Yes, investigation of choice is only external inspection. Don't do any kind of DRE or digital rectal examination. Don't go for any kind of proctoscopy. I always say, if you try to forcefully do a DRE or proctoscopy in a patient of anal fissure, do remember, patient is facing towards the wall, but his legs are facing you. You will get kicked so hard, beta, that you will remember that never ever do a DRE or a proctoscopy in a patient suffering from anal fissure. Has to be kept in mind. Clear? Because it is extremely painful. Treatment. In cases of anal fissure, you can go for lifestyle modification. Here also the risk factor is same. Here also the risk factor is nothing else but constipation or hard stools. So again, advise the patient same advices as hemorrhoids. That is, high fiber diet, plenty of fluids, avoid fatty meals or meat. These are the advices that you can give. Now, apart from lifestyle modifications, beta, another very important advice that you give is sitz bath. What is sitz bath? This can also be recommended in hemorrhoids, but it is more important over here. That is nothing else but ask the patient to take warm water in a tub, and the patient has to sit in that tub so that the patient will have pain relief, beta. and without excessive pain. ठीक है, without excessive pain, please remember the patient will pass the stools easily. ठीक है, without excessive pain the patient will be able to pass the stools easily. समझे? चलो, so these are the things that you have to remember. Next important is you can also prescribe laxatives or stool softeners like lactulose syrup, and these laxatives or stool softeners which are there, they will make the passage of stools much easier and painless. Apart from that, as it is extremely painful condition, also give some analgesics or painkillers for local application like 2% xylocaine jelly, diltiazem ointment, nitrate gel, right? These kind of procedure, these kind of ointments or these kind of gels can be given for local application for the purpose of pain relief. Clear hai baat? Chalo. Yes, it is usually recommended in hemorrhoids also, as I've told you. SIDS bath mainly. ठीक है? Surgery, if I talk about, it is nothing else but a lateral anal sphincterotomy. Do remember, a lateral anal sphincterotomy can be done in a case of fissure, but it is not very commonly recommended. Reason: when we make incisions over this anal sphincters laterally, there is a very high risk that the cuts or the incisions may go deep and the sphincters will get permanently damaged, leading to anal incontinence or a fecal incontinence. Due to the risk of anal or fecal incontinence, the lateral anal sphincterotomy is not a very preferred choice. We try to manage the patient conservatively or with lifestyle modifications. If not managed, then we go for a surgery. Clear hai? Next is nothing else but a case of perianal fistula. If I talk about a case of perianal fistula, what is that? Let's say if this is my anal canal and this is the perianal skin. So what happens is, here there is the abnormal connection between the anal canal and the perianal skin, and this abnormal connection between the anal canal and the perianal skin which develops is called as your fistula in ano or the perianal fistula. Now in pilonidal sinus, there was only a one-way opening which was there like this. Okay? In pilonidal sinus, there was only one-way opening in the perianal region. But in cases of perianal fistula, there is a two-way opening which is there. Therefore, in pilonidal sinus, there was only pus discharge from the openings. But if it is a case of perianal fistula, there is pus discharge from the opening as well as there is pus discharge even from the rectum. So as soon as they write there is pus discharge per rectum, you have to remember that this opening is somewhere connected to the anal canal also, and it is nothing else but classically known as a perianal fistula. Okay, so please remember this is the classical case. Okay, so do remember this point. If I talk about perianal fistula, याद रखना perianal fistula में, as the patient is going to have infection, the patient will have a lot of pain. ठीक है, the patient is going to have a lot of pain. Along with that, the patient will also have pus discharge per rectum. Okay, along with that, the patient will also have pus discharge per rectum. समझे? तो पस डिस्चार्ज बस ओपनिंग से नहीं होता, पस डिस्चार्ज रेक्टम से या एनल कैनाल से भी होता है. और अगर पस डिस्चार्ज एनल कैनाल से हो रहा है, दैट मीन्स यू हैव टू रिमेंबर कि कोई इंटरनल ओपनिंग भी है, एंड दैट इज अ केस ऑफ नथिंग एल्स बट पेरियानल फिस्टुला. होपफुली क्लियर. मोस्ट कॉमन टाइप, अब ये देखो, दीज आर द वेरियस टाइप्स ऑफ द पेरियानल फिस्टुला दैट यू आर एबल टू सी. नाउ इफ आई टॉक अबाउट these various types of perianal fistula, the first one, do remember this is my dentate line, this is my anorectal ring. This purple one is the internal anal sphincter. This yellow one is the external anal sphincter. अब देखो, the first one is going to be a superficial fistula. The first one which is there, it is nothing else but the superficial fistula. Next, ये दूसरा वाला जो दिख रहा है, the second one is the fistula which goes between the sphincters. So the fistula that goes between the sphincter is known as intersphincteric fistula. The second one is known as intersphincteric fistula. Third one is crossing both the sphincters. If the fistula crosses both the sphincters, it is known as transsphincteric fistula. If it is crossing both the sphincters, it is known as transsphincteric fistula. Next one, here you can see the fistula is going up and then it is opening up. So if the fistula is going upwards and then it is opening, this is known as a suprasphincteric fistula. This one is known as suprasphincteric fistula. And the last one, this fistula is completely outside the sphincter. ये sphincter के पूरी तरह से बाहर है. So if the fistula is completely outside the sphincter, it is known as nothing else but the extrasphincteric fistula. It is known as nothing else but the extrasphincteric fistula. ठीक है. So do remember this classification of fistula is known as Parkes classification, right? This classification of fistula which is there, it is known as Parkes classification. So please tell me, PYQ in the FMG exam was, according to Parkes classification, which is the most common type of perianal fistula? According to the Parkes classification, the most common type of perianal fistula, answer will be, कौन सा commonest होगा? The answer is nothing else but intersphincteric fistula. According to the Parkes classification, the most common type of fistula that you are able to see, it is nothing else but the intersphincteric fistula. Yes, so this was a PYQ, do remember. The commonest type of fistula is intersphincteric. Next is, we know in perianal fistula there is a rule that is followed, and the rule that is followed for a perianal fistula is known as the Goodsall's rule. ठीक है, the rule that is followed for a perianal fistula is classically known as the Goodsall's rule. Now what does the Goodsall's rule say? Goodsall's rule says anterior fistulas will have a straight track, whereas posterior fistulas will have a curved track. The anterior fistulas usually have a straight track beta, whereas the posterior fistula will have a curved track. That is what is the Goodsall's rule. In a PYQ they just ask you that Goodsall's rule is generally applicable for which among the following condition? Answer was perianal fistula. Okay. Now investigation of choice, this is the question. Now let me know in the chat box what should be the investigation of choice. Options are fistulogram, MRI, CT fistulogram. What is going to be your investigation of choice? Option 1 fistulogram, option 2 MRI, option 3 CT fistulogram. Answer will be, let me know in the chat box. Bolo. Investigation of choices. Very good. Among this, the answer has to be MRI beta. A T2 weighted MRI is going to be done. And whenever we do a MRI, and on that MRI, definitely if the fistula is seen, that is what is known as MR fistulogram. ठीक है, तो अगर MR fistulogram option में नहीं हो तो please prefer MRI as your answer. Clear? Only fistulogram means X-ray. ठीक है, so investigation of choice is nothing else but MR fistulogram, which is a T2 weighted MRI for the fistula that we do. Hopefully clear है बात. So these are the points that you have to keep in mind. Next important is, if I talk about if it is a high or a low fistula, what is the treatment? High and low मतलब क्या? So do remember, if this is the anorectal ring, any fistula above anorectal ring is known as high fistula. Any fistula below anorectal ring is known as low fistula. Got it? So if it is a high perianal fistula, do remember, for high perianal fistula, we usually go for a set-on thread insertion. This set-on thread which is there, it will actually help us to break the fistula beta. Okay, we will pass a set-on thread via the fistula and we keep on tightening that thread. As you keep on tightening the thread, this set-on thread, as you tighten, it will keep on breaking the fistula or the fistulous tract. Clear? That is important. Whereas low fistula which is there, basically low fistula can be treated either by a fistulotomy. Fistulotomy में we just make an incision and we cut open the fistulous tract. ठीक है, उसको पूरा खोल के रख दो fistulous tract को. So please remember, fistulotomy is just open up the fistulous tract and let it drain. Another option is fistulectomy, and we know ectomy means removal. So fistulectomy is nothing else but complete removal of the perianal fistula. So when I do a complete removal of the perianal fistula, that is known as fistulectomy. So low fistulas can be treated by either a fistulotomy or a fistulectomy. Clear about? That is important. Another question if I ask you, and that is this over here. Let me know in the chat box now. A neonate has been brought to you with the below given anorectal malformation. What is the likely anorectal malformation that you are able to see in this investigation? So I hope all of you are quite aware. What is this investigation? This investigation is the X-ray or a radiograph beta. But in this X-ray, you have held the child ulta, upside down. ठीक है, बच्चे को उल्टा पकड़ा टांगों से. So you have hold the child basically upside down. That is known as an invertogram. ठीक है, this was a previous year image based question. So in this invertogram, you are able to see we have kept a coin or we have kept a metallic marker, and you can see there is a gap between the metallic marker and the tip of gas shadow. That means the anal canal of the child is not formed or the anal opening of the child is not formed. समझे बात? That is what is classically known as nothing else but imperforate anus. तो हमें पता है whenever the anal opening is not formed, that condition is classically known as nothing else but imperforate anus. Okay, so do remember the diagnosis in this condition is which type of anorectal malformation. So the diagnosis in this condition is nothing else but a case of imperforate anus where the anal opening is not formed. Clear? Now important is, we know in cases of anorectal malformation or in cases of imperforate anus, the first investigation that I tend to do is the invertogram. The first investigation that we do is the invertogram after the first 24 hours of life. You have to do an invertogram after the initial 24 hours of life. Okay? And confirmation of diagnosis or the investigation of choice will be MRI. Right? Confirmation of diagnosis has to be done with the help of MRI. So first investigation, if they ask you, answer is the invertogram. But if they ask you what is going to be the investigation of choice, answer has to be MRI. Clear? Treatment. We know beta, all the anorectal malformations are treated according to the same type of surgery, and that is known as posterior sagittal anorectoplasty. Plasty means a repair. So we know in any cases of in any case of anorectal malformation, the surgery is same, and that surgery is nothing else but anorectoplasty, or specifically called as a posterior sagittal anorectoplasty. Okay? Now, sometimes you might have heard, now what we do is, let's say if you have cut some part of the intestine, तुमने कुछ हिस्सा intestine का निकाल दिया है, अब after you have resected some part of the bowel beta, you are not able to go for immediate anastomosis. Why? Let's say there was peritonitis or let's say there was infection. ठीक है? If you try to go for an immediate anastomosis, there will be an anastomotic leak beta. Clear? अगर इन्फेक्शन है बहुत ज्यादा है, पेरिटोनाइटिस है, और उस कंडीशन में तुमने अगर इमीडिएट एनास्टोमोसिस करने की कोशिश करी तो सूचर्स टूट जाएंगे या फिर एनास्टोमोसिस से लीक होगा. तो in those conditions, whenever there is an infection, I don't go for an immediate anastomosis. We bring out the colon or we bring out the ileum on the anterior abdominal wall and we create an opening for the structures on the anterior abdominal wall. I hope all of you are quite aware. Whenever we make an opening for the ileum or the colon on the anterior abdominal wall, that is classically known as stoma. If we are doing an opening for colon, we call it as colostomy. If we are doing an opening for ileum, we call it as ileostomy. Clear hai? Chalo. And due to this, what will happen? The patient will keep on passing stools. So yes, the patient will keep on passing stools via this colostomy or ileostomy openings beta for a span of few days. And once the infection gets resolved, you can go for a delayed anastomosis. ठीक है? तो कभी कभी stomas are temporary, कभी कभी stomas are permanent, depending on the condition. ठीक है? तो ये जो stomas करते हो, either it can be a colostomy or it can be a ileostomy. Now, these stomas definitely may have complication. So if they ask you what is the earliest complication of the stoma surgeries, what is the commonest complication of the stoma surgeries? What is the commonest complication of stoma surgeries? Let me know in the chat box. Earliest complication rather, sorry. The earliest complication of stoma surgery is nothing else but necrosis. If the stoma is not receiving enough blood supply, it will immediately undergo necrosis. So the earliest complication of stoma surgeries is necrosis of the stoma. Next, if they ask you which is the most common complication of ileostomy. So do remember, in ileostomy, the excreta which comes out is usually liquid in nature. And that liquid excreta which is there, it comes in contact with the surrounding skin. Stoma के आजू बाजू में skin है, उसके साथ वो liquid contact में आ जाता है, and that causes inflammation or a skin excoriation. Clear? So in ileostomy, the commonest complication which is there, it is nothing else but skin excoriation that happens because the effluent that comes out or the excreta that comes out in ileostomy is usually liquid in nature. Clear? Whereas colostomy which is there, in colostomy, the most common complication is a parastomal hernia. In colostomy, the most common complication is a parastomal hernia. That is, if I have created a stoma, around that the skin will become, if I have created a stoma, around that the abdominal wall will become weak. And if the abdominal wall will become weak, there is a high risk of herniation around the stoma opening. Okay, so there's a high risk of parastomal hernias beta in cases of colostomy. The most common complication of ileostomy is skin excoriation. Most common complication of colostomy is a parastomal hernia. Chalo. Next, let's talk about now, that is nothing else but appendix. So I hope all of you are quite aware. Appendix is also known as vermiform appendix. This vermiform appendix is a blind tubular structure that is usually present at the level of the ileocecal junction. We know it is present at the level of ileocecal junction. We all are quite aware that the base of the appendix is fixed. This base of the appendix is fixed. It is always found at the ileocecal junction. But this apex of the appendix may vary in the location or may vary in position. The apex of appendix can be anywhere. So if they ask you, what is the most common position for the appendix? Let me know in the chat box. This was a PYQ also. Let me know. कौन सी commonest position होती है appendix की? The most common position of appendix, if they ask you, answer is nothing else but, very good. The most common position of appendix, answer is nothing else but retrocecal. The commonest position of appendix is usually retrocecal, followed by second most common position is pelvic. So the commonest position is retrocecal or behind the cecum, followed by second most common position is going to be pelvic. Got it? Now, if they ask you which is the least common position of appendix, so I hope all of you are quite aware. The least common position of appendix, if they ask you the least common position of appendix, the answer is going to be post-ileal, that is behind the ileum. Clear hai? The least common position of appendix, if they ask you, answer is nothing else but post-ileal or behind the ileum. Hopefully clear till here. Chalo. So that is what is important to be remembered. Clear? Now if I talk about basically a condition related to appendix, and that is nothing else but acute appendicitis. Okay? If I talk about a case, that is nothing else but acute appendicitis. Do remember the point now. If I talk about acute appendicitis, it is inflammation of the appendix beta. Okay, it can be a catarrhal appendicitis or it can be an obstructive appendicitis. Let me know, if it is a case of obstructive appendicitis, what is the most common cause for obstruction? If it is a case of an obstructive appendicitis, so what is the commonest cause for obstruction? Let me know in the chat box. Very good. If it is a case of obstructive appendicitis, the most common cause for obstruction is nothing else but fecalith. So we know due to constipation, the patient develops a fecalith beta, a hard stool stone, and that fecalith is going to commonly block the mouth of the appendix, leading to an obstructive appendicitis. Yes. Important is if they ask you, what is the age group? So do remember, yaad rakhna, appendicitis is very commonly seen in around 10 to 25 years of age group. Okay? Appendicitis is more commonly seen in second decade of life. That is usually around 10 to 25 years of age group is the commonest age group in which appendicitis will present to us. In cases of appendicitis, we know the patient will have various features like anorexia, abdominal pain, fever, nausea, vomiting. Okay, and depending on these features beta, we will suspect whether my patient is having a chance of appendicitis or not. Clear? So if I am going to suspect appendicitis, do remember the score I use to calculate the suspicion of appendicitis is known as the Alvarado score, also referred to as the Mantel score. Okay, the score we use to calculate is known as the Alvarado score, also called as the Mantel score. Now if I talk about the Alvarado, the Mantel score, Mantel is an abbreviation of the 8 parameters seen in this score beta. What are the features of Mantel score? First is migratory right iliac fossa pain. Why I am calling it as migratory right iliac fossa pain? Reason, we know appendix is present in the right iliac fossa, but the pain starts from the umbilicus and then it radiates to the right iliac fossa. Let me know the reason. Which is that nerve segment or which is that dermatome that is known to supply the umbilicus as well as the right iliac fossa, due to which the pain in acute appendicitis radiates or the pain in acute appendicitis migrates from the umbilicus till the right iliac fossa. That was the PYQ. Very good. Shabash. So migratory right iliac fossa pain happens in case of acute appendicitis due to a nerve segment or due to a dermatome known as T10. ठीक है, तो migratory right iliac fossa pain happens, it is going to be according to prevalence. Please remember it is breast, but according to incidence, last year incidence, basically it is lung cancer. That is what I've clarified now yesterday also. Okay. So migratory right iliac fossa which is there, please remember that migratory right iliac fossa, okay, migratory right iliac fossa pain will be there due to T10, and that is given a score of 1. A stands for anorexia. Anorexia or loss of appetite is given a score of 1. N for nausea and vomiting. Nausea and vomiting is again given a score of 1. Next, signs mein, do remember T for tenderness. Tenderness in the right iliac fossa or tenderness at the McBurney's point is a very special feature, and that is given a score of 2. So tenderness in the right iliac fossa is given a score of 2. R for rebound tenderness, also known as Blumberg sign. Rebound tenderness means patient does not have any pain on palpation. Patient has pain on release. Okay? So that is known as rebound tenderness, which is given a score of 1. Next is elevated temperature, that is fever. So elevated temperature or fever has a score of 1. Next, lab findings. Leukocytosis. Leukocytosis is the increased total leukocyte count or an increased total WBC count. That is a specific feature again, that is given a score of 2. And when you see the differential leukocyte count, in differential leukocyte count there is shift to left. Shift to left matlab there is more amount of immature cells or there is more amount of immature neutrophils. So if you are able to find more amount of immature neutrophils beta, we call it as shift to left, and that is given a score of 1. Clear? And the total score of Mantrals is going to be 10. The total score of Mantrals which is there, it is going to be 10. Yaad rakhna. Now if I say if the patient score is less than 5, there is no suspicion of appendicitis. We know whenever the patient score is less than 5, there is no suspicion of appendicitis. When the patient score is 5 or 6, there are equivocal chances of appendicitis. What do I mean by equivocal? 50-50% chances. Matlab it may or may not be acute appendicitis. Beta. Clear? So 5 or 6 score is suggestive of equivocal chance. But whenever the score is going to be more than equal to 7, whenever the score is more than equal to 7, it is definitely suspicious of appendicitis or it is suggestive of appendicitis beta. Okay? So it is suspicious of or suggestive of appendicitis in the patient. Clear? Whenever the Mantral score or the Alvarado score is going to be more than equal to 7, we know it is suggestive of or suspicious of appendicitis. That is what is important to be remembered. Now please tell me which is the most dangerous score over here. Which is the most dangerous score in a case of Mantros or Alvarado? Among these, which is the most dangerous score? Let me know in the chat box. Very good. So yaad rakhna beta, the most dangerous score is going to be 5 or 6. Reason is that's the here if in case you do not do a CCT and if it was a case of acute appendicitis and you discharge the patient will come back to you with appendicular perforation. So it's better that always go for a CCT abdomen if the patient is having an equivocal score of around 5 or 6. Clear hai baat? Chalo. Now if they ask you what are the signs, we know in cases of acute appendicitis there are various signs seen. First is the Rovsing sign. Now what is Rovsing sign? If I palpate the left iliac fossa, the patient experiences pain in the right iliac fossa. Okay? So palpation of left iliac fossa causes pain in the right iliac fossa. That is what is classically known as nothing else but the Rovsing sign. Next is Blumberg sign. What is Blumberg sign? When I palpate, at that time patient does not have pain, but as I release, now patient has pain. That is rebound pain or rebound tenderness. The rebound tenderness is classically known as Blumberg sign. Next, psoas sign. Psoas sign matlab whenever I hyperextend my right hip. So let's consider this is your right leg. So if you are going to hyperextend your right hip, the patient has pain in the right iliac fossa called as psoas sign. So whenever the location of appendix is retrocecal, the psoas sign will be positive. Okay? So whenever the location of appendix is retrocecal, psoas sign is positive. Next, obturator sign. Obturator sign, let's consider this is the lower limb. So if you do flexion and internal rotation of the right hip, whenever you do flexion and internal rotation of the right hip, that causes pain. It is known as the obturator sign. Obturator sign is positive whenever the location of appendix is pelvic. So whenever the location of appendix is pelvic, that is known to cause obturator sign. Clear? There are multiple other signs. These are the important ones. Samjhe? Investigation of choice. We know the same logic applies everywhere. If the patient is a small child, then the investigation of choice is an ultrasound abdo. If the patient is a small child, then the investigation of choice is an ultrasound abdomen. But if the patient is an adult, then the investigation of choice is CECT abdomen. Then the investigation of choice is nothing else but CECT abdomen has to be remembered. Now we know if a patient comes to us with complaints of acute appendicitis, always go for an appendectomy or always go for removal of the appendix. Okay? So if you do not go for an appendectomy, there will be a risk of an appendicular perforation. So acute appendicitis is the most common surgical emergency, beta. So do remember appendectomy is necessary. Either you can go for an open appendectomy or you can go for a laparoscopic appendectomy. Okay? Either you can go for an open or a laparoscopic appendectomy. If I go for a open appendectomy, I hope all of you are quite aware, you have to make an incision, beta, in the right iliac fossa. And the incision that I make in the right iliac fossa can be of two types. Do remember, if I make a oblique incision in the right iliac fossa, okay, it is known as my McBurney's incision. If I make an oblique incision in the right iliac fossa, it is known as my McBurney's incision. But if I make a transverse incision in the right iliac fossa, 2 centimeters below the umbilicus, if I make a transverse incision in the right iliac fossa, it is known as my Lanz incision. Okay? So oblique incision is known as McBurney's incision, whereas the transverse incision is known as the Lanz incision. This have been an image-based question which have been asked in the exam, so be aware. Hopefully clear hai yahan tak. Next important. Okay, do remember if available laparoscopic appendectomy or laparoscopic appendicectomy is always preferred. The reason being a better recovery or a faster recovery will be there with less risk of complications. Clear? Next important question says, this was a PYQ in FMGE exam. A pregnant female presents to you with complaints of acute appendicitis. Please let me know what is going to be your what is going to be your treatment of choice. One is conservative management, second is Ochsner-Sherent regime, third is elective appendectomy, fourth is emergency appendectomy. If they say a patient who is pregnant has come to you with complaints of acute appendicitis, please tell me what is the treatment of choice. Should it be conservative management, Ochsner-Sherent regime, emergency appendectomy or elective appendectomy? Very good. If a pregnant female comes to us with complaints of appendicitis, do remember we have to go for an emergency appendectomy. Reason is pregnancy is an immunocompromised state. In this pregnancy, which is an immunocompromised state, if you do not go for a surgery, the patient will have a very high risk of appendicular perforation. And if appendicular perforation happens, not only the fetus, but even the mother's life will be at a risk. So that's the reason, beta. Do remember this was a PYQ. Pregnant female with acute appendicitis, treatment has to be an emergency appendectomy. Clear hai baat? Chalo. Now here the question says, a patient was diagnosed with a case of acute appendicitis and now a lump is palpable in the right iliac fossa. What shall be the treatment used in this patient? Bolo. What is the diagnosis? If a patient has been already diagnosed with appendicitis, now a lump is palpable in the right iliac fossa. Why the lump is palpable? We know. As the appendix is inflamed, beta, what happens? The omentum gets wrapped or the omentum gets adhered to the appendix. Okay, omentum chipak jata hai appendix se. And as the omentum gets adhered or the omentum gets wrapped around the appendix, that's the reason why you are able to feel or you are able to palpate that lump. So yes, the diagnosis of this case is nothing else but appendicular lump. July 2023 FMGE it was, and it has been asked multiple times earlier also. So the diagnosis is appendicular lump. If the diagnosis is appendicular lump, should your management be conservative or surgical? So we know whenever the diagnosis of the case is going to be an appendicular lump, we know appendicular lump forms due to adhesions. And when there are too many adhesions, I don't go for a surgery. Reason, if I try to go for a surgery during excessive adhesions, while removing those adhesions, I may damage the bowel or I may injure the bowel. So during excessive adhesions, don't go for a surgery. Okay, wait for the surgery, beta, and you have to go for a conservative management. Shabash. And that conservative management which is there, it is classically known as nothing else but a Ochsner-Sherin regime. Very good. So appendicular lump, if it is diagnosed in a patient, do remember we have to go for conservative management. And that conservative management that we do in a case of appendicular lump is classically referred to as the Ochsner-Sherin regime. And we know conservative management in surgery, I've already told you. First, keep your patient NPO or nil per oral. Give IV fluids, give IV antibiotics, and give painkillers, that is analgesics. Clear about? So that is what is done usually in the Ochsner-Sherin regime or in the conservative management. When you are giving conservative management according to the Ochsner-Sherin regime, please monitor the patient's condition. Monitor the vitals, monitor the lump, monitor fever, everything. Okay? If you see the patient is recovering, if you see the patient's condition is improving, if you see the patient recovers, then better is to discharge the patient now. And after discharging the patient, call him after a span of 6 weeks. As you call the patient after a span of 6 weeks, then go for an interval surgery or an interval appendectomy. Why? Because in the 6 weeks, the inflammation will get resolved somewhat, the adhesions will get resolved. Or एक बार adhesions निकल जाएंगे, then it will be easier for you to operate. Okay, so please remember, if the patient recovers, discharge the patient, call him back after 6 weeks, and then go for an interval surgery or an interval appendectomy. Clear? But in case if I say, when you're monitoring the patient, if the patient's condition worsens, okay, it was a case of appendicular lump, but the patient's condition does not improve, rather it worsens by conservative management. That means this condition has already progressed to the stage of appendicular abscess. And if this condition has progressed into the stage of appendicular abscess, then immediately go for an extraperitoneal drainage. In those conditions, you have to go for a extraperitoneal drainage. Hopefully clear hai? Chalo, as I always say that one word can change answers in clinical questions, and that is this. They will give 3-line history of appendicitis and one word they will mention, and that is lump. And that changes your answer from appendectomy to conservative management. Samjhe baat? Next organ if I talk about is nothing else but pancreas. If I talk about pancreas now, so do remember most common congenital anomaly of pancreas if they ask you. If they ask you which is the most common congenital anomaly of pancreas, do remember it is a condition known as pancreas divisum. Most common congenital anomaly of pancreas is nothing else but called as pancreas divisum. Okay? The commonest congenital anomaly in pancreas is classically called as pancreas divisum. That is when both the ventral and dorsal bud of pancreas do not fuse with each other. That problem is known as pancreas divisum. और याद रखना pancreas divisum में the patient will have a high risk of pancreatitis. In pancreas divisum there is a very high risk of pancreatitis. Clear? The question is over here that states a male patient presents to the ER or male patient presents to the emergency room with complaints of sudden onset severe epigastric pain. Patient is having a sudden onset severe epigastric pain which is radiating to the back, and this pain which is there in the epigastrium and it is radiating to the back, it worsens whenever the patient lies supine beta. Whenever the patient will lie supine, the pain worsens and it is relieved on bending forwards. So whenever the patient bends forwards, obviously the symptom or the pain gets relieved. Along with that, patient is also having fever, nausea and vomiting like features. What is the likely diagnosis? So we know if there is a middle-aged male patient coming to you with the complaint of sudden severe epigastric pain radiating to back, and this epigastric pain worsens on lying supine and relieves on bending forward, it is a classical case of acute pancreatitis beta. बराबर है? It is a classical case of acute pancreatitis that has to be kept in mind. Now please tell me what is the most common cause of acute pancreatitis. Let me know in the chat box what is going to be the commonest cause of acute pancreatitis. If they ask you what is the most common cause of acute pancreatitis, do remember, yes, most common cause of acute pancreatitis will be gallstones. The commonest cause of acute pancreatitis will be gallstones. Followed by that, the second most common cause is going to be alcohol. The most common cause of acute pancreatitis is gallstones. Followed by that, second most common cause is going to be alcohol. chronic pancreatitis पूछा जाए तो do remember chronic pancreatitis में the most common cause is alcohol, but acute में the most common cause is gallstones followed by alcohol. Gallstones will block the opening of the main pancreatic duct, due to which the pancreatic secretions are not able to drain, and that is the reason what happens, the pancreatic enzymes get activated within the pancreas and start damaging the own pancreatic tissue, causing pancreatitis. Children, may let me know what is the most common cause. With sign. So please tell me basically, beta, what is going to be the most common, what is the most common cause for acute pancreatitis in children? What is going to be the most common cause for acute pancreatitis in children? Let me know in the chat box. Yes, very good. So do remember the most common cause for acute pancreatitis in children is nothing else but blunt abdominal trauma. And which kind of blunt abdominal trauma? Usually a bicycle handle injury. You might have seen now, these small children, they may have a bicycle handle injury in the epigastrium. And this blunt abdominal trauma is the leading cause for acute pancreatitis in children. That has to be remembered. Anybody, which anti-diabetic drugs are known to increase the risk of acute pancreatitis? Let me know in the chat box. Which anti-diabetic drugs are known to increase the risk of acute pancreatitis? Let me know in the chat box. An important question. Which anti-diabetic drugs may increase the risk of acute pancreatitis? Now we know sometimes the acute pancreatitis can be hemorrhagic in nature. That is, it will cause bleeding and there will be hemoperitoneum. And the classical signs of hemoperitoneum will be observed. First is what? You are able to see there is bruising around the umbilicus. And we know this bruising around the umbilicus is classically referred to as the Cullen sign. The bruising around umbilicus which is there, it is classically known as the Cullen sign. Whereas second one, you are able to see the bruising in flanks. And we know this bruising in flanks which is there, it is classically referred to as the Gray Turner sign. The bruising in flanks which is there, it is classically known as the Gray Turner sign. Clear hai? So do remember, bruising around the umbilicus is known as Cullen sign. Bruising in the flanks is known as the Gray Turner sign. These are the features of acute hemorrhagic pancreatitis or hemoperitoneum. Please tell me, Cullen sign and Gray Turner sign will be a differential for which obstetric condition? कौन सी ऐसी ऑब्स की कंडीशन है जिसमें these signs can be seen? Let me know in the chat box. Very good. Yes, semaglutide is the drug. That is nothing else but the GLP-1 analogs. So GLP-1 analogs like semaglutide, liraglutide, they are the ones basically. Do remember. ठीक है? Flankus sites. So please remember semaglutide which is there, or GLP-1 analogs are there. They increase the risk of acute pancreatitis. Do remember it was a recent NEET PG question. ठीक है? From pharma. Very good. Yes, ruptured ectopic pregnancy will have these signs of hemoperitoneum as well. Ruptured ectopic pregnancy can be a differential for this condition because it will also have these signs of hemoperitoneum also. Clear? Now if they ask you what is the radiological investigation of choice in acute pancreatitis, तो याद रखना, the radiological investigation of choice in acute pancreatitis is nothing else but CECT abdomen beta. तो याद रखना, pancreas is a retroperitoneal organ, and henceforth remember one point. For all the retroperitoneal organ, the best radiological investigation is always a CECT abdomen or a contrast enhanced CT scan of abdomen. Whichever retroperitoneal problem it may be, beta, do remember CECT abdomen is the best radiological investigation. Clear about? So radiological investigation of choice is nothing else but CECT abdomen that you have to remember. Clear? And this is how the CECT abdomen will look like. There is the inflamed or edematous pancreas, and around this inflamed or edematous pancreas, you are able to see this hyperdensity, which is due to the blood collection or which is due to the bleeding beta. Clear? Chalo. Now, we know that CECT abdomen is done after 3 days, or CECT abdomen in acute pancreatitis is done after 72 hours. Reason, we don't want to underestimate the necrosis beta. Clear about? So please tell me, in cases of acute pancreatitis, what is the investigation that confirms a diagnosis? Because CECT, so we are going to do after 3 days. So how do we confirm a diagnosis of acute pancreatitis then? If CECT is not done early, then what is done to confirm the diagnosis of acute pancreatitis? Very good. Shabash. Yes. So if CCT is done after 3 days, the best investigation to confirm a diagnosis of acute pancreatitis is going to be a serum lipase followed by serum amylase. So we know serum lipase and serum amylase, like pancreatic enzymes, will be grossly elevated in acute pancreatitis. But the more specific one will be serum lipase beta. Serum amylase is not very specific. That has to be remembered. Clear about? Very good. Yeah, these enzyme levels will be grossly elevated in the patient's blood, and that confirms a diagnosis. Now, if they ask you what is the CT severity index, which will tell us about the severity of pancreatitis. Matlab, depending on the CT scan findings, if you have to find out whether it is a case of mild, moderate or a severe pancreatitis, that is going to be done with the help of a CT severity index, very good, known as Balthazar grade. So depending on the CT findings, beta, if you tell me about the severity of pancreatitis, that is going to be the Balthazar grading. That is known as Balthazar grading. Now, clinical severity score, if they ask you, that is depending on the signs, symptoms or clinical manifestations of the patient. If you decide the severity of pancreatitis, patient के signs symptoms के ऊपर से अगर तुम मुझे बता रहे हो कि patient को severe pancreatitis है या नहीं, then that clinical severity score is classically known as Ranson's score or the Ranson's criteria. This has been a PYQ. The clinical severity score in cases of acute pancreatitis is classically known as Ranson's score or the Ranson's criteria. Do remember, if the Ranson score is more than equal to 3, then we say it is a severe pancreatitis. अगर 3 या 3 से ज़्यादा है, then we say it is a case of severe pancreatitis. Clear? Now treatment. We know in cases of acute pancreatitis, we usually don't go for any surgery. The treatment of acute pancreatitis is nothing else but conservative management. The treatment of acute pancreatitis is nothing else but conservative management to be done. समझे यहाँ तक बात? So conservative management has to be done if it is a case of acute pancreatitis. And as we know all, conservative management में the 4 things that we do. We have to keep the patient NPO or nil per oral, give IV fluids, give IV antibiotics and give analgesics or painkillers. Do you remember, in cases of acute pancreatitis, give broad spectrum antibiotics like meropenem and all. Clear? Chalo. Next is this complication of acute pancreatitis. Let me know in the chat box. A patient presents to you with complaints of epigastric fullness along with epigastric pain and early satiety. Early satiety means खाना खाने के बाद इमीडिएटली 1 या 2 रोटी खाने के बाद इमीडिएटली पेशेंट को फुलनेस लगती है या फुलनेस महसूस होती है. ठीक है, तो द पेशेंट का पेट जल्दी भर जाता है. दैट इज अर्ली सटाइटी. ठीक है, सो एपिगैस्ट्रिक फुलनेस, पेन एंड अर्ली सटाइटी along with vomiting. CCT abdomen is done and it reveals the below given finding. You are able to see in the retroperitoneum there is some hypodensity or there is some collection of fluid that is seen. ठीक है, in a sac. What is the likely diagnosis? What is this likely complication in a case of acute pancreatitis? So after an episode of pancreatitis, the patient starts experiencing epigastric fullness, pain, early satiety, nausea, vomiting like features. Yes, we know it is due to a collection of fluid in the granulation tissue, classically known as pseudocyst or a pancreatic pseudocyst. समझे बात? So the diagnosis in this condition is nothing else but a pseudocyst or a pancreatic pseudocyst. The commonest location where this pancreatic pseudocyst is developed is known as the lesser sac of omentum. ठीक है, ये जो pancreatic pseudocyst है, that usually develops in the lesser sac of omentum. So inside the lesser sac of omentum, you see this pancreatic pseudocyst has developed. Okay. Now majority cases में the pseudocyst is going to be small in size and it is going to spontaneously resolve. तो अपने आप ठीक हो जाता है वो. But there are some conditions where the pseudocyst will not spontaneously resolve. ठीक है, there are few conditions where the pseudocyst does not spontaneously resolve and it may start causing pressure symptoms like these. Then we have to go for treatment. So do remember, what is the indication for treatment? Indication for treatment is if the cyst is more than 6 weeks old. We know majority pseudocyst resolve within a span of 6 weeks. But if the cyst is more than 6 weeks old, next, if the size of the cyst is more than 6 centimeters, or if the wall thickness in the cyst is more than 6 mm. The rule of 6 you can remember. Yes, the cyst is more than 6 weeks old, the size is more than 6 centimeter, or the wall thickness is more than 6 millimeter. In this condition, we have to go for surgical intervention or we have to go for drainage of the cyst. Do remember, either I can go for a cystoenterostomy or we can go for a cystogastrostomy. Okay, either we can go for a procedure where we do an internal drainage. Internal drainage matlab open up the cyst into the intestine called as cystoenterostomy, or open the cyst into the stomach known as cystogastrostomy. But if the cyst is infected, then we cannot do an internal drainage. अगर cyst infected है तो internal drainage possible नहीं है. In those conditions, we have to go for a external drainage, and that is done with the help of the classical pigtail catheter. So external drainage has to be done with the help of the pigtail catheter under ultrasound guidance. Hopefully clear है बात. चलो. Next, if I talk about the next one, that is nothing else but the pancreatic neuroendocrine tumors. If I talk about the pancreatic neuroendocrine tumor, yesterday itself I have told you neuroendocrine means the tumors which are going to secrete some hormone or some neurotransmitter like substance. A lot of people take it lightly, but do remember recently also there has been a question, and they have commonly been asking questions on pancreatic neuroendocrine tumors. So don't skip this topic at all. Most common pancreatic neuroendocrine tumor overall, if they ask you, answer is a non-functional PPOMA. The most common type of a pancreatic neuroendocrine tumor overall is a non-functional PPOMA, or we can call it as a non-functional pancreatic polypeptide tumor. Okay, either you can call it as a non-functional PPOMA, or you can call it as the non-functional pancreatic polypeptide tumor. Okay. Next, if they ask you then which is the most common functional neuroendocrine tumor of pancreas, याद रखना the most common functional neuroendocrine tumor of pancreas is nothing else but an insulinoma. We know the most common functional neuroendocrine tumor of pancreas is an insulinoma. That has to be remembered. Now याद रखना that majority cases, almost 90% cases of insulinoma which are there, they are benign in nature. We know 90% cases of insulinoma, they are usually benign in nature, beta. And this insulinoma usually arises from the beta cells of pancreas, and it causes excess secretion of insulin. If there is an excess secretion of insulin in insulinoma, the patient has a classical triad seen known as Whipple's triad. Do remember Whipple's surgery is done for pancreatic cancer, but Whipple's triad is the feature of insulinoma. Whipple's triad mein, as there is high level of insulin, the patient will have a fasting hypoglycemia beta. The patient will have fasting hypoglycemia. Second, blood glucose less than 40 milligrams per deciliter. And third, if you give glucose, the patient symptoms will get resolved. अगर ग्लूकोज खिला दोगे पेशेंट ठीक हो जाता है. ठीक है, तो फास्टिंग हाइपोग्लाइसीमिया, ब्लड ग्लूकोज लेस देन 40, और डेफिनेटली giving glucose improves the patient's condition. That is known as Whipple's triad. Gold standard investigation to diagnose the case of insulinoma. Do you remember we can check for the fasting serum insulin levels or the fasting insulin is to glucagon ratio. ठीक है, so the gold standard investigation to confirm the diagnosis of insulinoma is either a fasting serum insulin levels which will be high, or the fasting insulin to glucagon ratio which will be high again. If this is high, that confirms the diagnosis of insulinoma. Let me know what is the drug of choice. What is the drug of choice for a case of insulinoma? Let me know in the chat box. Which is that drug given in insulinoma to decrease the insulin secretion? What is the drug of choice in patients of insulinoma? Very good, shabash. The drug of choice in cases of insulinoma was a PYQ NEAT. That is nothing else but diazoxide. The drug of choice in patients of insulinoma is known as diazoxide. Has to be remembered. Clear? Whereas if they ask you treatment, so do remember, if the insulinoma is usually seen in the head of pancreas, if the insulinoma is seen in the head of pancreas, I just remove the insulinoma, or we just remove the tumor called as enucleation. If it is seen in the head of pancreas, we just remove the tumor, that is known as enucleation. If it is in the tail, then I go for a distal pancreatectomy. If it is in the tail, then we go for a distal pancreatectomy. But otherwise, head mein hai, so only enucleation to be done. Okay. Next, we know that majority cases of insulinoma are benign. So, if they ask you which is the most common malignant neuroendocrine tumor of pancreas, so do remember the most common malignant neuroendocrine tumor of pancreas is a gastrinoma. We know gastrinoma is a tumor arising from the G cells, and it causes excess secretion of gastrin hormone. Clear? The most common malignant neuroendocrine tumor of pancreas is gastrinoma, and gastrinoma is seen in a patient suffering from Zollinger-Ellison syndrome. Gastrinoma is usually seen in a case of Zollinger-Ellison syndrome. Has to be remembered. We know the most common site for that gastrinoma is nothing else but the Passaro triangle, also called as the gastrinoma triangle. The most common site for a gastrinoma to form is the Passaro triangle, also known as the gastrinoma triangle. And do remember, in the Passaro, the gastrinoma triangle, the most common site is the duodenum, not the pancreas. Yes, Passaro triangle के अंदर the commonest site for the gastrinoma to develop is the duodenum, not the pancreas. Clear? Now, we know if there is going to be hyper secretion of gastrin, that gastrin causes more stimulation of the parietal cells, and due to more stimulation of parietal cells, there is more stimulation of, there is more secretion of HCl. And if there is more secretion of HCl or more secretion of acid, the patient is going to develop recurrent peptic ulcers or giant peptic ulcers. That is a very classical feature. Yaad rakhna, in cases of gastrinoma, patient will develop recurrent peptic ulcers or giant peptic ulcers due to hyper secretion of HCl or due to hyper secretion of acid. समझे बात? If they ask you investigation of choice is what? याद रखना, investigation of choice in a gastrinoma is serum gastrin levels. So whenever the patient's serum gastrin levels are going to exceed more than 1000 picogram per ml, we know it is a confirmed case of gastrinoma. It is a confirmed case of gastrinoma. Drug of choice. We know in patients of gastrinoma, if the main problem are recurrent peptic ulcers, we have to give nothing else but PPIs, that is proton pump inhibitors. So you can give lansoprazole, pantoprazole like drugs. So PPIs are considered as the drug of choice in the treatment of gastrinoma. PPIs are the drug of choice for gastrinoma. But if they ask you what is the treatment, so do remember the treatment for a case of gastrinoma can be the Whipple surgery, or nowadays we tend to perform a modified Whipple surgery. Okay, a pylorus preserving modified Whipple surgery is the treatment that we can do for a case of gastrinoma. Clear? Chalo. So that is what is important. No issues with this. Next is a question about a pancreatic neuroendocrine tumor itself. That is, a patient has complaints of diabetes mellitus, deep venous thrombosis, depression and dermatitis. The 4 Ds which are there. Okay, diabetes mellitus, DVT, depression and dermatitis. Okay, and this dermatitis is usually seen in the form of necrolytic migratory erythema. A previous year image based question twice or thrice in the FMGE exam. Okay, this is the necrolytic migratory erythema, which is a red rash which keeps on changing the location or which keeps on changing the site beta. Okay, so this necrolytic migratory erythema along with diabetes mellitus is a very classical feature of which tumor? Very good. It is a classical feature of nothing else but glucagonoma beta. ये जो tumor है, it is a classical feature of glucagonoma. So it is a tumor arising from the alpha cells of pancreas and causes hyper secretion of glucagon. याद रखना, glucagonoma का question was asked in the recent NEET PG. Same question but different format. That is, they gave a picture of necrolytic migratory erythema and they asked you this below given finding is associated with the tumor arising from which among the following organ? Answer was pancreas. Clear? So that is how the question was framed. We know in cases of glucagonoma, due to excess glucagon secretion, there is high blood glucose levels or diabetes mellitus. Therefore, the treatment or the drug of choice will be insulin or oral hypoglycemic agents. And the definitive treatment is surgical resection or surgical excision of the tumor. Barabar hai? Chalo. Next, if I talk about basically the liver. Next, if I talk about the liver now. If they ask you which is going to be the most common malignancy in liver overall, let me know in the chat box. What is going to be the most common malignancy of the liver? Let me know in the chat box. The most common malignancy in the liver agar pucha jaye to answer will be anybody. The most common malignancy in liver, if they ask you, answer is nothing else but metastasis or secondaries. Okay, most common malignancy in liver, answer is nothing else but metastasis or secondary. We know that GIT cancers like the esophageal cancer, gastric cancer and the colorectal cancer, all these GIT cancers, they mainly spread to the liver itself. So therefore, do remember, most common malignancy in liver is going to be metastasis or secondaries. But if they ask you which is the most common primary liver malignancy, primary का मतलब the malignancy which will start from the liver itself. ठीक है, तो most common primary liver malignancy, yes it is right, that is HCC or a hepatocellular carcinoma. The most common primary liver malignancy, if they ask you, we know it is a HCC, also known as a hepatocellular carcinoma. ठीक है, do remember this point. Next is, which is the most common primary liver tumor in children? So if they ask you which is the most common primary liver tumor in children or the most common primary liver malignancy in children, answer is nothing else but hepatoblastoma. Answer is nothing else but hepatoblastoma, has to be remembered. The most common primary liver malignancy in children, if they ask you, answer is hepatoblastoma. And lastly, most common benign liver tumor in patients. Most common benign liver tumor overall, if they ask you, the most common benign liver tumor overall is a hemangioma. That is a tumor which usually arises from the blood vessels. Okay, followed by FNH, called as focal nodular hyperplasia. So the most common benign liver tumor is known as hemangioma, followed by the second most common is known as FNH or a focal nodular hyperplasia. So do remember, all the liver malignancies are more common in males. All the liver malignancy will be more common in males, but all the benign liver tumors are always more common in females. Reason, anybody? Why are all the liver malignancies more common in females? Let me know in the chat box. All the liver malignancies which are there, they are usually common in females. That is important to be remembered. Anybody, let me know the answer. Liver malignancies are more common in males, that is due to alcohol, that we all know. But why all the benign liver tumors are more common in females? By all the benign liver tumor, very good. All the benign liver tumor, they are more common in females because all these benign liver tumors are associated with OCP intake. All the benign liver tumor, whether it is a hemangioma, focal nodular hyperplasia or a hepatic adenoma, all these benign liver tumors, as they are associated with OCP intake, therefore they are more commonly seen in females. Clear? Anybody, which is the liver malignancy associated with PVC exposure? Which is that liver malignancy associated with PVC or the polyvinyl chloride exposure? PYQ it was. Which is the liver malignancy which is associated with the PVC exposure? Let me know in the chat box. It is going to be angiosarcoma. Yes, hemangiosarcoma, angiosarcoma, whatever you want to call it as. So do remember, the liver malignancy that is associated with PVC exposure is nothing else but known as the angiosarcoma. Has to be remembered. Clear about yahan tak? Chalo, great. Next important, if I talk about are the liver infections. After the liver we can take break. Okay? If I talk about liver infections now, do remember the first condition is liver abscess. Either it could be a pyogenic liver abscess or it can be a amoebic liver abscess. Okay? Now if I talk about pyogenic liver abscess, we know it is due to bacterial infection. Okay? Pyogenic liver abscess is mainly due to bacterial infections and it is usually polymicrobial, that is multiple bacteria together are known to cause pyogenic liver abscess. But agar pucha jaye, which is the single most common cause for a pyogenic liver abscess? So do remember, the single most common cause for a pyogenic liver abscess is E. coli. The single most common cause for a pyogenic liver abscess is E. coli. But we know beta, we Asians, we don't get affected with these kind of chota mota organisms like E. coli. We need dangerous organisms beta. So Asia mein, the most common cause of pyogenic liver abscess is Klebsiella. In Asia, the most common cause of a pyogenic liver abscess is Klebsiella. Barabar? So worldwide it is E. coli, but in Asia it is going to be Klebsiella. Whereas we know amoebic liver abscess, by the name it is evident. Amoebic liver abscess is caused by an amoeba, that is nothing else but Entamoeba histolytica. Amoebic liver abscess is caused by an amoeba known as Entamoeba histolytica. Clear yahan tak? Now if I talk about the pyogenic liver abscess is more commonly seen in which kind of patients? So do remember, pyogenic liver abscess is more commonly seen in the immunocompromised patients. Okay, the elderly diabetic patient, that is immunocompromised patients mein it is more commonly seen. But amoebic liver abscess is more commonly seen in alcoholics. Reason, alcoholics can consume contaminated food and water, so they initially develop intestinal amoebiasis and from there the patient develops a amoebic liver abscess. बराबर है बात? तो कुछ भी खाते हैं, that is the reason. So alcoholic patients are more commonly affected with amoebic liver abscess, especially males more common as compared to females, right? Now common symptoms in both the condition. In both the condition there is a liver infection or a liver abscess. So patient will have a right upper quadrant pain or a right hypochondrium pain. Patient will have fever. Along with that, patient is going to have jaundice, and patient may have generalized weakness or fatigue. Do remember, all these symptoms are actually going to be much more severe if a patient is suffering from a pyogenic liver abscess. Yes, pyogenic liver abscess may the patient appears more toxic, but these symptoms are going to be mild. Usually in a case of amoebic liver abscess, may the patient appears less toxic comparatively. Clear? Now, if they ask you, beta, what is going to be the lab finding? Whenever a patient comes to me with liver abscess or jaundice, the first investigation to be done is the LFT, that is the liver function test. When I do a LFT or a liver function test, yaad rakhna beta, in cases of pyogenic liver abscess, the serum bilirubin is high, the AST, ALT level is also high, but a specific feature, and that is serum ALP, that is alkaline phosphatase levels. So the serum ALP or the alkaline phosphatase levels are going to be elevated. So serum ALP is high in cases of pyogenic liver abscess. It may be normal in amoebic liver abscess. Understood? Next important, if I talk about amoebic liver abscess, here also on LFT the serum bilirubin is high, the AST, ALT levels are high. But another specific feature will be the PT-INR beta. If I check for the PT-INR, that is prothrombin time or the international normalized ratio, that is going to be prolonged. So if PT-INR is prolonged, that is more specific for a case of amoebic liver abscess. Clear hai baat? Do remember, investigation of choice. Now children mein the investigation of choice has to be ultrasound abdomen, and adults mein the investigation of choice is CCT abdomen. That is what we have discussed until now, abdominal problems ke liye, right? Now best investigation overall. See, ultrasound abdomen, CCT abdomen can show me a cavity filled with pus inside the liver, but it cannot confirm whether it is bacterial infection or amoebic infection. For that, the best investigation is, for pyogenic liver abscess, I can take the patient's blood sample or I can take the patient's pus aspirate and I can send it for culture. So blood culture or pus culture I can do beta if it is going to be a case of pyogenic liver abscess. Samjhe baat? But if it is a case of amoebic liver abscess, we know culture is not possible because amoeba cannot culture. So in a case of amoebic liver abscess, very good, you have to do a serology, and that serology can be done either with the help of an immunoblot or with the help of ELISA. In cases of amoebic liver abscess, you can go either for an immunoblot or a ELISA. That is what is important. Clear? Treatment. Now we know in cases of the pyogenic liver abscess, as it is a bacterial infection, treatment has to be IV antibiotics beta. We have to give broad spectrum IV antibiotics. Along with that, we have to go for an early aspiration or early drainage of the pus. Whereas in cases of amoebic liver abscess, we have to give an anti-amoebic drug, and the drug of choice for amoebiasis is nothing else but metronidazole. We have to give metrogel or the metronidazole drug beta. Now once you give metronidazole, then monitor the patient. If the patient's condition is improving, then only continue metronidazole only. You don't have to go for an aspiration or drainage. तो अगर पेशेंट रिस्पॉन्ड कर रहा है तो बस मेट्रोनिडाजोल देते रहो, बाकी एस्पिरेशन करने की जरूरत नहीं है, ठीक है? But if the patient's condition does not improve, in those conditions you have to go for a aspiration or a drainage. And we know whether it is a pyogenic liver abscess or a amoebic liver abscess, the aspiration or drainage is always done under ultrasound guidance with the help of pigtail catheter. Shabash. It is done with the help of pigtail catheter. Now if I talk about this picture over here, what is seen? You can see a classical picture that shows you in the intestinal wall beta, you are able to see a ulcer. And this ulcer that is seen in the intestinal wall is classically known as flask shaped ulcer. So if a patient is having intestinal amoebiasis, in a case of intestinal amoebiasis, there is going to be a classical flask shaped ulcer which is seen. This was the previous year image based question. So yaad rakhna, intestinal amoebiasis of a patient is suffering from, in those conditions, there is going to be this classical flask shaped ulcers that is important. And for intestinal amoebiasis, the drug that we give for intestinal amoebiasis, the drug that we give is known as diloxanide furoate. You will be like, why? Reason, The metronidazole is a tissue amoebicidal. Matlab, it can only kill the amoeba inside the tissue. So if you have to kill the amoeba inside the lumen, then you have to give a drug known as diloxanide furoate. Okay? So intestinal amoebiasis mein, the flask shaped ulcers are going to be seen and the drug given is diloxanide furoate. Clear? Whereas in cases of amoebic liver abscess, when we definitely aspirate the pus, you are able to get this classical pus over here. And what is this classical pus known as? This classical pus over here is known as the Uncovy sauce pus. This classical pus is classically known as the Uncovy sauce pus, and we know that this Uncovy sauce pus is also called as the chocolate pus. So Uncovy sauce pus or chocolate pus aspirated from liver is a classical feature of amoebic liver abscess. Clear about? Chalo. Lastly, the condition from liver that you need to remember, and that is nothing else but a case of hydrated cyst. When I talk about a case of hydrated cyst, do remember the most common cause of hydrated cyst, if they ask you, it is nothing else but the most common cause of hydrated cyst, if they ask you, it is nothing else but Echinococcus granulosus. We know hydrated cyst mein there is a cystic fluid collection inside the liver or in multiple other organs, and it happens basically due to the infection of Echinococcus granulosus, which is also referred to as the dog tapeworm, right? We know that this Echinococcus granulosus is also called as the dog tapeworm. This is known to cause hydrated cyst. Please tell me, beta, if there are multiple hydrated cysts, then what is the cause? If there is going to be multiple hydrated cysts, or if there is a malignant hydrated, what is the likely cause? Let me know in the chat box. Bolo. We know hydrated cyst, most commonly they are usually seen in the liver, but the second most common site for hydrated cyst will be lungs. Most common site for hydrated cyst is the liver, but second most common site will be lungs. Yes, if there is a multiloculated hydrated cyst or multiple hydrated cyst, we know, very good, it is classically caused by an organism known as Echinococcus multilocularis. Yes, it is not caused by granulosus, then it is caused by an organism known as Echinococcus multilocularis, and this was the PYQ, and that has to be remembered at any cost. Please remember this. Clear? We know if there is a hydrated cyst, patient will complain of right upper quadrant pain, or patient will have right hypochondrium pain. Patient may have fever, along with that jaundice. If they ask you what is the best investigation, तो याद रखना, the best investigation in cases of hydrated cyst is either a immunoblot or a ELISA, which will confirm that it is a infection of a tapeworm or it is an infection of Echinococcus. So immunoblot or ELISA is confirmed as the best, immunoblot or ELISA is going to be the best investigation to confirm it is a case of hydrated cyst. Beta, yes, serology, that is immunoblot or ELISA. But the radiological investigation of choice is a CCT abdo. And when you do a CCT abdomen, a classical picture, you can see a cavity inside the liver or a cyst inside the liver containing fluid. And the endocyst is floating inside this fluid. And this is classically known as this detached membrane, which is floating inside the fluid, is classically known as the water lily sign, or we can call it as the floating water lily sign. Barabar? So we call it as the classical water lily sign or the floating water lily sign, even called as the serpent sign. Even I can call it as the serpent sign. Let me know in the chat box. We have a classification in cases of hydrated cyst known as Gerbe's classification. The old classification for hydrated cyst is known as Gerbe's classification. So according to Gerbe's classification, water lily sign or detached membrane comes under which type of Gerbe's? That was a PYQ NEET. According to Gerbe's classification, the water lily sign or the detached membrane comes under Gerbe's type 2. Barabar? It usually comes under Gerbe's type 2, has to be remembered. Clear? Whereas if I talk about the WHO stage, so the new classification for the new classification for hydrated cyst is nothing else but beta. The new classification for hydrated cyst is nothing else but the WHO classification. According to WHO classification, it usually comes under nothing else but the WHO type CE3B. It commonly comes under the WHO type basically CE3B basically beta. That is what is important to be remembered. No issues with this, anybody? Clear है यहाँ तक बात? चल. Now if they ask you what is the treatment over here, तो याद रखना treatment is nothing else but we have to go for albendazole, which is the drug of choice for echinococcus infection or tapeworm infection. So you have to give albendazole. But along with albendazole, you have to go for a pair therapy. Now, what is pair? Pair therapy is nothing else but percutaneous aspiration, injection of scolicidal agents, and reaspiration. Matlab, aspirate all the fluid from the cyst, then inject scolicidal agents, wait for 20 minutes, and after that, reaspirate the scolicidal agents also. Okay? The most common scolicidal agent used is usually 20% hypertonic saline. The commonest scolicidal agent used is 20% hypertonic saline. Let's say there are some conditions जहाँ पे pair therapy is contraindicated. So if pair therapy is contraindicated, we have to go for surgery or a surgical resection. मतलब if there is a single cyst, I go for a cystopericystectomy. But if there are multiple cysts, I have to go for liver resection. If there is single cyst, go for a cystopericystectomy. But if there are multiple cysts, go for a liver resection. That part has to be removed. Clear? That was about your liver. Take a break. After the break, we will be discussing in the last session about gallbladder, bile ducts, and urology part. Okay? Sure. So hopefully all of you are there. Am I audible? To make sure to do this stage, basically the water lily sign that I've told you, the detached membrane, it is going to be Gervais type 2 of the C3A classification that has to be remembered. Clear? Chalo. Now let's talk about the next one, and that is nothing else but gallbladder. If I talk about gallbladder now, the first condition we have to talk about is known as gallstones, and we know gallstones are also known as cholelithiasis beta. Chole literally means bile, lith means stones. Okay, so gallstones are also known as cholelithiasis. Do remember there are three types of gallstone. One are cholesterol gallstones, second are the pigmented gallstones, and third are the mixed gallstones. अगर पूछा जाए most common gallstones overall, so do remember the most common type of gallstones overall are going to be the mixed gallstones. If they ask you which are the most common gallstones in Asians, so do remember Asia, man, the most common gallstone are going to be considered as the pigmented gallstone. The commonest gallstone in the Asian population is going to be the pigmented gallstone. And if they say there is a fat fertile female in her 40s beta, 4Fs we say, right? The fat fertile female in her 40s, then the most common type of gallstones are going to be cholesterol gallstones, which are made up of more than 90% of cholesterol beta. Okay, which are made up of more than 90% cholesterol. Clear? So do remember most common type of gallstones overall are the mixed gallstone. Most common type of gallstones in Asians are going to be the pigmented gallstones. Have to be remembered. Clear? Now if I talk about, we know majority cases of gallstone are usually asymptomatic, right? Mostly patients of gallstone are going to be asymptomatic. It is an incidental diagnosis. Matlab, you're doing an ultrasound for some other condition, and at that point of time you got to know, okay, the patient is having a gallstone. Now we know in cases, some cases definitely may have symptoms, and those patients who present to you with symptom is going to be a right upper quadrant pain beta. The patient will have a right upper quadrant pain or a right hypochondrium pain, which mainly worsens after meal, especially after fatty meals beta, because for fatty meals we need bile for digestion or bile for emulsification. Okay, so after eating fatty meals the patient's pain gets worsened. Sometimes patient may have jaundice also. Do remember, investigation of choice is nothing else but an ultrasound abdomen. Reason being, याद रखना, majority gallstones, that is almost 90% of the gallstones are radiolucent. That means they will appear black on the X-ray or CT scan. इसीलिए the investigation of choice is an ultrasound abdo, and on ultrasound abdomen you are able to see this classical feature. If it is a stone, behind that gallstone you are able to see a shadow beta, and that is classically referred to as nothing else but posterior acoustic shadow or the posterior acoustic shadowing. So do remember, if the gallstone is going to show, if there is a gallstone beta, you are able to see a posterior acoustic shadow behind the stone. Okay? If it is a gallstone, you are able to see the classical posterior acoustic shadow behind the stone. Hopefully clear to all of you now. So if shadowing is present, it is a case of gallstone. If shadowing is absent, it may be a case of gallbladder polyp. Clear? Next important is treatment now. Do remember, if the gallstone is symptomatic or if there is some other indication like multiple gallstone, stone more than 2 centimeters in size, patient is a salmonella typhi carrier, in all these conditions it's better to go for removal of the gallbladder. And I hope all of you are quite aware, removal of gallbladder is known as cholecystectomy beta. ठीक है, तो either you can go for a open cholecystectomy or you can go for a laparoscopic cholecystectomy. So that has to be done. So removal of gallbladder or cholecystectomy is done. Clear? Next important is this. So this is a wrong picture which has been given. So do remember basically beta, if there is a calcified gallbladder wall, this is the water lily sign again. If there is a calcified gallbladder wall beta, that condition is basically called as porcelain gallbladder. ठीक है, तो if they say what is a porcelain gallbladder, do remember porcelain gallbladder is nothing else but a calcified gallbladder wall. ठीक है, and whenever there is a porcelain gallbladder or a calcified gallbladder, do remember it is a pre-malignant condition. मतलब if the patient is having porcelain gallbladder, there is a very high risk of gallbladder cancer, and as there is a very high risk of gallbladder cancer, you need to perform a cholecystectomy or you need to perform a gallbladder removal. Clear about? Next important is this picture. Here you can see the gallbladder appears like which fruit? August 2020 FMG question. Here you can see beta, the gallbladder is having multiple cholesterol deposits, and due to this cholesterol deposits beta, the gallbladder is appearing somewhat like strawberry. So we know this condition which is there where the gallbladder appears like a strawberry is classically known as cholesteatolysis of gallbladder. This condition is classically referred to as cholesteatolysis of gallbladder, and in cholesteatolysis of gallbladder you are able to see a classical strawberry gallbladder. That has to be kept in mind. समझे बात? Do you remember this point? Do you remember strawberry gallbladder is going to be a feature of cholesteatolysis? If they ask you strawberry gums are seen in which condition, let me know in the chat box. Strawberry gums are seen in which condition? Strawberry tongue, so we all know one is Kawasaki disease and second is scarlet fever. So strawberry tongue is seen in Kawasaki disease and scarlet fever. Strawberry vagina or strawberry cervix also we know it is seen in trichomoniasis. Barabar, the strawberry tongue or the strawberry cervix or the strawberry vagina is seen in trichomoniasis. But strawberry gums, if they ask you, very good. They are seen in vaginous granulomatosis. Strawberry gums are usually a feature of vaginous granulomatosis, has to be kept in mind. समझे बात? Do remember that cholesteatolysis or strawberry gallbladder is not a pre-malignant condition. So if it is not a pre-malignant condition, I don't need a gallbladder removal or I don't need a cholecystectomy in that case. That has to be remembered. समझे बात? Now here there is a question which states a patient presents to you and that patient presents to you with complaints of sudden onset right upper quadrant pain along with fever, nausea and vomiting. So patient is having a sudden onset right upper quadrant pain, fever, nausea and vomiting, and whenever I palpate the right upper quadrant the patient catches breath beta. ठीक है, जैसे ही तुम राइट अपर क्वाड्रेंट पैल्पेट करोगे पेशेंट सांस रोक लेता है दर्द के मारे. ठीक है, तो पेशेंट कैचेस ब्रेथ ड्यू टू पेन. दिस इज क्लासिकली नोन एज विच साइन? आई होप ऑल ऑफ यू आर क्वाइट अवेयर. Patient catching breath on palpation of right upper quadrant is classically known as very good. It is classically known as the Murphy's sign beta. And we know if Murphy's sign is seen, if there is going to be a Murphy's sign, we know the diagnosis is classically nothing else but acute cholecystitis, that is inflammation of the gallbladder. So diagnosis in this case, wherever the patient is having jaundice and the Murphy's sign is positive, it is a classical diagnosis of acute cholecystitis. Okay. Now if I talk about acute cholecystitis, do remember in this condition the investigation of choice is nothing else but an ultrasound abdomen. The investigation of choice for an acute cholecystitis is going to be an ultrasound abdomen itself. Majority cases of acute cholecystitis are only treated by conservative management. ठीक है, the acute cholecystitis is usually treated by conservative management, that is nil per oral, IV fluids, IV antibiotics and analgesics beta. So only a conservative management is done. But if the patient presents to you early, beta, then I can go for a emergency cholecystectomy. If my patient has presented to me early, then we can go for a emergency cholecystectomy. But if my patient presents to me late, that is if the patient is presenting to me after 2 or 3 days of the symptom onset, then there would be a lot of adhesions, and if there will be a lot of adhesions, better go for an interval surgery or interval cholecystectomy. So if your patient comes early, go for an emergency cholecystectomy. If your patient presents late, go for an interval cholecystectomy beta. Clear about that? Is important. Now if I talk about cholecystectomy, basically let's say the patient has undergone a cholecystectomy, and after the cholecystectomy, let's say after lap chole surgery beta, your patient comes to you with complaints of right up, the patient comes to you with complaints of abdominal pain beta. ठीक है, patient is having complaints of abdominal pain along with fever, along with somewhat jaundice. Patient is having complaints like abdominal pain, fever and jaundice. What is going to be the first step in this condition? In this condition beta, what should be your first step? After lap chole, if the patient comes to you with complaints of nothing else but abdominal pain, fever and jaundice, then what should be done? Follow. What is going to be done in this condition? The next step or the first investigation that I will do, the first investigation that I can do in this condition is nothing else but an ultrasound abdo beta. The first investigation that I'll do in this condition is an ultrasound abdo. After doing an ultrasound abdomen, I will be able to find some bile collection that is known as bilioma. Reason, we know beta, during a cholecystectomy surgery, we might have injured the bile duct. And as we have injured the bile ducts, beta, due to that bile duct injury, there is a leakage which is happening, and that bile leakage leads to formation of a bilioma or a bile collection. Samjhe baat? Now, if there is a bilioma or a fluid collection seen on the ultrasound abdo, what is the next step to be done? What is the next step? Common question से ये exam के. What is going to be the next step? They ask you that ultrasound shows you a bilioma or a fluid collection. What should be your next step to be done? So we have to drain the fluid, or we have to drain the bile, and that is nothing else but we have to go for a pigtail catheter insertion and drainage. Okay? You have to use the pigtail catheter, and by inserting the pigtail catheter, you have to go for a drainage. The pigtail catheter insertion and drainage to be done. Clear? That is important. Do you remember this? Next important, if I talk about basically beta, that once this is done, uske baad I have to investigate that where is exactly the bile duct injury, how big is the bile duct injury, from where exactly the bile leakage is happening, everything. So we know the investigation of choice for bile duct injury is nothing else but MRCP. Barabar, the investigation of choice for bile duct injury is MRCP. In case the MRCP or magnetic resonance cholangiopancreatography, if it doesn't help you to confirm the diagnosis, then you can go for ERCP also. Then you can even go for ERCP. Okay. And lastly, once you have confirmed the bile leakage or once you have confirmed the bile duct injury, then treatment. If my patient has presented to me early, that is within 2 days of surgery, beta. So if the patient has come to you early within 2 days of surgery, then you have to take the patient back to the OT and go for re-exploration and repair. If the patient has presented to you early, beta, within 2 days of surgery, then take the patient back to the OT and go for a re-exploration and repair of the bile duct injury. But if the patient is presented to you after 2 days of surgery, then only go for a temporary management, and that is ERCP with stenting. This has also been a common question in the FMGE exam. Go for a ERCP with stenting. Hopefully clear to all of you now. Chalo. So these are the points that you have to remember properly, beta, in a case of bile duct injury or a bile leakage which happens after a cholecystectomy surgery. Clear है बात? No issues with this. याद रखना है बात. ठीक है? Now answer this question over here. What is the question saying? Do remember this question says patient is having pneumobilia. Okay, that is air inside the gallbladder or gas inside the gallbladder. ठीक है? Next, patient is having small bowel obstruction. ठीक है? Patient is having small bowel obstruction. That is multiple air fluid levels are seen, and there is a gallstone seen in the right iliac fossa or gallstone present in the terminal ileum. What is this classical triad called as? But what is this classical triad known as? Pneumobilia, small bowel obstruction, and gallstone in the right iliac fossa. This classical triad is going to be called as the, very good, this classical triad over here is known as the regular triad, beta. Okay, so we know this classical triad is known as regular triad, and I hope all of you are quite aware that regular triad which is there, it is usually seen if a patient is suffering from gallstone ileus. Matlab, what happens is there is formation of a fistula between gallbladder and the duodenum. Therefore, a stone from the gallbladder goes and it causes intestinal obstruction or a bowel obstruction, and that condition is classically known as gallstone ileus. And if the patient is having gallstone ileus, this classical regular triad is going to be seen. If it is a case of gallstone ileus, beta, do remember treatment is nothing else but go for an exploratory laparotomy. Once you open the abdomen, then open the intestine, that is enterotomy, and do a stone removal. Okay? Go for an enterotomy along with stone removal. Clear hai baat yahan tak? Chalo. Next important, if I talk about is this question over here, and that question states we are having a neonate who has complaints of progressive jaundice at birth. So we are having a neonate who is complaining of progressive jaundice at birth along with dark urine and pale stools. Let me know in the chat box, dark urine and pale stools are a feature of which kind of jaundice? A pre-hepatic jaundice or a post-hepatic jaundice? Let me know in the chat box that dark urine and pale stools is going to be a classical feature of pre-hepatic or a post-hepatic jaundice. Let me know in the chat box. And the LFT or the liver function test also shows raised ALP levels or the raised alkaline phosphatase levels, beta. I hope all of you are quite aware. याद रखना, the dark urine and pale stools, if they say, okay, along with raised ALP level, it has to be a feature of post-hepatic jaundice or an obstructive jaundice. Yes. So whenever there is obstruction in the bile duct beta, that is the condition when the patient will have this kind of dark urine, pale stools and raised ALP levels. ठीक है. तो यहाँ पे there is a problem in the bile duct and therefore the bile is not able to drain. And as the bile is not able to drain, this neonate is having progressive jaundice since birth itself. Okay. Now important is, if they ask you what is the classical diagnosis, a neonate having progressive jaundice since birth along with raised ALP levels, we know it is due to fibrosis of the bile ducts. Okay, and this condition is classically known as biliary atresia. This condition is classically referred to as nothing else but the biliary atresia, beta, has to be remembered. Barabar hai baat? Now, biliary atresia, which is there, it is of 3 types. Do remember, beta, if type 1 biliary atresia, if I talk about, it is atresia of the CBD or atresia of the common bile duct. Type 2A biliary atresia, if I talk about, it is atresia of the CHD or the atresia of the common hepatic duct. And if I talk about the type 3 biliary atresia, that is, sorry, if I talk about the type 3 biliary atresia, beta, it is biliary atresia of all the ducts. Samjhe baat? At least remember these 3. Type 1, atresia of common bile duct. Type 2, atresia of common hepatic duct. And type 3, atresia of all the ducts, basically. Clear? Now, do remember investigation of choice if I talk about. So, investigation of choice is nothing else but HIDA scan. That is the hepatic immunodiacetic acid scan, right? So, investigation of choice in a case of biliary atresia is going to be the HIDA scan, beta, called as hepatic immunodiacetic acid scan. But if it is a intrahepatic atresia, matlab if the bile ducts within the liver are not formed, so in intrahepatic atresia, the investigation of choice is liver biopsy. And when I do a liver biopsy for the intrahepatic atresia, do remember, you will be able to see proliferation around the bile ducts. So if you are able to see proliferation around the bile ducts or around the biliary radicals, think about biliary atresia as the diagnosis. Clear? Now, if it is the case of type 1 biliary atresia, that is when the common bile duct is not formed. So in those conditions, what we do, we connect the jejunum directly to the common hepatic duct, beta, and that is classically called as a Roux-en-Y hepaticojejunostomy. That is known as the Roux-en-Y hepaticojejunostomy. But in type 2 or type 3, type 2 or type 3 mein what is the problem? Majority bile ducts are absent. In type 2 or type 3, as majority bile ducts are absent, what I do, I connect the jejunum directly to the porta hepatis, which is located below the liver. Barabar, we connect the jejunum directly to this porta hepatis located below the liver, known as portoenterostomy. Anybody, what is another name for this portoenterostomy that we do in a case of type 2 and a type 3 biliary atresia? Let me know in the chat box. So for a type 2 and a type 3 biliary atresia, the portoenterostomy that we do, very classically, yes, known as the Kasai operation or the Kasai surgery. That has been a PYQ. So yaad rakhna, Kasai operation or Kasai surgery is usually done for a type 2 or a type 3 biliary atresia, also known as portoenterostomy. Next, identify these 2 investigations, beta. The first investigation that you are able to see, here you can see this is cystic duct, the right and left hepatic duct, common hepatic duct, common bile duct. This investigation mein I am also able to see the endoscope, beta. And we know if endoscope is seen, this investigation is nothing else but called as ERCP. That is endoscopic retrograde cholangiopancreatography. In ERCP, you turn the camera in a retrograde manner or in a backward manner. That's the reason endoscope is visible. Okay? This investigation has been asked just as an image-based question of radio. So do remember, this investigation is known as ERCP, beta. Whereas the other investigation, again, cystic duct, right and left hepatic duct, common hepatic duct, and bile duct, along with pancreatic duct. So this investigation that you are able to see is nothing else but MRCP. MRCP, which is a non-invasive investigation of bile duct. Investigation of choice in majority cases of bile duct problems, beta. That is MRCP or magnetic resonance cholangiopancreatography. It is a T2 weighted MRI, beta, which we do in a case of bile ducts. That is what is known as MRCP. Samjhe baat abhi? So that is important. Next important is a condition that is nothing else but called as choledochal cyst. If I talk about choledochal cyst, that is nothing else but dilatation of the bile ducts, beta. Yes, if the bile ducts gets dilated like a cyst, that is called as choledochal cyst. याद रखना, choledochal cysts are usually classified according to this classification known as Todani's classification. ठीक है, choledochal cysts are usually classified according to this Todani's classification, beta. And 2 questions from Todani's classification have been asked. तो याद रख लो, type 1 Todani classification which is there. Type 1 Todani classification में there is a solitary extrahepatic cyst or there is a single extrahepatic cyst in the common bile duct. ठीक है. Type 2 choledochal cyst में, type 2 choledochal cyst में there is an outpouching or there is a diverticulum from the common bile duct. So type 2 is the extrahepatic diverticulum from the common bile duct. Next is this one. Here you can see that the intraduodenal portion of CBD is dilated. The intraduodenal portion of CBD is dilated, that is known as choledococele, beta. That is type 3. So type 3 is nothing else but choledococele, and this was the PYQ, image based PYQ in a case of FMGE exam. They gave this picture and they asked you it is which type of choledochal cyst. So yaad rakhna, if you are able to see a choledococele or an intraduodenal dilatation, then go for type 3 as the answer. Next is type 4A. You can see in type 4A, beta, there are multiple intrahepatic as well as extrahepatic cysts. The multiple intrahepatic and extrahepatic cyst is known as type 4A. Type 4B, it is multiple extrahepatic cyst only. Type 4B is multiple extrahepatic cyst only. And type 5 is multiple intrahepatic cyst only. Type 5 is multiple intrahepatic cyst only. Yaad rakhna another thing, that type 5 where we have multiple intrahepatic cyst is also known as Caroli's disease. Another question they asked, that Caroli's disease is which type of choledochal cyst. So do remember, Caroli's disease is nothing else but a type 5 choledochal cyst. Has to be remembered. Hopefully clear to all of you now. Chalo. Next important, if I talk about, we know in patients of choledochal cyst there is a classical triad, that is abdominal pain along with abdominal lump and jaundice. So the patient will have a classical triad of pain, lump and jaundice known as the choledochal triad. Okay, the patient has a classical triad of pain, lump and jaundice known as the choledochal triad. That cyst which is there now, it is felt as a lump. So pain, lump and jaundice is a choledochal triad seen in patients of choledochal cyst. Let me know in the chat box, beta, that pain, fever and jaundice is a feature of which triad? Pain, fever and jaundice is going to be called as which triad? Anybody let me know in the chat box. तो पेन, फीवर एंड जॉन्डिस अगर बोला जाए, दैट इज गोइंग टू बी विच ट्राइड एंड इट इज सीन इन विच कंडीशन? वेरी गुड. तो याद रखना, द पेन, फीवर एंड जॉन्डिस विच इज देयर, इट इज गोइंग टू बी कॉल्ड एज द शार्कॉट्स ट्राइड. द पेन, फीवर एंड जॉन्डिस इज नोन एज द शार्कॉट्स ट्राइड. एंड डू रिमेंबर दैट शार्कॉट्स ट्राइड of pain, fever and jaundice is usually a feature of cholangitis. We know in patients of cholangitis there is a classical triad known as Charcot's triad where there is pain, fever and jaundice. ठीक है. Along with this, if I add hypotension and mental confusion, if I add hypotension plus mental confusion, then it becomes a Raynaud's pentad. Then it is going to become the Raynaud's pentad. That has to be remembered. शाबाश. अगर hypotension plus mental confusion add करोगे तो clear है बात. चलो, so that is what is important to be remembered. Coming back to choledochal cyst, do remember here the complaint is pain, lump and jaundice. Investigation of choice, I have already told you, investigation of choice for bile duct is usually a MRCP, beta. Investigation of choice for a bile duct is MRCP, which is a non-invasive investigation on which you are able to see the cyst. Clear? But gold standard investigation which will also help us in treatment, that gold standard investigation is a ERCP. So gold standard investigation which is there, that is nothing else but ERCP, that has to be kept in mind. समझे बात? Now if I talk about a type 1 choledochal cyst, so do remember type 1 choledochal cyst में there was a single cyst in common bile duct. So what I do is I remove the CBD and we connect the jejunum directly to the common hepatic duct called as Roux-en-Y hepatico-jejunostomy. So do remember, type 1 biliary atresia and type 1 choledochal cyst, both of them are treated by the same procedure known as Roux-en-Y hepatico-jejunostomy. Type 2 is easy. Type 2 is the extrahepatic diverticulum. So I just cut the diverticulum and we repair the CBD. That's it. टाइप 3 जो होता है, डू रिमेंबर टाइप 3 में the opening of the common bile duct is very narrow, therefore a choledochocele form. तो इसीलिए we have to widen up the opening beta, and to widen up the opening we have to perform a procedure known as ERCP with sphincterotomy. So you have to widen up the opening of the CBD or the common bile duct, and for that you have to perform a procedure known as ERCP with sphincterotomy. Now type 4A and 5 में क्या common चीज थी? तो we know type 4A and type 5 both of them were having multiple intrahepatic cysts. Type 4A and type 5 both of them were having multiple intrahepatic cysts. So in both the conditions we can go for a liver transplant. Both of them were having multiple intrahepatic cysts. So in both these cases basically we can go for a liver transplant. That is what is important. Whereas type 4B which is there, type 4B में there are multiple extrahepatic cysts. In type 4B, as there are multiple as there are multiple extrahepatic cysts, what I do, we remove basically beta, ठीक है, I remove basically the bile ducts, and then we connect the jejunum directly to the porta hepatis, known as portoenterostomy, also known as the Kasai operation. So do remember type 2 and type 3 biliary or type 4B choledochal cyst. In this condition, the treatment is nothing else but Kasai operation or the Kasai surgery. That has to be kept in mind. Clear about? Chalo. Now let's talk about the next part, that is nothing else but urology. Now if I talk about urology, beta, the first portion, the first condition that we have to talk about is nothing else but horseshoe kidneys, beta. The first condition that you have to talk about is nothing else but horseshoe kidney. Do remember, horseshoe kidney is nothing else but bilaterally ectopic kidneys, these are, which are fused in the midline. At which vertebral level? Let me know in the chat box. कौन से vertebral level पे basically it is going to be commonly going to fuse? तो यहाँ पे you can see these are the bilaterally ectopic kidneys where the lower poles are fusing in the midline, beta, and they are giving us a horseshoe like shape. ठीक है? So the most common site of fusion in a case of horseshoe kidney is going to be L3, L4. Yes, the commonest site of fusion, beta, in a case of horseshoe kidney is going to be the junction of L3, L4 basically. That has to be remembered. Clear? Now, if there is a horseshoe kidney where we have ectopic kidney, the urine drainage cannot happen properly, due to which the patient may have problems like urine retention, and as there will be urine retention, patient will have increased risk of UTI, that is urinary tract infections, or urinary stones, beta. ठीक है? Investigation of choice. We know kidneys are a retroperitoneal organ, और मैंने बताया है for all the retroperitoneal organ the best radiological investigation is always a CCT. ठीक है? तो यहाँ पे देख सकते हो this is the CCT abdomen. तो investigation of choice in a patient of horseshoe kidney has to be a CCT abdo, beta. ठीक है? Now if they ask you, IVP will show us very classical appearance. What is that appearance known as? Let me know in the chat box. IVP or intravenous pyelogram in a case of horseshoe kidney shows us the very classical appearance known as which one? Let me know in the chat box. What is the classical appearance known as? So the IVP classically shows us the flower vase appearance, also known as the hand joining sign or the hand shaking sign, beta. Barabar? So do remember that the intravenous pyelogram in cases of horseshoe kidney classically shows us the flower vase appearance, also known as the hand shaking sign or the hand joining sign. Hopefully clear to all of you. Chalo. Now if they ask you management, तो याद रखना बेटा, majority cases of horseshoe kidney are managed conservatively. Surgery is not recommended in cases of horseshoe kidney. Reason, the time you cut the kidney, beta, the kidneys will get damaged. So it's better basically to only go for a conservative or a symptomatic management in these cases. समझे बात? Next is the case of nothing else but ADPCKD. What is that? Autosomal dominant polycystic kidney disease. We know polycystic kidney disease can also be autosomal recessive, beta, but the autosomal recessive type is incompatible with life. Matlab, the baby does not survive in the autosomal recessive variety. So the patient who comes to us is usually the autosomal dominant polycystic kidney disease wala case, okay, also called as the congenital or the adult PCKD. In this condition, the gene mutation responsible is known as PKD1 or PKD2. ठीक है. So it is basically the PKD1 or the PKD2 gene mutation which is known to cause autosomal dominant polycystic kidney disease beta. Here the patient is going to complain of mass, pain and hematuria, right? Due to the PCKD or due to the multiple cysts, the kidneys may enlarge beta, leading to a mass in the flank region or mass in the lumbar region. Patient may have some pain and the patient may have hematuria also. If I do a IVP or intravenous pyelogram, let me know which kind of sign is going to be seen on the IVP if it is a case of PCKD. Investigation of choice, so as usual we know, investigation of choice has to be a CCT abdomen or a contrasonant CT abdomen. And when I do a CCT, this is the classical picture in a patient of PCKD. Multiple cysts, multiple fluid filled cysts are seen in both the kidneys beta, causing enlargement. This is what is the classical picture of PCKD on the CCT abdo. Very good, shabash. So we know beta that IVP or intravenous pyelography in a patient of PCKD shows us the classical spider leg appearance. Samjhe baat? It shows us the classical spider leg appearance. That is what is important to be remembered. Now, management in cases of PCKD. So usually we can go for antihypertensives. One of the commonest presentation in a patient of polycystic kidney disease is hypertension. So we have to give antihypertensives like ACE inhibitors or ARBs beta. ठीक है, तो ACE inhibitors or ARBs can be given, or sometimes we can go for deroofing of the cyst. You have to deroof the cyst and drain the cyst beta. What is this surgery called as? Let me know in the chat box. Sometimes in patients of PCKD beta, we can definitely go for deroofing of the cyst to drain the cyst basically. What is that condition classically known as? Bolo. That surgery is classically known as the roofing surgery. So whenever we do deroofing of the cyst beta to drain the cyst thoroughly, that condition is classically known as the roofing surgery. Okay, that condition or that surgery is known as the roofing surgery. Clear hai baat? Yaad rakhna. And the best treatment if they ask you for a case of PCKD, answer is nothing else but renal transplant. The best treatment if they ask you for a case of PCKD, answer is a kidney transplant or a renal transplant. याद रखना point, renal transplant or kidney transplant में I prefer left kidney of the donor. Reason, as the left renal vein is longer, we know we are going to prefer the left kidney of the donor beta, and we have to place the donated kidney in right iliac fossa. Yes, I don't place the kidney at the original location. We have to place the new kidney in the right iliac fossa beta. That is what is important. Clear hai baat? Do remember this. That is what is important to be remembered. Chalo. Do remember most common there is maximum risk of rejection in cases of lung transplant followed by kidney transplant. अगर पूछा जाए maximum risk of rejection is with which transplant, answer is lung transplant 80% followed by kidney transplant around 50% beta. Clear? Now here there is a small child Bache, and that small child has been brought to us with complaints of urine retention, and therefore if you see a IVP or the intravenous pyelogram, you can see the pelvis and the chelicus appears to be dilated beta, and we know whenever there is dilatation of pelvis and chelicus, we call it as hydronephrosis. So yes, this condition is a congenital cause of hydronephrosis where there is some obstruction at the level of the pelvic-ureteric junction. So what is the diagnosis in this case? In this scenario, the diagnosis is nothing else but PUJ or the pelvic-ureteric junction obstruction beta. The diagnosis is nothing else but PUJ or the pelvic-ureteric junction obstruction. And yaad rakhna, due to this pelvic-ureteric junction obstruction, the patient is having hydronephrosis. Due to this pelvic-ureteric junction obstruction, the patient has retention of urine, जिसकी वजह से the patient develops hydronephrosis. Anybody let me know what is the investigation of choice for PUJ obstruction? What is the investigation of choice for a PUJ obstruction beta? Let me know in the chat box. What is the investigation of choice for PUJ obstruction? So when we have to assess the renal function beta, the investigation of choice for a case of hydronephrosis or for a case of PUJ obstruction, very good, it is going to be the MAC3 scan. To assess the renal function, we have to go for a investigation classically known as the MAC3 scan. And याद रखना treatment is what? We know the treatment is classically known as the Anderson-Heinz pyeloplasty. We have to do a repair at the level of pelvic-ureteric junction, and that surgery that we do or the treatment that we do is classically referred to as the Anderson-Heinz pyeloplasty, which is the treatment that we prefer in a case suffering from or a patient suffering from PUJ obstruction or pelvic-ureteric junction obstruction. DMSA is basically done for anatomy beta. Okay, please remember that DMSA is usually done for anatomy. The MAC3 or DTPA, they are usually done for functions. Okay, so MAC3 scan is considered as the best investigation overall. Understood? Next, Sarkari question. Here they have reversed the pictures. Chalo, we'll discuss it. So first of all, beta, if I talk about a condition that is known as ureterocele, what happens in ureterocele? Let's say this is your urinary bladder. So when the ureter opens in the urinary bladder, now at that site the ureter gets too much dilated. Why? Because the opening of the ureter is very narrow. As the opening of the ureter is very narrow, basically, therefore this intramural part or the intravesical part of the ureter gets dilated, and that is classically known as the ureterocele. तो अगर ureter की opening बहुत छोटी होगी, बहुत पतली होगी, तो जो intravesical part है ureter का वो dilate हो जाएगा, जिसको बोला जाता है ureterocele. Now in examination they more commonly give bilateral cases. So you tend to think it is more commonly bilateral. No, do remember majority cases of ureterocele are unilateral. Few cases of ureterocele are bilateral. That has to be kept in mind. Clear? And in patients of ureterocele, okay, this is a picture of ureterocele. In patients of ureterocele, when we do a IVP or intravenous pylography, as you are able to see, when I do a IVP or intravenous pylography in ureterocele, recent image-based question in the FMGE exam, multiple times repeated, it gives us a very classical appearance called as nothing else but the cobra head appearance, also known as the adder head appearance. Beta, clear hai baat? So ureterocele on the intravenous pyelogram gives us the very classical cobra head appearance, also called as the adder head appearance. Basically, that is what is important. Okay, the classical cobra head appearance or the adder head appearance is going to be seen. Treatment, if they ask you, we know that definitely over here the ureteric opening is very narrow. Either try to widen up the ureteric opening. If that's difficult, better is create a new ureteric opening. ठीक है, और नई ureteric opening अगर बनानी है, that is classically known as ureteric reimplantation. ठीक है, instead of this, close this opening and create a new opening for that ureter, known as the ureteric reimplantation. Beta, that can be done. Clear? Next important is the condition of nothing else but duplex renal pelvis and ureter. That is, we know normally from one kidney there is one pelvis and one ureter which arises. Barabar? But in this condition, from one kidney there will be two pelvis and two ureter. एक kidney से दो pelvis निकल रही है, दो ureters निकल रहे. So that condition is known as duplex renal pelvis and ureter. If I talk about duplex renal pelvis and ureter, in this condition, beta, if you go for a IVP or if you go for a intravenous pyelogram, on this pyelogram basically, beta, you are able to see a very classical feature. And what is the feature on intravenous pyelography in a case of duplex renal pelvis seen, called as this sign which is seen on the intravenous pyelogram in a case of duplex renal pelvis is classically known as the drooping lily sign. Beta, समझे बात? So do remember IVP showing us a drooping lily sign is a very classical feature of nothing else but the duplex renal pelvis and ureter. Hopefully clear to all of you now. Chalo. So these are the points that you need to remember. Now if they ask you what is the treatment, तो याद रखना, the treatment is in cases of duplex renal pelvis and ureter, बेटा क्या होता है, majority cases में both these ureters combine together and they open as a single ureter. अगर दोनों यूरेटर ज्वाइन हो जाए और एक यूरेटर की तरह ओपन करते हैं तो कोई दिक्कत नहीं होगी. ओके, सो इफ बोथ द यूरेटर्स फ्यूज देन दैट डजंट कॉज एनी प्रॉब्लम. बट इफ एनी वन ऑफ द यूरेटर बिकम्स एक्टोपिक, अगर एक यूरेटर का गलत जगह ओपन हो जाए तो दिक्कत आएगी. तो इफ वन ऑफ द यूरेटर इज बिकमिंग एक्टोपिक, द ट्रीटमेंट इज रीइम्प्लांटेशन ऑफ दैट एक्टोपिक यूरेटर. ठीक है, विच एवर इज द एक्टोपिक यूरेटर, you have to create an opening for that ureter into the urinary bladder. Open that ureter properly into the urinary bladder. समझे बात? Next important now, let's talk about a case, and that is nothing else but about the urinary stones, also known as urolithiasis beta. ठीक है, the urinary stones, also known as urolithiasis. Do remember, there are two types of urinary stones or urolithiasis. One is the renal stones, also called as nephrolithiasis, and the bladder stones, also known as cystolithiasis beta. ठीक है, तो renal stones called as nephrolithiasis and the bladder stones called as cystolithiasis. ठीक है. Now, if they ask you among all the types, the most common cause for this urinary stone is going to be, तो याद रखना, the most common cause of urinary stone is nothing else but idiopathic hypercalciuria. The most common cause of urinary stones is nothing else but idiopathic hypercalciuria. So whenever there is more calcium getting excreted out by the patient's urine beta, that is known as hypercalciuria, and this calcium may deposit into the patient's urinary tract, leading to formation of stones beta. Now please tell me which is the most common type of renal stone or the most common type of bladder stone. Both is same. Let me know in the chat box which is the commonest type of renal stone or bladder stone. Let me know in the chat box which is the most common type of renal stone or the bladder stone basically. I hope all of you are quite aware. The commonest type of renal stone and bladder stone is nothing else but the calcium oxalate stones beta. The most common type of renal stone and bladder stone are nothing else but the calcium oxalate stones, which are usually seen in patients suffering from hyperoxaluria. Okay, it is usually seen in patients who are suffering from hyperoxaluria beta. Barabar baat? Now, another question to you, recent NEET PG question, and that is, if the patient is having a Proteus mirabilis urinary tract infection, if the patient is having a UTI due to a Proteus organism, the pH of the urine becomes alkaline, and due to that, there is a high risk of which urinary stones? Let me know in the chat box. Proteus UTI usually increases the risk of which urinary stones? Bolo. I hope all of you are quite aware. Shabash. Yes, the Proteus infection usually increases the risk of struvite stones, also classically known as nothing else but the triple phosphate stones beta. Okay, so the struvite stones or the triple phosphate stones which are there basically, those are going to be commonly associated with the Proteus infection. This is a very important and a common question asked. So struvite stones or triple phosphate stones beta, they are commonly associated with Proteus infection. Triple phosphate means calcium phosphate, magnesium phosphate, and ammonium phosphate. Okay, these are the stones. They are associated with the Proteus infection. Next, cola urine. Sorry. Cola urine is seen in which condition? Let me know in the chat box, beta. Cola urine is a feature of which condition? Cola urine is a feature of which condition? Sorry. Very good. So cola urine which is there beta, it is a classical feature of nothing else but cystinuria. Barabar, cola urine is a feature of cystinuria. You might have discussed in cases of biochemistry. ठीक है? So cystinuria which is there, in that condition there are 4 dibasic amino acids excreted out known as cystine, ornithine, lysine, and arginine beta, and that is known as cola urine. So if the patient is having cola urine, that is a case of cystinuria, obviously the patient will have a high risk of cystine stones beta. The patient is obviously going to have a very high risk of cystine stones. That is what is important to be remembered. Hopefully clear to all of you now. Chalo. Now do remember one point about cystine stones, that cystine stones are going to be the hardest urinary stones. So agar pucha jaye which is the hardest urinary stone, answer is nothing else but cystine stones beta. Sorry. Now in cases of urinary stones or in cases of urinary tract infection, the most common clinical feature is nothing else but increased urinary frequency. So the patient has to go for urination again and again. Increased urinary frequency or increased micturition frequency is the most common symptom in patients of urinary stones or UTI. Some stones, especially the calcium oxalate stones, they may also cause bleeding, leading to hematuria beta. And the most important symptom is nothing else but pain. The patient may have either a lumbar pain or a suprapubic pain. याद रखना, if they say patient is having a fixed lumbar pain, matlab patient is having lumbar pain which is not radiating anywhere else. So if there is a fixed lumbar pain, then it is the case of kidney stone or a renal stone beta. But if the patient is having a lumbar pain radiating to various sites like perineum, scrotum, iliac fossa, thigh, if there is a lumbar pain radiating to all these sites beta, that means the patient is having a ureteric stone or a ureteric calculi. That is, the stone is inside the ureter beta. Clear? Next, if the patient is having suprapubic pain beta, okay, if the patient is having a suprapubic pain, it is a case of bladder stone. Suprapubic pain is a feature of bladder stone. But if the patient is having suprapubic pain radiating to the tip of penis, suprapubic pain radiating to the tip of penis beta, then it is a case of stone at the level of bladder neck or in the urethra. Okay, if the suprapubic pain radiates, then the stone is at the level of bladder neck or in the urethra. Clear hai baat yahan tak? That is important. Now we know first line investigation that we may do in a patient of urinary stone is nothing else but called as X-ray, because unlike gallstone, 90% of the urinary stones are going to be radio opaque beta. That means they appear white on an X-ray or a CT scan. So do remember, first line investigation in a case of urinary stone is nothing else but now X-ray, KUB or X-ray, kidney, ureter and bladder. Okay? So that is important. The first line investigation is X-ray, KUB or X-ray, kidney, ureter, bladder. Investigation of choice अगर पूछेंगे, do remember the investigation of choice is going to be NCCT KUB or a non-contrast CT scan of kidney, ureter, bladder. Okay, it is going to be NCCT KUB or a non-contrast CT of kidney, ureter, bladder. Clear about? The first line is X-ray, investigation of choices NCCT. याद रखना, along with this I can also send a urine microscopy. Reason, on this urine microscopy we can see the shape of crystals, and depending on the shape of crystals we can conclude that which stones are present in the patient's urinary tract beta. तो shape of crystals देख के पता लगा सकते हैं कौन से stones हो सकते हैं करके. तो first of all, here you are able to see envelope shaped crystals, and I hope all of you are quite aware that envelope shaped crystals which are there, they are usually a feature of calcium oxalate stones. Okay, the envelope shaped crystals are going to be the calcium oxalate crystals, especially the dihydrate crystals beta. So जो calcium oxalate crystals होते हैं, the dihydrate ones, they are going to be envelope shaped. Next, this here the shape is going to vary beta. Some are flower shaped, some are rectangular, some are rhomboid shaped. Any shape is there. मतलब this crystals which are there, they are irregular in shape. If I say the crystals are irregular in shape basically, so do remember, irregular shape crystals or the universal crystals are usually seen in uric acid stones. The uric acid crystals which are there, they do not have a fixed shape, they are irregular or universal in shape. Next, these crystals that you are able to see beta, these are your coffin lid shape crystals, and I hope all of you are quite aware. The coffin lid shape crystals which are there, they are usually seen in a struvite stone or a triple phosphate stone. So we know that the struvite or the triple phosphate crystals, they are usually going to be coffin lid shape, has to be remembered. And lastly, these are going to be the hexagonal crystals or the benzene ring shape crystals, and we know the hexagonal or the benzene ring shape crystals, they are usually seen in cystine stones. So cystine crystals which are there, those are going to be hexagonal or benzene ring shape beta. That is important to be remembered. चलो यहाँ तक क्लियर है सबको. So here you are able to see a X-ray KUB beta, and on that X-ray KUB, how do I differentiate whether it is the IVP or X-ray? याद रखना, here I am not able to see any ureter or I am not able to see any bladder. मतलब there is no contrast, and if contrast is not there, it has to be a X-ray beta. ठीक है? If ureter and bladder would have been seen, मतलब if contrast was there, then it would have been a contrast study called as IVP or intravenous pyelogram. अब on this X-ray KUB, I am able to see a calcification or a stone, and this stone is actually in a shape of renal pelvis. Whenever there is a stone in a shape of renal pelvis, that is classically known as the staghorn calculi. whenever there is a stone in a shape of renal pelvis beta, we classically call it as nothing else but the staghorn calculi has to be remembered. समझे बात? So this is nothing else but a this is nothing else but a struvoid stone or the triple phosphate stone. And when the struvoid or the triple phosphate stone grows very big in size, that is known as the staghorn calculi beta. Clear? This is the NCCT. On this NCCT, you are able to see a stone in the inferior calyx of the left kidney. Clear? Chalo. Now if I talk about treatment, तो याद रखना, treatment in cases of urinary stone depends on the location and depends on the size. First, if they say beta, the patient is having renal stone. Okay, the patient is having renal stone and the size of renal stone is less than 5 to 6 millimeter. We know if it is a renal stone less than 5 to 6 millimeter, just go for an observation or a conservative treatment. Conservative treatment means you can give analgesics or painkillers. You will ask the patient to take plenty of fluids and you can give urine alkalizers beta. Barabar? So you can definitely give plenty of fluids, analgesics and alkalizers beta. That can be done. So whenever the renal stone is less than 5 to 6 mm in size, go for observation only. If the stone is more than 5 to 6 mm in size, if the renal stone is more than 5 to 6 mm in size, go for ESWL. What do I mean by ESWL? Extracorporeal shock wave lithotripsy beta. If the stone is more than 5 to 6 mm in size, go for ESWL, that is extracorporeal shock wave lithotripsy. Matlab, with the help of shock waves, I am going to break down the stone into multiple pieces. And once the stone has been broken down into pieces or fragments, these pieces will easily get excreted out via urine. तो स्टोन को अगर तुमने तोड़ दिया, वो जो टुकड़े स्टोन के वो अपने आप यूरिन में बाहर आ जाएंगे. दैट प्रोसीजर इज नोन एज ESWL or extracorporeal shock wave lithotripsy. Whenever the stone is more than 2 centimeter in size or if there is a distal obstruction, do remember ESWL is contraindicated in few conditions like pregnancy. If there is any distal obstruction, why? Let's say you have broken the stone by ESWL, but there is obstruction in the urethra. Will these fragments of stone come outside? No. अगर distal obstruction है तो fragments बाहर ही नहीं आएंगे ना. So इसीलिए if the stone is very large in size, more than 2 centimeters usually, or if there is a cystine stone, which is the hardest renal stone beta, which cannot easily break with the help of ESWL. So in these conditions, especially in these two, that is whenever the stone is large, more than 2 centimeters in size, or whenever there is a distal obstruction, in these conditions, the procedure that we go for is nothing else but PCNL beta. And what is PCNL? Percutaneous nephrolithotomy. We go for a procedure that is nothing else but known as PCNL or a percutaneous nephrolithotomy beta. Clear? Matlab you will directly go percutaneously, okay, via the lumbar region, and you are going to extract or remove the stone beta. Next, this is about the renal stone. Let's talk about a ureteric stone, bache. Now when there is a stone inside the ureter, so please remember, if the stone is less than 5 to 6 millimeter, if the stone is usually less than 5 to 6 millimeter, in this condition, we have to again go for observation. Yes, if the ureteric stone is less than 5 to 6 mm, and if it is not causing any obstruction, if it is not causing any problem, just go for an observation. Okay, ureteric stone less than 5 to 6 mm, not causing any blockage, just go for observation. But if there is going to be a large or impacted ureteric stone, if there is a large ureteric stone or impacted, that is the obstructed ureteric stone, in those conditions you have to go for ureteroscopic removal. ठीक है, तो large ureteric stone और impacted ureteric stone में the treatment is nothing else but ureteroscopic removal. It is done with the help of which basket? Let me know in the chat box. So we know, let's say if this is the ureter and in the ureter there is a stone, so we slide a basket behind the patient's ureteric stone beta and we open up this basket. Now once you have opened up the basket, you are just going to pull out the basket. When I pull out the basket, the stone gets trapped in the basket and easily gets pulled out. This is known as the ureteroscopic removal of stone. And in this ureteroscopic removal of stone, yes, the basket that we use is known as the Dormia basket beta. That basket that we use for the ureteroscopic removal of stone is known as Dormia basket. Clear? Shabash. Next important is the bladder stone beta. So bladder stone or cystolithiasis, if I talk about, do remember, If there is a bladder stone, the surgery or the procedure is known as cystolithotomy. Okay, the procedure is basically called as cystolithotomy. Now that has to be done via two routes. What are the two routes? First, either I can go for a perurethral cystolithotomy or you can go for a suprapubic cystolithotomy. Matlab, if the bladder stone is small in size, go via the urethra inside the bladder and remove the stone. That is perurethral cystolithotomy. But if the bladder stone is big in size, then you have to go via the suprapubic region, make an incision and then remove the stone directly, known as a suprapubic cystolithotomy. Samjhe baat? Great. So that is what is important. Now answer this question. A patient presents to you, beta, with complaints of increased urinary frequency along with fever, and urine microscopy was done. And when I did a urine microscopy, that reveals there is a sterile pyuria. What is the likely diagnosis? Let me know in the chat box. This is the most important keyword that we know in the whole question. Let me know. If the patient is having features of UTI, increased urinary frequency, fever, dysuria, burning micturition, along with that, microscopy shows you classical sterile pyuria. Ab sterile pyuria kya hota hai? We know, beta, whenever there is any other UTI or any other urinary tract infection, bacteria is going to be seen and pus cells are going to be seen. Barabar? But if it is this infection, beta, in the urinary tract, I will be able to see the pus cells, and as I am able to see pus cells, we call it as pyuria. But I am not able to see any bacteria. That's the reason we call it as sterile. So sterile pyuria is a classical feature of nothing else but a genitourinary tuberculosis or a renal tuberculosis, beta. Yaad rakhna that if the patient is having a sterile pyuria, that is a classical feature of genitourinary tuberculosis or a case of renal tuberculosis. So whenever there is a genitourinary or a renal TB, the keyword of that question is sterile pyuria. Reason is, in all other infection, bacteria is also seen, but in TB, bacteria is not seen. Therefore, we call it a sterile pyuria. Samjhe baat? Now, in cases of genitourinary TB or renal TB, initially there is pus collection called as pyonephrosis. After pyonephrosis, there is going to be caseous necrosis in the kidney along with calcification. And caseous necrosis along with calcification in the kidney is classically referred to as putti kidney, beta. Barabar? The texture of the kidney becomes like putti basically. So this picture that you are able to see, it is the X-ray, and on this X-ray, you are able to see a calcification, but that calcification is appearing in the form of kidney or in the shape of kidney. So whenever there is calcification in the form of kidney, call it as a putti kidney or a cement kidney. And this putti kidney or cement kidney is a classical feature of genitourinary TB or a renal TB, beta. Hopefully clear. This putti kidney wala question has come a lot in the previous year FMGE exam. Clear? Now if they ask you what should be the treatment, we know any kind of TB basically, beta, doesn't matter whether it is the renal TB, ureteric TB, bladder TB, whatever kind of TB it is there, you have to treat the patient with ATT, that is anti-tubercular therapy, right? We have to give ATT or anti-tubercular therapy. Along with that, the symptomatic treatment has to be done. Symptomatic treatment means, let's say if the patient is having hydronephrosis or if the patient is having pus collection, in those conditions I have to drain with the help of nephrostomy. ठीक है? तो urine retention है या फिर pus retention है, तो I have to drain it with nephrostomy. If there is a ureteric stricture, you have to open up that ureteric stricture with the help of a DJ stent, also known as the double J stent, beta. Or if the bladder has been damaged, if there is a thimble bladder, you might have heard, the thimble bladder is there or the bladder damage is there, go for a cystoblasty or repair of the urinary bladder. समझे बात याद है? That is important. Now, this is the question, beta, which has been asked in the FMGE examination earlier, and that is, a patient presents to you with complaints of abdominal mass and a painless hematuria. What is the likely diagnosis? We know, see, hematuria can also be seen in a case of urinary stone, but the hematuria in stones is extremely painful. Hematuria can also be seen in a UTI or a urinary tract infection, but that is also extremely painful. Okay? So do remember, painless hematuria, if they say, it is usually suggestive of cancers, beta. Either it is suggestive of a renal cell carcinoma or a bladder carcinoma. That has to be remembered. समझे बात? So patient is having an abdominal mass along with a painless hematuria. So more likely it is going to be a diagnosis of RCC, that is a renal cell carcinoma. Now, if I talk about renal cell carcinoma, we know it has to be an adenocarcinoma itself more commonly. Okay, renal cell carcinoma, more commonly it is the adenocarcinoma. There are various subtypes that we have. Barabar, renal cell carcinoma ke various subtypes are there. One is basically going to be the clear cell carcinoma. Second is going to be the chromophobe carcinoma. Third is the papillary carcinoma. And fourth can be the Bellini duct carcinoma. Out of them, अगर पूछा जाए the most common type of RCC or renal cell cancer, so do remember the most common type of RCC or the renal cell cancer is nothing else but clear cell carcinoma. Yes, the most common type of RCC or a renal cell cancer is nothing else but a clear cell carcinoma. Has to be remembered. Clear यहाँ तक बात? चलो. Now do remember that this clear cell carcinoma which is there, it is usually associated with which gene mutation beta? Clear cell carcinoma which is there, it is commonly associated with the VHL gene mutation. So clear cell carcinoma which is there beta, do remember it is very commonly associated with the VHL gene mutation or the von Hippel-Lindau gene mutation. Okay, this was a PYQ NEET, that VHL gene mutation is associated with which subtype of renal cell carcinoma? Answer has to be the commonest subtype, that is clear cell carcinoma. Okay. Next important if I talk about beta is the chromophobe type. याद रखना why chromophobe type is important. Chromophobe type, in this, if you do a histopath, on that histopath you are able to see a classical plant cell like appearance. You are able to see the classical plant cell like appearance. And secondly, the chromophobe variety is going to have the best prognosis among all the subtypes of renal cell carcinoma. The chromophobe variety is going to be associated with the best prognosis. That is important. Clear? The most common type is the clear cell carcinoma. Best prognosis is seen with the chromophobe carcinoma. Now, in cases of renal cell carcinoma, biopsy is not usually done. Biopsy is done after the removal. Okay? So investigation of choice अगर पूछेंगे तो we know best radiological investigation in retroperitoneum is CCT abdo. So investigation of choice for a renal cell carcinoma is nothing else but a CCT abdomen beta. And when I do a CCT abdomen, this is the classical picture. Can you see? A huge mass is actually growing from the kidneys of the patient. This is the classical picture of nothing else but a renal cell carcinoma that is going to be seen. Clear? Now, if they ask you about the treatment, तो याद रखना, in a case of renal cell carcinoma, whenever it is going to be a small cancer less than 4 centimeters in size, or if it is a case of bilateral renal cell carcinoma, matlab cancer is present in both the kidneys beta. So if it is a small cancer less than 4 centimeter, or if it is a case of bilateral cancer, we only go for a partial nephrectomy. Obviously, in this condition, I will only do a partial nephrectomy beta. But if the cancer is more than 4 centimeter, then in this condition we have to go for a radical nephrectomy, that is complete removal of kidney. If the cancer is more than 4 centimeters in size, then we have to go for a radical nephrectomy beta. Clear? Another question now, let me know in the chat box that which is the most common renal malignancy in children. Agar पूछा जाए which is the most common renal malignancy in children, answer is going to be the most common renal malignancy in children. Answer would be, bolo, most common renal malignancy in children. Very good. Yes, the most common renal malignancy in children is nothing else but called as the Wilms tumor, also known as a nephroblastoma beta. याद रखना, the most common renal malignancy in children, answer has to be the Wilms tumor, also referred to as the nephroblastoma. Let me know in the chat box beta that which is the most common renal malignancy, what is the most common abdominal malignancy in children? Most common renal malignancy in children, so we know it is the Wilms tumor or a nephroblastoma. Okay, most common renal malignancy in children, we know it is a nephroblastoma or Wilms tumor. But most common abdominal malignancy in children अगर पूछा जाए, what is the most common abdominal malignancy in children? Answer will be, let me know in the chat box. Shabash. So do remember, most common abdominal malignancy in children, if they ask you, answer has to be a neuroblastoma followed by nephroblastoma or Wilms tumor. याद रखना, most common abdominal malignancy in children, answer is neuroblastoma followed by Wilms tumor or the nephroblastoma. ठीक है, तो अगर renal malignancy पूछा जाए तो we know it is going to be Wilms tumor, but abdominal malignancy, if they ask you in children, then most common type is neuroblastoma. And most common malignancy in children, pediatrics, please let me know in the chat box which is the most common type of malignancy in children. Let me know in the chat box the most common type of malignancy in children overall. Most common type of malignancy in children overall. Bolo. Most common malignancy in children overall. ALL, that is nothing else but acute lymphoblastic leukemia. Okay, that is the most common malignancy overall in the body. Clear? Now do remember that Wilms tumor or nephroblastoma, which is the renal malignancy in children beta, that is commonly associated with a condition known as Beckwith-Wiedemann syndrome. A previous year question of August 2020 FMGE. So they gave a picture of a baby who was having hemihypertrophy. Matlab, half body was enlarged in size. Second, the child was having large tongue called as macroglossia. Third, the child was having an umbilical hernia or sometimes an omphalocele. And they asked you now, in this condition, which among the following tumor will be commonly associated? So we know if it is a case of Beckwith-Wiedemann syndrome, Wilms tumor or nephroblastoma will be commonly associated. Understood? In cases of Wilms tumor beta, again investigation of choice is a CECT abdo. In early stages, you can go for an MRI abdo also. Okay? Once you remove the tumor after surgery, then histopathological examination shows you a very classical feature, and that is known as mixed tumor. Matlab, if you see the histopathological examination in Wilms tumor, you will be able to see epithelial elements, blastomal elements, and mesenchymal elements, everything. So epithelial, mesenchymal, blastomal, every element is seen beta. Therefore, we call Wilms tumor as a mixed tumor beta. Clear? Treatment. Do remember, Wilms tumor is majorly treated by surgery or a surgical resection. But after surgery, either we should go for only a chemotherapy. Matlab, if the child is in the early stages of Wilms tumor, go for surgery followed by chemotherapy. But if the child is in the advanced stages of Wilms tumor, go for surgery followed by chemo radiation. Agar advanced stages mein hai, so followed by surgery, you have to give chemo radiation, not only chemotherapy. Got it? Now, let's talk about the next topic, and that is nothing else but called as bladder rupture beta. Okay, two topics from trauma. One is bladder rupture, second is urethral rupture. Bladder rupture can be of two types. Either it is an extraperitoneal bladder rupture or an intraperitoneal bladder rupture beta. Now we know normally bladder is an extraperitoneal organ. Normally bladder is an extraperitoneal organ. So more common is definitely a extraperitoneal bladder rupture. More common is going to be the extraperitoneal bladder rupture. Now, extraperitoneal bladder rupture happens due to a pelvic trauma. Let's say patient met with a road traffic accident and due to that there was a pelvic fracture. Obviously, if the pelvic bone is fractured, then the bladder inside it will also get injured. बराबर? अगर pelvic bone ही fracture हो जाता है तो उसके अंदर की bladder भी rupture हो जाएगी. तो most common cause of extraperitoneal bladder rupture is a pelvic trauma or a pelvic fracture. And in cases of intraperitoneal bladder rupture, most common cause is trauma to a full bladder or trauma to an overdistended bladder. Let's say the patient has drank a lot of beer beta, or the patient has been taken for a lower abdominal surgery. Now the patient's bladder is full or the patient's bladder is distended. Now, due to beer drinking, if the patient falls down and there is a trauma to this full bladder, obviously this full bladder will rupture, causing urine leakage in the peritoneal cavity. That is known as intraperitoneal bladder rupture. Same manner mein, if you take this patient with a full bladder for a lower abdominal surgery like LSCS and you retract the bladder forcefully, again the bladder may rupture, causing a urine leakage into the peritoneal cavity or intraperitoneal bladder rupture. समझे बात? So extraperitoneal and intraperitoneal bladder ruptures can be seen. दोनों conditions में the common symptoms are, first, as in both the condition the bladder has ruptured, obviously we know beta the urine has leaked out. That's the reason the patient is not able to pass urine. There is inability to pass urine. Apart from that, there is going to be blood seen at the level of the external urethral meatus. So as there will be bladder rupture, there will be bleeding and the blood is going to be visible at the tip of the external urethral meatus and with or without peritonitis. Matlab, if it is a case of intraperitoneal bladder rupture, the urine leakage will happen inside the peritoneal cavity, so patient will develop peritonitis. Yaad rakhna, peritonitis is a feature of intraperitoneal bladder rupture, not seen in extraperitoneal. Hopefully clear. Next, investigation of choice in both the condition is a CT cystography beta. ठीक है, मतलब you have to inject a contrast inside the urinary bladder, and once the contrast is filled inside the urinary bladder, then you have to do a CT scan. You will find that the contrast is leaking out from the ruptured part of the bladder, and that confirms your diagnosis. ठीक है, तो CT cystography is the investigation of choice for bladder rupture. But we know that whenever the patient is hemodynamically unstable, I cannot go for a CT cystography. So CT scan cannot be done in hemodynamically unstable patient. So in those patients, again we will fill the bladder with contrast. But this time, rather doing CT, we do a X-ray. ठीक है, हमें वापस contrast भर देना है bladder में और leakage देखना है. But इस बार CT की जगह हम बस X-ray करेंगे. And that is known as cystogram. So if my patient is hemodynamically unstable, then the investigation of choice for bladder rupture will be a cystogram. Clear? Now if they ask you basically what is going to be the treatment, do remember beta, if I talk about treatment in cases of extraperitoneal bladder rupture, just drain the bladder. And to drain the bladder, you can just go for a suprapubic catheterization or a supracath. Matlab, directly insert a catheter inside the patient's urinary bladder and drain the bladder beta. Reason, if you drain the bladder thoroughly, the bladder will get the time to heal, and definitely beta, the bladder rupture which is there, it is going to resolve. If it is a minor one, it will resolve spontaneously beta. So just give the bladder some time to heal, and for that you have to go for a drainage with the help of supracath or a suprapubic catheterization. But if it is an intraperitoneal bladder rupture, we know intraperitoneal bladder rupture mein there is peritonitis, and peritonitis is always an indication of surgery. Peritonitis is always an indication that you have to open the abdomen. That is, you have to do an exploratory laparotomy. Along with laparotomy, clean the peritoneum. That is, go for a peritoneal lavage. And lastly, do a bladder repair. So laparotomy, peritoneal lavage, along with bladder repair. These are going to be done if it is a case of an intraperitoneal bladder rupture. Clear about? Chalo. Next important, if I talk about basically, is nothing else but yaad rakhna, I hope all of you are quite aware. Cystogram, if you see on cystogram beta, if it is a case of an extraperitoneal bladder rupture, on cystogram, if there is a case of extraperitoneal bladder rupture, you classically see the teardrop deformity. Extraperitoneal bladder rupture on cystogram shows us the classical teardrop deformity. But if it is an intraperitoneal bladder rupture, the cystogram classically shows me a sunburst appearance or sunray appearance. If it is a case of intraperitoneal bladder rupture, then the cystogram classically shows us the sunburst appearance or the sunray appearance. Hopefully clear to all of you now. Understood? Chalo. Next important, talking about the urethral rupture. Now, whenever I talk about a case of urethral rupture beta, so we know there are two parts to a male urethra, the anterior urethra and the posterior urethra. Anterior urethra has two parts, the penile urethra and the perineal urethra beta, whereas or the penile urethra and the bulbar urethra, it is one and the same thing. Okay? So penile and the bulbar urethra, these are the two parts of anterior urethra. Posterior urethra has two parts beta. One is the membranous urethra and second is the prostatic urethra. One is the membranous and second is prostatic urethra. So membranous and prostatic, these are the two parts of posterior urethra. Clear? Now if I talk about the anterior urethral rupture, do remember more common in anterior urethral rupture is the rupture of bulbar urethra or the perineal urethra. Has to be remembered. Whereas if I talk about posterior urethral rupture, do remember more common in a posterior urethral rupture is going to be the membranous urethral rupture beta. It is going to be the membranous urethral rupture. That has to be kept in mind. No issues with this. Next important, if I talk about beta, is what are the causes now? So do remember, if I talk about basically a case of nothing else but anterior or a bulbar urethral rupture, do remember the anterior or the bulbar urethral rupture happens due to perineal trauma. Which kind of perineal trauma? Let's say you are walking by the road or you are cycling by the road beta, and you see a beautiful girl, तो क्या हो जाएगा, तुम्हारी नजर हट जाएगी, and then what is going to happen is you may step on the loose manhole cover, वो ढीला ड्रेनेज का ढक्कन, and that loose manhole cover exactly hits between your legs, or the loose manhole cover exactly hits in your perineum beta, and that is known to cause a perineal trauma. Another reason, again the same thing, and you are riding a bicycle this time, but which kind of bicycle? The one which has a rod in it. Okay, again you suddenly apply a brake, and again the rod of the bicycle hits between your legs or hits in the perineum beta, again causing a anterior urethral rupture. So if there is any kind of perineal trauma due to a loose manhole cover or due to bicycle accidents, basically beta, they are actually known to cause a anterior or a bulbar urethral rupture. If I talk about a posterior urethral rupture, it mainly happens due to a pelvic trauma. Okay? Now let's say there was a road traffic accident due to which there was a pelvic fracture, and we know pelvic fracture mein there will be a bladder rupture, and along with bladder rupture the patient will have a posterior urethral injury or the posterior urethral rupture. Clear? We know in these conditions beta, what are the common feature? First of all, both the cases of urethral rupture mein patient will have inability to pass urine. Obviously, if the urethra has been ruptured beta, either there is urine retention or there is a urine leakage which is happening, and that's the reason why the patient has inability to pass urine. Second, due to bleeding, there will be blood at the tip of the external urethral meatus. So at the external urethral opening, you are able to see blood. And third, there will be a hematoma. If it is an anterior urethral, if there is an anterior rupture, there will be a perineal hematoma which will be formed, and if there is a posterior rupture, there is a pelvic hematoma. तो जो ब्लड कलेक्शन होता है एंटीरियर में वो पेरिनियम में होगा और पोस्टीरियर में पेल्विक कैविटी में होगा. क्लियर है बात? दैट इज इंपॉर्टेंट. नाउ another question from anatomy which is important. Do remember urine extravasation or the urine collection in cases of urethral rupture, they happen exactly at which site? Do remember, if it is a case of an anterior urethral rupture, the urine extravasation happens at the level of superficial perineal pouch, at the level of scrotum, at the level of the penis, and at the level of the abdominal wall. So superficial perineal pouch, scrotum, penis, abdominal wall. At all these sites, the urine can collect if it is a case of a anterior urethral rupture or a bulbar urethral rupture. But if it is a case of posterior or a membranous urethral rupture, here the urine collection happens in the deep perineal pouch and the pelvis. So if it is a case of a posterior urethral rupture beta, the urine collects in the deep perineal pouch and pelvis. Now a repeat PYQ from FMGE examination, and that is, patient is having an anterior urethral rupture. The urine extravasation may happen at all of the below given sites except options are superficial perineal pouch, deep perineal pouch, abdominal wall, and scrotum. What is going to be an exception? If it is an anterior urethral rupture, the urine collection will happen at all the below given sites except superficial perineal pouch, deep perineal pouch, abdominal wall, and scrotum. Very good. It is a repeat question from anatomy 2. So do remember, if it is an anterior urethral rupture, the urine collection can happen in the superficial perineal pouch beta, but urine collection will never happen in the deep perineal pouch. Shabash. Yes. So that is what is your answer. Samjhe baat abhi? Next, investigation of choice. Do remember, if it is a case of a urethral rupture, investigation of choice is something called as the RGU, or a retrograde ureterogram. That is, you have to inject a contrast inside the urethra, and when you inject a contrast in the urethra, you will see the contrast leaking out from the ruptured part, and that is known as the retrograde ureterogram. This is the picture. Can you see the contrast leaking out from the ruptured part of the urethra? So that is what is important to be seen over here beta. So this is a classical picture of membranous urethral rupture, which is a previous year image based question also. Clear? So next is treatment. तो याद रखना, treatment in cases of both the urethral rupture is only a SPC or a suprapubic catheterization. Reason, if you insert a supracath beta, the bladder will keep on draining, and if the bladder will keep on draining directly, the urethra gets the time to heal. ठीक है, तो majority cases में spontaneous healing is seen in the urethral rupture. You just have to drain the bladder with the help of SPC or a suprapubic catheterization. समझे यहाँ तक बात? चलो, next important, here there is a neonate who was brought to the emergency room beta with complaints of urinary retention, and a MCU or a micturating cystourethrogram has been given below, and that is going to show you this finding. What is this finding on the micturating cystourethrogram seen? Let me know in the chat box. What is this classical finding on the micturating cystourethrogram? Let me know in the chat box. क्या दिख रहा है यहाँ पे? On this micturating cystourethrogram, the classical finding that is seen, or the classical appearance that is seen, is known as the keyhole appearance beta. बराबर? So here you are able to see the classical keyhole appearance on the MCU or the micturating cystourethrogram. Understood? And we know whenever there is a keyhole appearance on the ultrasound or a MCU, it is a classical case of nothing else but a PUV. What do I mean by PUV? A posterior urethral valve. Matlab, in the posterior urethra or in the prostatic urethra, we are having a valve, and this valve is actually causing blockage, or this valve is actually causing an obstruction in the flow of urine beta. This valve is actually causing blockage, or it is causing obstruction in the flow of urine. That is what is known as the posterior urethral valve. Clear है बात? So you know, let's say for example, this is the bladder, this is the urethra. So in the posterior urethra, we are having a valve beta, and this valve is not allowing the urine to flow out, and that is the reason why the patient is having a severe urine retention. समझे बात? Due to that, there is a urine retention. Now, when a case of posterior urethral valve is brought to us in the emergency beta, okay, what is the first line treatment? Let me know in the chat box. What is the emergency treatment if it is a case of posterior urethral valve? Patient of posterior urethral valve is not able to pass urine, and that's the reason definitely the child has been brought to us with complaints of severe urine retention. So the first step has to drain the bladder properly. The first step has to drain the retained urine beta, barabar. And to drain that urine, we have to insert a Foley's catheter. याद रखना, this valve is a one-way valve. So if you insert a Foley's, the Foley's can easily go inside the bladder beta. Don't worry about that. The emergency management is nothing else but a Foley's catheter to be done. ठीक है? So you have to insert a Foley's catheter, or you have to do a Foley's catheterization to drain the urinary bladder properly, as the patient's main complaint is retention. ठीक है? Once you have done the Foley's catheterization, then you can do an ultrasound, then you can do a micturating cystourethrogram. Do remember, this micturating cystourethrogram is the investigation of choice in a patient of posterior urethral valve. ठीक है? And once you have diagnosed this condition, okay, then you have to go for the treatment. Treatment is whatever valve is present, we have to remove that valve. Barabar. Nowadays I can do that with the help of laser also, right? So we can directly go for nothing else but a TURV. What is TURV? Transurethral resection of valve, or a transurethral fulguration of valve beta. So either you can resect the valve surgically, or you can just fulgurate the valve beta. That is what is important. Clear? बच्चों में beta, it is usually 8 or 10 French that we tend to use. Clear? Depending on the diameter again, depending on the age and everything. ठीक है? So do remember beta, transurethral resection or transurethral fulguration of valve, that has to be done. Understood? Now here there is a question beta which states a patient complains of downward stream of urine. Normally we have a forward stream of urine. Barabar, in male the urethral opening is exactly in the front of penis. So we usually have a forward stream of urine, but some patients may have a downward stream of urine beta. So a patient complains of downward stream of urine and has been diagnosed with hypospadias. Now what is hypospadias? We know at times what happens is the urethral opening which is there, that urethral opening is not exactly in front of penis. that urethral opening is on the ventral surface of penis or on the under surface of penis. The condition wherever the urethral opening is on the ventral or the under surface of penis, that is known as hypospadias. Yeah, dekh sakte ho. Can you see in these conditions? This is the urethral opening. Normally it should have been over here. Okay, normally it should have been over here, but you can see in these conditions the urethral opening is on the under surface of penis, beta. That is what is important. Samjhe? Do remember there are various types of hypospadias, but among all of them, if they ask you, the most common type of hypospadias is known as the granular hypospadias. Matlab, when the urethral opening is just present below the normal opening on the glans penis. If the urethral opening is found on the glans penis itself, we call it as granular hypospadias. But the least common or the most severe one is known as perineal hypospadias. The least common or the most severe one is known as the perineal hypospadias, beta. Here the urethral opening is usually found in the perineal region. That is what is important to be remembered. Clear about? Do remember this. Now if I talk about the treatment. The treatment which is there basically is nothing else but a urethroplasty, beta. Okay, you have to repair the urethra. You have to create a new opening for the urethra. Okay, that surgery is nothing else but called as urethroplasty. Do remember the time for urethroplasty, beta, in cases of hypospadias is around 6 to 12 months of age. But that doesn't mean we cannot do it after this. After this also you can do a urethroplasty, but the best time basically for doing a urethroplasty in a patient of hypospadias is around 6 to 12 months of age. Now, which procedure is contraindicated, beta, if a child is suffering from hypospadias? We know for hypospadias we have to do a urethroplasty, and for that urethroplasty I need a graft, and that graft is going to be your foreskin or the prepuce, beta. That graft is going to be your foreskin or prepuce. So if you remove the prepuce, I have nothing to do a urethroplasty, right? So therefore, beta, the procedure of circumcision is contraindicated if the child is having hypospadias. If the child is suffering from hypospadias, don't go for a circumcision. समझे यहाँ तक? चलो. Next important two conditions that you need to remember, beta. What is this? The first one is nothing else but a patient complains of a curved erection, and when you palpate the penis, you are able to find a fibrous plaque which is palpable inside the penis. Let me know the diagnosis. If a person is having a curved penile erection and on palpation a fibrous plaque is going to be palpated inside the penis. Can you see? The penis is curved and a fibrous plaque is palpated in the penis. Very good. It is a classical case of nothing else but basically sorry, if you are preparing for the upcoming examination, if you have not studied anything, so at least revise this properly and solve MCQs. If you are like appearing for the July examination or after that, please go through the main videos. That is what is my recommendation. Clear? Diagnosis, if I talk about basically, do remember it's nothing else but Peyronie's disease, beta. So Peyronie's disease में क्या होता है? In one of the corpora cavernosa or in one side of the penis, there is nothing else but formation of fibrous plaque, and due to this fibrous plaque the penis gets curved towards that particular side, beta. Clear about? So that is what is important. Okay, now if I talk about Peyronie's disease, do remember in cases of Peyronie's disease the treatment is nothing else but reassurance. Why? Because majority cases of Peyronie's disease are self-resolving, अपने आप ठीक हो जाते हैं. So majority cases of Peyronie's disease are self-resolving. They resolve by a span of around 3 to 5 years. So the mainstay of management in Peyronie's is nothing else but reassurance. But in case, beta, the condition is not resolving. Matlab, you have tried reassurance, but the patient's condition does not improve. The patient's condition did not resolve. Then the best surgical option that we have is known as Nesbitt's operation, beta. The best surgical option that we have is known as Nesbitt's operation. Yaad rakhna. So do remember what we do in Nesbitt's is, we know on one side of the penis we have the fibrous plaque which is pulling the penis. So on the other side of the penis or in the opposite side of the penis we apply a non-absorbable suture. Q. Reason, when the patient gets a penile erection, on one side the plaque is going to pull the penis, on another side, our suture will pull the penis. Ultimately, the penis remains straight. That is known as Nesbit's operation. Injection collagenase can be tried, but it is not the best one. Best one is basically Nesbit's operation, beta. Clear about collagenase is very commonly used nowadays though, but still it is not the best one. Clear? Next important is this picture. Two conditions hai. The first condition that you are able to see, beta, what is seen here, as the opening in the prepuce or as the opening of the skin is very small, beta, you are not able to bring back the prepuce. Okay, as the opening of the prepuce or opening of the skin is very small, you're not able to retract the prepuce, you're not able to bring back the prepuce. What is this condition classically known as? So this condition where we are not able to bring back the prepuce is classically called as phimosis, beta. This condition is classically known as phimosis. Do remember, phimosis can be physiological up to 6 years of age. Barabar, phimosis can be physiological up to 6 years of age. After that, it may start causing problems basically. Do remember, due to phimosis, as you're not able to retract the skin, patient may have difficulty in urination, difficulty in deposition of sperms. Okay, there will be poor hygiene as well. These are the problems. So what should be the treatment in a case of phimosis? Let me know in the chat box. Here the patient is not able to pull back the prepuce, beta. Please tell me, what is the treatment in a case of phimosis then? As the patient is not able to pull back the prepuce, obviously just excise the pubis, beta, and that is nothing else but called as circumcision. Very good. So in all the symptomatic patients of phimosis, you have to go for nothing else but circumcision, beta. That is important. Next important is this condition. यहाँ पे क्या किया तुमने? You have already retracted the prepuce. You have pulled back the prepuce, beta, but now you forgot to bring back the prepuce. And now as we have forgot to bring back the prepuce, there is a lot of edema or a lot of swelling developed. And now it is very difficult to bring back the prepuce, beta. तुमने prepuce को पीछे खींच लिया है, but अभी edema की वजह से तुम वापस उसको ले नहीं जा पा रहे हो. That condition is classically known as, whenever you're not able to take back the retracted prepuce, this condition is classically known as nothing else but paraphimosis. This condition which is there, it is classically known as nothing else but paraphimosis, beta. That has to be remembered. Do remember, paraphimosis mein treatment is nothing else but the patient is going to have severe urine retention because of this edema, because of this constriction ring. The patient is not able to pass urine, and as the patient is not able to pass urine, the first step is always do a Foley's catheterization, beta. Always go for a Foley's catheterization. Reason is, once you insert the Foley's catheter, the patient will be able to drain the urine, beta. Okay? And once you are able to drain the urine, after that you can definitely go for the treatment, and that is what? Apply some lignocaine jelly and try to reduce, beta. Okay? So apply some lignocaine jelly and try to reduce the foreskin. If you are not able to reduce the foreskin, you go for a dorsal slit operation. If you will not be able to reduce the foreskin, beta, manually, then you have to go for a dorsal slit operation. Hopefully clear to all of you now. These are the points to be remembered. Now, a repeated PYQ in the FMGE examination, and that is this one. What is there? A child has been brought to you with complaints of empty scrotal sacs. The right testis was found to be inside the pelvis, beta, and the left testis was found to be inside the inguinal canal. Now please tell me, what is the likely diagnosis? Bolo. Which one is going to be undescended and which one is going to be ectopic in nature? So you are able to see this case where both the scrotal sacs are empty. We know if both the scrotal sacs are empty, either it is a case of an undescended testis or an ectopic testis. Now here they are saying right-sided testis is in the pelvic region and the left-sided testis is in the inguinal canal. So please tell me, the right-sided testis which is found in pelvis is going to be the right-sided, very good. The right-sided testis that is found in the pelvis is going to be ectopic, beta. Whereas the left-sided testis which is in the inguinal canal, that is going to be undescended. The left sided testis which is in the inguinal canal, it is going to be an undescended testis. समझे बात? What is the basic difference? याद रखना that understanding is undescended testis means we know testis develop in the abdominal cavity. Once the development is completed, then they come down into the scrotal sacs beta. How the testis come down? From the abdomen into the inguinal canal. From the inguinal canal down to the scrotum. So if the testis is arrested in this normal path of descent, अगर normal रास्ते में कहीं अटक गया है, that is undescended. ठीक है? So if the testis gets arrested in the normal path of descent, we call it as undescended testis. But if it is somewhere else only, तीसरी जगह कहीं मिल रहा है, that is an ectopic testis. So we know as the left one was found in the inguinal canal, which is a normal path of descent, we say it is undescended. But right is found in the pelvic cavity. Pelvic cavity is not a normal path of descent. So the right one is going to be ectopic in nature. Clear है बात? Now if I talk about basically the undescended testis, also known as cryptorchidism. We know whenever there is a bilaterally undescended testis or both the testes are undescended, then we call it as cryptorchidism, which literally means hidden testis. Crypto means hidden, orchid means testis. याद रखना, undescended testis which is there, if it is unilateral, it is more commonly seen on right side beta. Okay, if there is an undescended testis, more commonly it is seen on the right side because the right sided testis descends down late. Okay, that is the reason why undescended testis, if it is unilateral, it is more commonly seen on right side. Okay, most common cause is idiopathic. Prematurity can be one of the risk factor, but it is not the cause. Majority cases of undescended testis are idiopathic till date beta. Most common cause of undescended testis is we don't know, idiopathic. Most common site where the testis gets arrested is usually the inguinal canal. The commonest site beta for an undescended testis is nothing else but the inguinal canal itself. Okay, the commonest site for an undescended testis is nothing else but the inguinal canal, has to be remembered. Whereas if they ask you what is the investigation of choice, so do remember beta, the investigation of choice in patients of undescended testis is usually an ultrasound. Yes, if the undescended testis is in the inguinal canal, then we can go for an ultrasound beta. Just by an ultrasound, we'll be able to locate or we'll be able to find the testis if it is in the inguinal canal. But if it is somewhere else, then you have to go for a diagnostic laparoscopy beta. If it is in the inguinal canal, only ultrasound will be enough. But if it is somewhere else, basically, then you have to do a laparoscopy. Okay? Now, whenever a child of undescended testis or cryptorchidism is brought to us, I hope all of you are quite aware, if the child is less than 6 months of age, we have to go for what treatment? Let me know in the chat box. If a case of undescended testis is less than 6 months of age, then what is the treatment that you tend to do? If the child is less than 6 months of age, then what is the treatment that we tend to do? Very good. If the child is less than 6 months of age beta, we don't go for any treatment, we just go for reassurance or observation beta. Yes, we don't go for any kind of treatment, we just go for reassurance or observation. Reason, majority cases में the testis will spontaneously descend up to 6 to 9 months. Majority बच्चों में 6 से 9 महीने तक testis अपने आप नीचे आ जाती है. So up to 6 months, never go for any surgery, just go for observation or reassurance as the answer. Clear? But if the child is between 6 to 18 months of life, if the child is 6 to 18 months of age, then we go for surgery. What is that? Find the testis. Once you have found the testis, bring it down and do a fixation. And we know fixation of testis is known as the orchidopexy beta. Wherever fixation of testis is going to be called as nothing else but an orchidopexy. That is important. So done with this. So do remember this point beta. Next, if I talk about now, is nothing else but a case of priapism. If I talk about priapism, what is priapism literally? So priapism is nothing else but a painful, prolonged penile erection which is lasting for more than 4 hours. तो 4 घंटे से ज़्यादा अगर पेशेंट को penile erection रहे, that is known as priapism. So priapism is a painful, prolonged penile erection lasting for a span of more than 4 hours beta. Do remember the most common cause of priapism is again idiopathic. Okay, the leading cause of priapism is again idiopathic. We don't know the exact cause. There are multiple secondary causes though. Okay, most common cause is idiopathic. multiple secondary causes, but the most common secondary cause is trauma. The most common secondary cause is trauma. If the person is having a over enthusiastic sexual intercourse, due to that there can be trauma to the penis, and that is basically the most common secondary cause of priapism. अगर पूछा जाए, let me know the answer of this question from pediatrics also, PYQ है ये. Most common cause of priapism in children. Let me know in the chat box. What is the most common cause of priapism in children? Why there will be a painful prolonged penile erection in children? Anybody? Most common cause of priapism in children if they ask you. Very good. The leading cause of priapism in children is nothing else but sickle cell anemia beta. We know in patients of sickle cell anemia, the sickled RBCs are going to block the penile vessels. And if the sickled RBCs block the penile vessels beta, the blood is not able to drain. And when blood pools up in the penis, the patient will get a painful prolonged penile erection causing priapism. Samjhe baat? That is important to be remembered. Now treatment, we know pooling up of blood in the penis causes priapism. So we have to aspirate all that blood. So treatment in cases of priapism is nothing else but aspiration of blood. So you have to aspirate all the blood from the corpora cavernosa, and once you aspirate all the blood from corpora cavernosa, the patient's priapism or the patient's penile erection gets resolved. And if it is recurrent, you may go for a shunt operation later on. Okay, you may go for a shunt operation later on, but mainstay of management is aspiration of blood. Next important, if I talk about this is the question, and that this is the case, that is nothing else but hydrocele. I hope all of you are quite aware beta, inside the scrotum or inside the scrotal sac, we have a peritoneal sac basically, or we have a processus vaginalis. In that processus vaginalis, if there is collection of fluid, that condition is known as hydrocele beta. Okay, so that is what is important to be remembered. Okay, so no, we can do it in the LA also beta. ठीक है, जनरल की जरूरत नहीं होती, epidural or LA is fine basically for these procedures. Important is hydrocele. If I talk about, so do remember beta, if I talk about a hydrocele in this condition, definitely what you have to keep in mind is, याद रखना, there is collection of fluid in the processus vaginalis beta or inside the scrotal sac, and therefore the patient comes to you with a swelling in the scrotal region or swelling in the inguinoscrotal region. Okay, most common cause if they ask you, तो याद रखना, the most common cause of hydrocele is nothing else but sorry, most common cause of hydrocele is nothing else but idiopathic again. ठीक है, primary hydrocele which is there, it is mainly idiopathic. So most common cause of a primary hydrocele is idiopathic, but most common cause of a secondary hydrocele are infection. Most common cause of secondary hydrocele are infection. Anybody, which infection is the one that leads to a secondary hydrocele in the patient? Which is that infection beta which can lead to a secondary hydrocele in a patient? The most common cause of primary hydrocele is idiopathic. Most common cause of secondary hydrocele are infections beta. And there are various types of hydrocele you might have heard about. One is going to be the vaginal hydrocele, where collection of fluid is only in the scrotum. Second is going to be a case of infantile hydrocele, where there is collection of fluid in the scrotum and the inguinal region. Third is the congenital hydrocele. Congenital hydrocele mein there is a connection with the abdomen or communication with the abdominal cavity. And fourth is the encysted hydrocele. Out of all of them, most common type of hydrocele is the vaginal hydrocele, where the patient has only a scrotal swelling. So yaad rakhna, most common type of hydrocele is the vaginal hydrocele. That has to be kept in mind. Very good. Yes, lymphatic filariasis, especially caused by the Wuchereria bancrofti. That is the reason beta why the patient may develop a secondary hydrocele. The patient will complain of either a scrotal swelling or a inguinoscrotal swelling. Along with this swelling, the patient will also have heaviness in the scrotum as well. Clear? Now, whenever you flash a torchlight in the swelling, we know the whole swelling is going to glow with light beta. And when this whole swelling glows with light, that is classically known as a trans-illumination test. And you can see the swelling is brilliantly trans-illuminant beta. Barabar? So, you have to go for a trans-illumination test, and you'll find that the trans-illumination test in the patient is positive. You will find beta that the trans-illumination test which is there in this case is going to be positive. Okay? We know 4 swellings in the body where trans-illumination is brilliantly positive: ranula, cystic hygroma, meningocele and hydrocele beta. समझे बात? Investigation of choice. As there is collection of fluid only, you can just go for an ultrasound scrotum. And when I go for an ultrasound scrotum, I am able to find the collection of fluid beta that confirms the diagnosis. Now, if they ask you what is the treatment, so yaad rakhna, the treatment in a patient of hydrocele is nothing else but if it is a small hydrocele beta, I can go for a Lord's plication surgery. Similar to that of marsupialization, you can say, you can do a Lord's plication surgery. That is, you will drain the fluid from the scrotum and you will open up the sac beta, not the scrotal sac, the inner sac. You have to open up the sac and plicate the margins. That is known as Lord's plication. But if it is a big vaginal hydrocele or if it is a big hydrocele, then we go for a procedure known as Jabulase surgery or a Jabulase procedure. Jabulase surgery mein I make an incision over the sac, drain the fluid and evert the sac and suture it. पूरा उल्टा करना sac और पीछे suture कर देना. That is known as Jabulase surgery or the Jabulase procedure. Clear है बात? So for a large hydrocele, the best treatment is always a Jabulase surgery or a Jabulase procedure. Now, if it is the case of congenital hydrocele, do remember congenital hydrocele mein we only open up the sac and we drain the fluid. Yes, we do not do anything else. That is known as herniatomy. So if I only open up the sac and drain the fluid, that procedure is basically known as herniatomy beta. That is the treatment in a case of a congenital hydrocele. Hopefully clear. Chalo. Next important if I talk about is this question over here which states we are having a 15-year-old male who presents to you with complaints of severe scrotal and abdominal pain along with fever. The patient is having scrotal or abdominal pain, fever, sometimes even nausea, vomiting. Okay. Now we are lifting the scrotum beta. Okay, as you lift the scrotum, basically either the patient's pain will be relieved or the patient's pain gets worsened beta. अगर patient का pain ठीक हो जाता है, sorry, on lifting, if the patient's pain gets better or if the patient's pain is relieved, then it is a case of epididyma orchitis beta. But on lifting the scrotum, if the pain is not relieved or if the pain worsens beta, then it is a classical diagnosis of which condition? Let me know in the chat box. Then it is a classical diagnosis of nothing else but testicular torsion beta. Right? Very good. So on lifting the scrotum, they are saying that the patient's pain is not relieved beta. So whenever they say on lifting scrotum, pain is not relieved, matlab it is a case of nothing else but testicular torsion. And we know testicular torsion is nothing else but twisting or malrotation of the testis. If the testis undergoes twisting or malrotation, it will not receive enough blood supply. And if it doesn't receive enough blood supply beta, it undergoes ischemic necrosis. So this can be the problem. As the testicular torsion has happened, the testis is not receiving enough blood supply, so it has undergone ischemic necrosis and the testis has become non-viable beta. Clear about? Next is to differentiate between a case of epididyma orchitis or testicular torsion. This test that we perform is classically known as French test. The test that I've told you right now, where you try to lift up the scrotum. So the test where you lift up the scrotum and see whether the patient's pain is relieved or not is known as French test. तो अगर मुझे एपिडिडाइमा ऑर्काइटिस और टॉर्जन के बीच में डिफरेंशिएट करना है तो फ्रेंच टेस्ट यूज करी जाती है. क्लियर है बात? Now, in cases of testicular torsion, ultrasound may be done, but usually torsion is a clinical diagnosis beta. ठीक है? Testicular torsion is usually a clinical diagnosis. Ultrasound is done to support the diagnosis. That's it. So as soon as you know it is a case of testicular torsion, you immediately shift the patient for a surgical exploration beta. And once I start doing a surgical exploration, first of all I'll see whether the testis is viable or non-viable. If the patient presents to me early, matlab the testis will be viable. The testis may not have undergone necrosis yet. If the testis is viable, agar testis viable hai, in this condition I will derotate the testis and I will fix the testis beta. ठीक है? So if the testis is viable, you have to go for derotation and orchidopexy. Okay, if the testis is viable, we have to go for nothing else but derotation and orchidopexy. That has to be done. Hopefully clear to all of you. But if the testis is non-viable beta, non-viable means if the testis has undergone necrosis, as this one. Okay, in this case, as you are able to see, the testis has undergone necrosis. So if the testis is non-viable, तो हमें पता है we have to remove the testis. That is known as orchidectomy. ठीक है, we have to remove the testis, known as orchidectomy. ठीक है, so if the testis is viable, go for an orchidopexy. If the testis is non-viable, go for an orchidectomy. But doesn't matter whether we are doing orchidopexy or an orchidectomy in the affected side. In the opposite side or in the contralateral side also, we have to do a fixation or orchidopexy. ठीक है, तो कोई भी सर्जरी कर रहे हो तुम अफेक्टेड साइड पे, बट जो नॉर्मल साइड है, ऑन द नॉर्मल साइड ऑलवेज गो फॉर अ प्रोफाइलैक्टिक orchidopexy or a prophylactic fixation. Clear? So we know the next topic is nothing else but varicocele, beta. What are varicosities? We all know varicosities means the dilated and tortuous blood vessels. So whenever the blood vessels are dilated and that tortuous, we call it as varicosities. So whenever the testicular vessels or whenever the pampiniform plexus of testicular veins, they will get dilated and they will become tortuous, that condition is known as varicocele, beta. ठीक है, तो प्लीज रिमेंबर varicocele is nothing else but the dilated and tortuous pampiniform plexus of veins. बराबर, तो टेस्टिकुलर वेन्स का जो प्लेक्सस होता है दैट इज नोन एज पैम्पिनिफॉर्म प्लेक्सस. So whenever this pampiniform plexus of the testicular veins, it will get dilated and it will become tortuous. That is classically referred to as nothing else but a varicocele. We know that varicocele is more commonly seen on the left side, beta. Varicocele is more commonly seen on the left side. The basic logic or the basic reason being, beta, yaad rakhna, on the left side, the left testicular vein drains into the left renal vein almost at a right angle, due to which the left testicular vein is not able to drain properly. And as the left testicular vein cannot drain properly, there is pooling up of blood in the left testicular vein, and thereby there is pooling up of blood in the pampiniform plexus also. And that is the reason this pampiniform plexus of veins get dilated and become tortuous. Okay, due to that pooling up of blood. Classically known as nothing else but varicocele, beta. समझे बात? तो do remember varicocele is more common on the left side. As there is pooling up of blood and dilation of these vessels, the patient starts complaining of heaviness in the scrotum. Along with that, patient has a constant vague dragging sensation. मतलब the patient feels as if somebody is pulling down the testis, beta. There is a vague dragging sensation in the scrotum which is felt. And on examination, very classical, when you palpate or when you try to feel the scrotum, beta, all these dilated tortuous vessels will be felt as worms in a bag. Barabar? And that is classically known as which appearance or which feel? Bag of worm feel. This was a PYQ. They said patient comes to you with heaviness and dragging sensation in scrotum. On examination, there is a bag of worm feel. We know the diagnosis is directly a case of nothing else but varicocele. Investigation of choice, let me know in the chat box. Here the problem is in the vessels, peripheral vessels. So we know as the problem is in the vessels or the peripheral vessels, basically the investigation of choice is nothing else but color Doppler. Right? We can go for a duplex scan or a color Doppler, beta. So color Doppler or duplex scan is considered as the investigation of choice in a patient of varicocele, beta. Right? Yes, it is a color Doppler or duplex which is the investigation of choice. Shabash. Now treatment. If the patient is in the early stages, go for angioembolization. Yes, embolize the vessels which are pooling up the blood. The angioembolization can be done. But if it is in the if angioembolization doesn't help, another option is surgical ligation. Okay, another option is surgical ligation or even sclerotherapy can be tried. But if they ask you what is the best treatment, so yaad rakhna, the best treatment for a case of varicocele is nothing else but varicocelectomy, beta. Okay, excision or removal. The best treatment option that we have basically for a varicocele is nothing else but excision or a varicocelectomy. Hopefully clear to all of you now. So do remember these are the points that you need to keep in mind. Samjhe? Now, these are the points, beta. Two conditions. First one, here we are having a 40-year-old male, beta, who complains of painless swelling of the right testis, and he is also experiencing a dragging sensation in the testis. the right testis was enlarged or it has increased in size, and you are able to palpate a hard mass of almost size 4 by 4 centimeter, and the para-aortic areas are absolutely normal. Matlab, there is no metastasis to the para-aortic lymph node. Serum LDH and the AFP levels were elevated beta. Barabar? So serum LDH and AFP, both of them are tumor markers. Their levels are elevated. What is the next best step in this condition? तो इतना तो clear है that we are having a middle-aged or an elderly male coming to us with complaints of painless swelling of the testis. Okay, the testis has been enlarged in size, so we know it is a case of testicular tumor more likely. Why do I say so? Reason, if you check the levels of the tumor markers, they are elevated. So we are thinking about testicular tumor. Now if I talk about testicular tumor, do remember the most common testicular tumors. If I talk about most common testicular tumor in children is a yolk sac tumor beta. Most common testicular tumor in children is a yolk sac tumor. Do remember the tumor marker in a yolk sac tumor is going to be nothing else but AFP or alpha fetoprotein. For all the germ cell tumors like yolk sac tumor or a teratoma, the tumor marker is AFP or alpha fetoprotein. Whereas if I see the histopath, on that histopathological examination, you are able to see the classical Schiller-Dovell bodies. On the histopath, you are able to see the classical Schiller-Dovell bodies, beta, that has to be remembered. Anybody, which is that germ cell tumor which has derivatives of all the three germ layers: mesoderm, endoderm, ectoderm, subca, teeth, bone, hair, mucosa, everything is there. Recent question in the exam. Let me know which is that testicular tumor or which is that germ cell tumor where there are derivatives of all the three germ cells. That is known as a teratoma, also known as a dermoid cyst. Yes, it is known as a teratoma, also known as a dermoid cyst beta. Do remember this. Next, if they ask you what is the most common testicular tumor in adults, the most common testicular tumor in adults is seminoma followed by teratoma. The commonest testicular tumor in adults is seminoma followed by teratoma. The overall most common testicular tumor is a seminoma beta. Clear? Next, most common testicular tumor in elderly patient is a lymphoma. Most common testicular tumor in elderly patient is a lymphoma. And if they ask you most common bilateral testicular tumor, answer is again a lymphoma. Most common bilateral testicular tumor, answer is again a lymphoma itself. Clear about? Now, if they ask you in this condition, please tell me what shall be the next best step. Choose something. Very good. So do you know beta that two things has to be remembered. Here we have done here definitely we have done an examination. Ultrasound would have been done and tumor markers are checked. If ultrasound and tumor markers are saying that it is a case of testicular tumor, you know it is a confirmed case of testicular tumor. Reason, a transscrotal FNSE or a transscrotal biopsy are absolutely contraindicated in patients of testicular tumor. FNSE or biopsy are absolutely contraindicated if a patient is suffering from testicular tumor beta. That is important. Samjhe baat? Orchidopexy, it is not a case of testicular torsion that we are doing orchidopexy. So therefore the next step has to be directly the treatment, and the treatment in a case of testicular tumor is a high inguinal orchidectomy. Yes, even for treatment, I do not make an incision on the scrotal sac. We make an incision high up in the inguinal region and we pull out the testicular tumor. Clear about high inguinal orchidectomy to be done. Do remember one point basically, and that is about seminoma. We know seminoma is the most common testicular tumor beta. Okay? Seminoma is AFP negative. Yes, yaad rakhna, very very important. I've seen a lot of people, if I ask tumor marker for seminoma, everybody is like AFP. No, alpha fetoprotein is negative in a case of seminoma. That has to be remembered. The tumor marker in a patient of seminoma beta, it could be LDH, that is lactate dehydrogenase, or it could be HCG beta, but it is never alpha fetoprotein. That is important. Next, if you see gross appearance of the seminoma, it basically looks like the cut potato. So when you cut a potato and look from inside, it appears ekdam homogeneous, right? It appears homogeneous, pinkish. Okay? So cut potato appearance is going to be seen beta on the gross appearance of seminoma. And histopathological examination if you do, so histopath pe you are able to see large cells with prominent nucleus, so large polygonal cells with prominent nucleus and a lot of lymphocytes beta. So in cases of seminoma, you are having a lot of fibrous septae and inside those fibrous septae you are having a lot of lymphocytes. So there are fibrous septae with lymphocytic infiltration. So in between the cells you will find a lot of fibrous septae, and in those fibrous septae there is a lot of lymphocytes or a lot of lymphocytic infiltration. This is the histopath which has been asked. Clear about? Hopefully clear. Next important, if I talk about basically risk of spread, basically beta. Yes, PLAP is also the tumor marker that you can use for a case of seminoma. That is nothing else but placental alkaline phosphatase. Okay? Do you remember, due to the risk of spread to the skin, the biopsy is usually absolutely contraindicated beta. Next is this one over here. What is this? The question states we are having an elderly male who presents to us with complaint of poor urinary stream along with urine retention and a urinary tract infection beta. Please let me know what is the classical diagnosis of this case. If a patient is an elderly male, usually more than 50 years of age, with a poor urinary stream, urine retention and UTI, one of the commonest diagnoses that should come to your mind is nothing else but BPH or a benign prostatic hyperplasia. We know beta, whenever the prostate gland undergoes a hyperplasia, it is going to compress the prostatic urethra. And if it is going to compress the prostatic urethra, तो क्या हो जाएगा? Obviously, the patient will not be able to pass urine. Let's say this is the hypertrophied prostate gland. It is compressing the prostatic urethra beta, and due to that, the patient is having difficulty in passage of urine. समझे बात? So it is a case of BPH or a benign prostatic hyperplasia. If they ask you which is the most common site, so do remember the most common site in a patient of BPH is nothing else but transitional zone. We know that BPH is more common in the transitional zone of prostate, but prostate cancer is more common in the peripheral zone of prostate. याद रखना, BPH more common in transitional zone, whereas cancer more common in the peripheral zone. Has to be remembered. If they ask you what is the investigation of choice, I hope all of you are quite aware. Investigation of choice is nothing else but an ultrasound, KUBP. When I do an ultrasound, KUBP or a kidney, ureter, bladder, prostate, on that I will find, yes, the size of the prostate has enlarged. Matlab, the volume of prostate is more than 30 cc and the post-void residue is more than 100 cc. Matlab, even after urination, more than 100 cc of urine is left in the bladder. Urine करने के बावजूद 100 cc की urine बच जाती है. So that is important. Along with that, I will also check for the serum PSA levels, that is serum prostate specific antigen, which is a tumor marker for prostate cancer. Reason, enlargement of prostate gland can also be seen in cancer. Then how to differentiate? For that we need a serum PSA beta. Serum PSA will be normal or very mildly elevated in a case of BPH. But serum PSA is very grossly elevated or very high in a patient of prostate cancer. That is how you differentiate. समझे बात? Drug of choice. We know initially medical management is done in patients of BPH. Drug of choice in cases of BPH is nothing else but the alpha 1A blockers. And these selective alpha 1A blockers are usually drugs like tamsulosin or silodosin beta. Barabar, you have to go for the selective alpha 1A blockers, the drugs like tamsulosin and silodosin. This has to be considered as the drug of choice in a patient of BPH. But if the patient is having BPH plus hypertension, then what is the drug of choice? Let me know in the chat box. Agar kisi patient mein there is a BPH plus hypertension, then what is going to be the drug of choice? Very good. If there is a BPH plus hypertension, we have to give alpha 1 blocker, not alpha 1A, only alpha 1 blockers. And these alpha 1 blockers are drugs like Zosins, Prazosin, Terazosin, Alfuzosin. Okay? So normotensive individuals may give tamsulosin, hypertensive individuals may give Prazosin. And along with that, to decrease the size of prostate beta, I have to give 5 alpha reductase inhibitors, drugs like finasteride. To decrease the size of prostate, I have to give 5 alpha reductase inhibitors, drugs like finasteride. Clear about? Now, in case if you have tried the medical management beta, but even after medical management, the patient's condition does not improve, the patient does not respond. In those cases, you have to go for TERP. What is TERP? transurethral resection of prostate. Matlab, you have to go inside the urethra and you have to resect or you have to excise the enlarged prostate beta. Transurethral resection of prostate. But nowadays, rather than doing a surgical excision, we also have a laser surgery available like HOLEP. Holmium laser enucleation of prostate. We can go for HOLEP, that is a holmium laser enucleation of prostate. Now, let's say there's a patient beta who is a 72-year-old male. He was diagnosed with BPH or benign prostatic hyperplasia. This patient has underwent a TURP surgery or he has underwent a transurethral resection of prostate under spinal anesthesia. After 1 hour of surgery beta, my patient starts developing nausea, vomiting, altered sensorium. What is the likely complication known as? Please tell me, with after 1 hour of TURP surgery, if your patient starts developing nausea, vomiting, altered sensorium, then definitely, yes, it is the classical complication known as the water intoxication syndrome, also called as the TURP syndrome beta, right? What happened? For irrigation during the TURP surgery beta, for irrigation during TURP surgery, you used hypotonic fluids. You used hypotonic fluids like distilled water or half normal saline or 5% dextrose. And as you used the hypotonic fluid, a lot of this fluid or a lot of this water got absorbed in the blood. And when a lot of water got absorbed in the blood got diluted beta. And due to the dilution, the patient developed a dilutional hyponatremia. Due to this, the patient developed a dilutional or a relative hyponatremia. That is the reason patient develops symptoms like nausea, vomiting, confusion, altered sensorium, and if severe, even seizures. Clear? So, ये dilutional hyponatremia क्यों हुआ? Because water got absorbed in the blood. How? Because we have used beta hypotonic fluids for irrigation, something like 5% dextrose, half normal saline, distilled water. That's the reason. Hopefully clear. Treatment kya? If the patient has developed a water intoxication syndrome or a TURP syndrome, first is don't give any more fluids, do a fluid restriction beta. Do not give more fluids to the patient. Okay? And second, if there is a severe hyponatremia or if the sodium levels are very low, then give IV 3% hypertonic saline. In that condition, give IV 3% hypertonic saline. Prevention. What should have been done? Instead of using hypotonic fluids for irrigation during the surgery, we should have used isotonic fluids for irrigation during the surgery. And the best fluid to be used beta for irrigation during the TURP surgery is isotonic glycine. Barabar? So please remember, instead of using hypotonic fluids for irrigation during the surgery, you should always use isotonic fluids for irrigation during this TURP surgery known as isotonic glycine. So the problem of TURP syndrome will not happen. And last part basically is known as hernia. Now, if I talk about the literal definition of hernia, it is nothing else but protrusion of a viscus or a part of viscus through the wall which contains it. Matlab, basically beta, if I say the abdominal organs are present or the bowel is present inside the abdominal wall. So when the bowel tries to come out of that abdominal wall, that condition is known as hernia beta. तो अगर अंदर वाले organs अपने wall से बाहर आने की कोशिश करते हैं, that is hernia in simple terms. We know that patient may have groin hernias. Groin hernias can be of two type beta. If the patient is having any hernia from the inguinal region, we call it as inguinal hernia, the direct and the indirect inguinal hernia. Whereas any hernia from the inner thigh is known as femoral hernia. Whereas there are hernias even from the abdominal wall or the ventral hernias. Like patient may have an epigastric hernia, patient may have a Spigelian hernia from the lateral border of rectus abdominis, patient may have incisional hernia from a previous incision or a previous scar, patient may have a flank or a lumbar hernia, patient may have an umbilical or a paraumbilical hernia. These are the various types of hernias which arise from the abdominal wall beta. Samjhe baat? Out of all of them, I hope all of you are quite aware, the most common type of hernia overall is nothing else but the indirect inguinal hernia. The commonest type of hernia overall is nothing else but the indirect inguinal hernia has to be kept in mind. Next important, if they ask you beta that which is the most common type of hernia in elderly patient. So if they ask you most common type of hernia in elderly patient, as in elderly patient the wall becomes weak, so elderly patients will have a direct inguinal hernia. The most common type of hernia in elderly patient is a direct inguinal hernia. Let me know which is the most common type of hernia in females. Which is the most common type of hernia in females? Let me know in the chat box. The most common type of hernia in elderly patients is nothing else but a direct inguinal hernia, has to be kept in mind. Most common type of hernia in females, if they ask you, bolo, let me know in the chat box. Commonest type of hernia in females. Yes, it is nothing else but indirect inguinal hernia. The commonest type of hernia in females is nothing else but indirect inguinal hernia, beta, that has to be remembered. The commonest type of hernia in females is indirect inguinal hernia. Do remember, femoral hernia is 4 times more common in female. Matlab, if you compare males and females, so femoral hernia is more common in females, but it is not the most common. Most common overall in females is also a indirect inguinal hernia itself. That has to be kept in mind. Samjhe baat? Do remember this. Now, if I talk about basically, beta, let's say if it is a case of inguinal hernia, we know this is the ASIS, that is anterior superior iliac spine. This is your pubic tubercle. This is my inguinal ligament. Above that, we have the deep inguinal ring. Let's say this is your inguinal canal, and this is your superficial inguinal ring. I hope all of you are quite aware this has been an anatomy question. Deep inguinal ring is the opening in fascia transversalis, beta. Deep inguinal ring is going to be an opening present in the fascia transversalis. Whereas superficial inguinal ring is an opening in external oblique aponeurosis. Superficial inguinal ring is an opening present in external oblique aponeurosis. Barabar hai baat? Chalo. So this is your deep inguinal ring, this is your superficial inguinal ring. And in between them, we have the inguinal canal. Above and behind the inguinal canal, we have the Hasselbalch triangle. Above and behind the inguinal canal, we have the Hasselbalch triangle, beta. Do remember this. Ye jo dikh raha hai yahan pe, this is nothing else but your Hasselbalch triangle. Clear? Now do remember, any herniation which happens from the deep inguinal ring, any hernia sac which enters from the deep inguinal ring is classically known as my indirect inguinal hernia. Any hernia sac that enters from my deep inguinal ring is known as my indirect inguinal hernia. And any herniation that happens from the Hasselbalch triangle is known as my direct inguinal hernia. Any herniation that happens from the Hasselbalch triangle, that is known as my direct inguinal hernia, beta. That is what is the basic idea. Hopefully clear. So indirect inguinal hernia enters from deep ring, passes via the inguinal canal, and then comes out via the superficial ring at times. But direct inguinal hernia comes out directly from the Hasselbalch triangle or comes out directly from the abdominal wall. And here, to differentiate between both of them, we have the inferior epigastric vessel. Yaad rakhna, the hernia that is lateral to the inferior epigastric vessel is known as my indirect inguinal hernia, and the hernia that is medial to the inferior epigastric vessel is known as my direct inguinal hernia. So the hernia that is lateral to the inferior epigastric vessel is known as my indirect inguinal hernia. The hernia that is medial to the inferior epigastric vessel is known as my direct inguinal hernia. Hopefully clear to all of you now. So that is important. No issues with this. We know, beta, whenever a patient is having hernia, okay, whenever the patient is having any kind of hernia, beta, always remember the risk factors that are necessary or the risk factors which are important in cases of hernia can be a chronic cough, it can be a chronic constipation, okay, it can be pregnancy at times, or it can be a previous incision. Reason is, beta, do remember, in all these conditions we know, if there is a chronic cough, chronic constipation, the intra-abdominal pressure is high. And as the intra-abdominal pressure is high, there is a high risk of herniation. Second important, pregnancy and incision. In pregnancy also the intra-abdominal pressure is high. Incisions which are there. Do remember, incisions ki wajah se the strength of abdominal wall decreases. And therefore the risk of herniation will be more. The commonest presentation in a patient of hernia. The most common clinical presentation in a case of hernia is a painless swelling, beta. Less commonly it is painful, more commonly it is painless. Okay? So most important or the most common presentation in a patient of hernia is nothing else but a painless swelling. So patient comes to you with a complaint of a painless swelling basically, beta. Okay? Patient comes to you with a complaint of painless swelling, and this swelling which is there, it usually increases whenever the patient stands. This swelling usually increases whenever the patient stands, whenever the patient coughs, or whenever the patient strains. So on coughing, straining, or straining, the swelling is actually going to increase in size, beta. That is important. Whenever the patient of hernia comes to us with a complaint of swelling, we have to do an examination. On examination, I will check two things. Okay, on examination, we have to check two things. One is when the patient is standing, I will keep the fingers over swelling and I will ask my patient to cough. Matlab, I want to check the cough impulse beta. Reason, if cough impulse is present, it is a non-obstructed hernia. But if cough impulse is absent, then it is an obstructed hernia. Matlab, the neck of that hernia sac is very narrow beta. Agar cough impulse nahi hai, so please remember basically, neck of the hernia sac is going to be narrow. Okay, it is going to be starting from 16th beta, 16 to 20th, it is going to start. Okay, Delhi and online. If I talk about basically in standing position beta, please remember there will be a cough impulse, and in supine position definitely we have to check the reducibility of the hernia. In supine position bache, we have to check the reducibility of the hernia. That is what is important to be remembered. Clear about? So these are the points that you need to keep in mind. So standing position mein check cough impulse, and supine position mein check the reducibility of the hernia beta has to be remembered. Yes, Jaipur would be starting from 26 to 29th will be Jaipur. Okay? I'll update it on my Insta and the Telegram channel. You can get the information from there also. Clear? Chalo. So these are definitely the important hints that you have to remember basically whenever a patient of hernia comes to you, bache. Clear? Do remember hernia is a purely clinical diagnosis, beta. Yaad rakhna, hernia is a purely clinical diagnosis basically. You don't need investigations in majority cases of hernia. You don't need investigations in majority cases of hernia, beta. Okay, that is what is important. Clear? Now, yaad rakhna, here there is a case basically which says a patient presents to you with complaints of umbilical hernia, beta. A patient complains of umbilical hernia. Okay, and if the patient is having an umbilical hernia like this, you can see the umbilicus gets everted, beta. Okay, the umbilicus usually gets everted. Now, here the treatment completely depends on the defect size. Okay, the treatment of umbilical hernia or abdominal wall hernia completely depends on the defect size basically. If it is a small hernia beta, if it is going to be a small hernia, then please make sure that you should go for nothing else. Sorry, you should go for nothing else but a herniorrhaphy. And the herniorrhaphy that we do in a case of abdominal wall hernia is known as Mayo's repair. Agar small defect hai, around 1 to 2 centimeters ka defect, then go for a herniorrhaphy that is classically known as Mayo's repair. What is herniorrhaphy, bache? So do remember beta, herniorrhaphy matlab I have to close the defect with the help of suturing. Okay, herniorrhaphy means I have to close the defect with the help of suturing beta. That is what is important to be remembered. Clear? Next important if I talk about is if there is a large defect in the hernia, if there is a large defect in the hernia, do remember large defect in hernia which is there, it has to be nothing else but sorry, large defect of the hernia is closed by hernioplasty. Hernioplasty matlab whenever I close the defect with the help of mesh beta. Okay, large defect of the hernias have to be closed by a mesh basically. That is nothing else but a hernioplasty. So hernioplasty is nothing else but whenever you close the hernia defect with the help of a mesh. So that mesh repair that we do is classically known as hernioplasty. So large defects of the hernia have to be closed with the help of a mesh beta, that is known as a hernioplasty. Do remember that in case if you are doing a repair of the hernia beta and during the repair if there is any kind of infections, then avoid which kind of mesh. If you are doing a hernioplasty surgery beta, okay, or the mesh repair basically, so please tell me if it is a case of an infection, then which mesh has to be avoided. If it is a case of an infection beta, then please remember you have to avoid using a synthetic mesh beta. You have to avoid using a synthetic mesh. That has to be kept in mind. Clear about? So avoid a synthetic mesh. You can use the biological mesh beta like alloderm and all, but never use a synthetic mesh in cases of infection because that will rather worsen or that will rather increase the inflammation beta. Isidya. Clear about? Next important if I talk about is, do remember near the inguinal region we are going to have a triangle of pain and a triangle of doom. Triangle of pain contains a lot of nerves and The triangle of doom contains the iliac vessels. Now, never use a cautery near the triangle of pain. If you use a cautery near the triangle of pain, the current may damage the nerves beta. And if the current is going to damage the nerves, the patient will have a severe post-op pain. Okay, if you use a cautery in the triangle of pain, that current will damage the nerves, causing a severe post-operative pain beta. Clear? If I talk about basically triangle of doom, so please remember, near the triangle of doom, avoid any kind of sharp dissection. Avoid a very sharp dissection near the triangle of doom, because by mistake during that sharp dissection, if you injure the blood vessel, the patient will have massive blood loss, and due to that massive blood loss, the patient will land up into shock and the patient may die. Clear about? Lastly, if I talk about beta, it is, we have discussed the basic differences between the direct and the indirect inguinal hernia. Indirect inguinal hernia is any hernia which enters via the deep inguinal ring. Direct inguinal hernia is any hernia which enters via the Hasselbalch triangle. Do remember, the indirect inguinal hernia will be downwards, inwards and forwards. But direct inguinal hernia only comes out forwards. Beta. Direct inguinal hernia only comes forwards. Direction, if they ask you basically beta, do remember that the indirect inguinal hernia which is there, it is usually seen in young patients beta. Indirect inguinal hernia is usually seen in young patients, and direct inguinal hernia is more commonly seen in elderly patients. That has to be remembered. Clear? Relation with the inferior epigastric vessel, as I've already told you, the relation with inferior epigastric vessel. In indirect inguinal hernia is lateral to these inferior epigastric vessel beta. Indirect inguinal hernia is lateral to the inferior epigastric vessel, and the direct inguinal hernia is medial to the inferior epigastric vessel. Direct inguinal hernia is going to be medial to the inferior epigastric vessels basically beta. Clear about? Do remember, indirect inguinal hernia, in this condition, the scrotal extension is going to be more common. In indirect inguinal hernia, the scrotal extension is actually going to be more common beta, whereas in direct inguinal hernia, scrotal extension is less common. Do remember, for inguinal hernias, the surgeries that we do, we can do a open surgery for a inguinal hernia. Okay? Please remember, I have told you already. See, there are three types of surgery. First is, if I just push back the hernial sac. Let's say this is the hernia defect, which is very small. Okay, and if you have just pushed back the hernia sac and you have not closed the opening, or you have not closed the defect, this surgery is known as herniotomy beta. Next, if the defect is moderate, small to moderate in size, if the defect is small to moderate in size, you push back the hernial sac. But after pushing back the hernial sac, you pull both the layers together, and after pulling both the layers together beta, you try to suture them together. So whenever you close the defect beta by suturing the layers, whenever you close the defect by suturing the layers, this kind of surgery is known as herniorrhaphy surgery. And whenever the defect is extremely large in size, whenever the defect is large in size, here I cannot pull the layers together. If I cannot pull the layers together, I am going to place a mesh over the defect beta, and we are going to close the defect with the help of mesh. And when I close the defect with the help of mesh, it is known as hernioplasty surgery. Clear about? So do remember, I have told you, for abdominal wall hernias or umbilical hernias के लिए small defect है तो we go for a herniorrhaphy surgery called as Menetrier Repair, and large defect है तो we go for a hernioplasty surgery like IPOM, intraperitoneal placement of mesh. Clear? Whereas if I talk about basically beta the inguinal hernia surgeries, तो inguinal hernia surgeries में the herniorrhaphy that we do for inguinal hernia surgeries, the herniorrhaphies that we do beta can be called as the Bassini's repair, the Shouldice repair, or the modified Shouldice repair beta. Right? You might have heard these names. So the herniorrhaphy that we do for a case of inguinal hernia is known as the Bassini's repair, Shouldice repair, or modified Shouldice repair. But the best surgery is obviously the hernioplasty surgery, where we close the defect with help of mesh beta. And the hernioplasty surgery that we do, okay, and we close the defect with the help of mesh, is nothing else but called as the a hernioplasty surgery. And that hernioplasty surgery is known as Lichtenstein's repair. याद रखना, Lichtenstein's repair is a tension-free repair beta, because it is a hernioplasty where I close the defect with the help of mesh. So there is no tension at the level of surgical site. So there is less risk of recurrence. In Bassini's and Shouldice, as it is a herniorrhaphy, there is more tension at the suture site, so sutures can break and there will be a risk of recurrence. But Lichtenstein's repair is a hernioplasty where I close the defect with the help of mesh, so there is no tension at the suture site and there is a less risk of recurrence. Most common nerve injured during an open inguinal hernia surgery. Answer is ilioinguinal nerve. A common repeated question in FMGE exam and NEET PG exam. Most common nerve injured in an open inguinal hernia surgery is nothing else but beta, the ilioinguinal nerve. If I talk about a laparoscopic surgery, so laparoscopic surgery which is there basically, it is nothing else but the TAP repair or the TEP repair beta. TAP is nothing else but a trans-abdominal pre-peritoneal repair and TEP is nothing else but a total extraperitoneal repair. TAP is trans-abdominal pre-peritoneal repair and TEP is total extraperitoneal repair. Okay? In laparoscopic inguinal hernia surgery, the most common nerve injured is the lateral cutaneous nerve of thigh. Let me know in the chat box if lateral cutaneous nerve of thigh is injured, patient develops which problem basically after the surgery. So in cases of laparoscopic inguinal hernia surgery, the most common nerve injured is the lateral cutaneous nerve of thigh, and due to that, patient has loss of sensations in the upper lateral part of thigh called as meralgia paresthetica or meralgia paresthesia beta. Patient develops a meralgia paresthetica, that has to be remembered. Clear about? Whereas lastly, if there is a congenital inguinal hernia, in cases of congenital inguinal hernia beta, do remember the patient is actually going to develop herniotomy. In a case of congenital inguinal hernia, the patient is actually going to develop a herniotomy. Herniotomy matlab I have already told you, you have to push back the content, you have to push back the sac, but you are not going to close the defect beta. You are not going to close the defect basically, that has to be remembered. Clear about? The mesh can be placed at various sites. If you place it above the sheath, that is onlay repair. At the level of sheath, inlay repair. Below the sheath, sublay repair. Below the muscle, retromuscular repair. Above the peritoneum, pre-peritoneal repair. Below the peritoneum, intraperitoneal repair. Multiple types of repairs can be done. And do remember, if there is a problem like gastroschisis or a case of omphalocele, हमें पता है that gastroschisis is the paraumbilical defect and omphalocele is the umbilical defect beta. ठीक है? Peritoneal sac is absent in gastroschisis, present in omphalocele. In this conditions, the treatment is nothing else but you have to do a gradual reduction of the contents. Slowly you have to send the contents inside beta using a silo. You are going to create a silo. So gradual reduction by creating a silo has to be done. So gradual reduction by creating a silo is done in a case. For example, this is the umbilicus or this is the defect. These are all your organs. You are just going to take them inside a container or inside a bag beta and you are going to create a silo. And now the organs which are there basically due to gravity will slowly start reducing inside or slowly start going inside beta. That is what is classically known as silo. In the recent FMG examination was a question. Clear about? Chalo. So that is what is all about surgery. So these are the contacts. You can reach out to me. You will get the answers for your questions, not only regarding the academics, but even for your strategy, your plans, basically the Instagram handle, Telegram handle, and the YouTube handle. So reach out to me at any of this. Clear? So you'll get the updates about any sessions, any classes that I'll be undertaking. Okay, all the PDFs, whatever you want to find, you can find in the Telegram group itself. Okay. And okay, so be connected. Whatever doubts you have, please reach out to me, bache. Okay. Take care and all the very best for the examination. I know all of you are going to come out with flying colors. Just be persistent for this last lap now. Do not lose the hope in between. Okay. Be at it. And we know definitely will be able to crack the examination. Do not think how the exam is going to be, what the result is going to be. You have prepared well and you are going to pass the examination. That confidence if you have, exam seems easy beta. Clear? It will cover majority of the topics bache. Clear hai? So don't worry about it. Okay? Chalo. Take care and goodbye. All the best for the exams.